through your window we can see really beautiful scenery outside.
Oh, okay. I can shift it a bit. You can see a bit more. Here you are.
Yes,
Thank you.
Devinder, good morning. Chief.
A very good morning, sir.
Thank you for joining.
Of course, sir.
Welcome.
Madam again. Okay.
Good morning, Amitabh sir.
Hi, how are you?
Sir, it's a humble request to all. It's a technical the suggestion. It's a humble request to all. When you're not going to speak, just mute yourself. Otherwise, it will some behind the noise, or when you're talking on the mobile, that audio will come to all. So whenever you're not going to talk, just mute yourself.
What is the link, Dinesh, for other people to join, not for the panelists?
Yes, www.entconclave.com, sir. I will WhatsApp you, sir.
Just WhatsApp it to me.
Yeah.
Good morning, sir. Narayan here. And good morning, everyone.
Hi, Narayan. Good morning, dear.
Sir, it's 9 o'clock. Can we go live?
Kirtane sir, should we start, sir?
Yeah, sure.
One second, sir. When I tell you are live, then you can start.
Right. Dr. Akhilesh, so you're there?
Yeah, I'm there, Anthony.
Right, sir. So once Dinesh gives the go ahead, we'll start from the address.
Hi.
Hi, good to see you.
All the very best. I'm sure you'll rock.
Thank you. So all my gurus are here today.
Sir, you all are alive. You can start, sir.
Okay. Welcome all to this 10th ENT Conclave 2020. As we know, a promise of a new dawn lies in our coming together and being together and working together. Perhaps our greatest strength into the future.
Everybody mute their mics, please.
Sir, you all are alive. You can start.
Welcome all to this 10th ENT Conclave 2020. As we know, a promise of a new dawn lies in our coming together and being together and working together. Our greatest strength.
Everybody mute their mics, please.
Sir, you all are alive.
Dinesh, there is some lag.
है ना और कोई वो मत लगाना एड्रेनलिन कुछ नहीं
Okay, someone has also opened the webcast link also. Okay, the webcast link.
कितने सर
So, good morning, doctors. On behalf of Alchem, we welcome you to the 10th ENT Conclave 2020. We thank you for joining hands with us in this mission. And as you know that over the course of the day, we shall have various luminaries who would take us through the most enriched wealth of the scientific cases, the knowledge which will come from them will enlighten us in the field of otorhinolaryngology. And there are significant plethora of insights to dwell on, to discuss, to debate, and finally arrive at conclusions which we hope will act as catalyst in achieving our shared vision. ENT Conclave has been conceived and coordinated by none other than Professor Dr. Milind Kirtane, who is also a scientific program coordinator and is by an unrestricted educational grant from Alchem Laboratories Limited, whom, as you know, have been the makers of some of the most important and supportive drugs contributed from the brands like Clavum, Pan, and Pandi. Professor Dr. Milind Kirtane, our scientific program coordinator, is a consultant ENT surgeon at Breach Hospital, PD, Hinduja Hospital. Though he needs no real introduction, but it's my pleasure and honor to give a few honorable words in for Professor Dr. Kirtane. He is a revered teacher, as you all know, and a man blessed with both healing hands and a caring heart. For his outstanding accomplishment and contribution in the field of medicine, Dr. Kirtane has been conferred with the Padma Shri Award by the President of India. We are especially delighted to present various cases and a path-breaking 10th ENT conclave which will bring out these cases that will begin with live surgery by eminent surgeon of India, Dr. Satish Jain, and coupled with various experts' comments coming from the faculties like Dr. H. Vijendra, Dr. Renuka Pradu, Dr. Devinder Rai, Dr. Nupur Nerurkar, Dr. Amitabh Roy, Chaudhary, Dr. Madhuri Mehta, Dr. Narayan Jaishankar, Dr. Devinder Chaukar, and will be moderated by Dr. Paromita Saha. It is just one more way which we strive to make our experience at this conclave even more richly rewarding than ever before. We do all hope that you will have a memorable conclave. Let us welcome our scientific coordinator to ENT conclave, Dr. Milind Kirtane. Over to you, Dr. Kirtane.
Yeah, very good morning to all of you. Am I audible? Can you hear me?
Yes, sir.
Okay. First of all, a very good morning to you and warm welcome to this ENT conclave. Information, operative surgery panel discussions. This time with the pandemic, we said we shouldn't put a stop to the educational aspect of it, although the social part of meeting in the evening and interacting with your fellow colleagues is going to be put off till next year. So I would like to really begin by thanking Alchem for their continued support through their unrestricted grant for education. And they've really been forthcoming without any kind of pressure on us regarding the choice of subjects, etc. They said, we just wanted to have scientific value, and we thank Alchem for that. Would also like to thank Satish Jain as a legend, absolute legend, and you've been watching him, more than 10 to 12,000 people in the world watching him at one time. So it was very nice of him to consent to be a part of this program and demonstrate surgery. The request to him was to show some surgeries which are performed routinely by people so that they take back home to their practice something that they can add to give better treatment to the patients, and some cases which are at the cutting edge of technology or complicated cases. So he's going to do both. Would like to thank Paromita. She's been sort of comparing his programs, and she kindly agreed to do the same for us for Alchem. Would like to thank the panelists who are here, experts, all of them absolutely top class leaders in their field. We have Dr. Nupur Nerurkar, laryngologist, Dr. Renuka Bradu, who is a professor and head of department at the Sion Hospital, Dr. Jai Shankar, who is an all-round ENT surgeon with special interest in skull-based surgery. We have Amitabh Roy Chaudhary, again all-round, but a lot of interest in voice surgery. Devinder Rai, again at Gangaram Hospital in Delhi, but with very special interest in endoscopic sinus surgery. We have Dr. Madhuri Mehta, again an all-round surgeon, fantastic, from Hisar, but very special interest also in otology and skull-based surgery, although she does everything. We also have Dr. Devendra Chaukar with us, who is a surgeon from Tata Memorial Hospital. He's the head of the ENT section there. So Devendra has agreed to join us for this program, although he has said that there may be some emergency for which he may have to shift, and he has said that in case he goes, his colleague, Dr. Shiva, also head and neck surgeon, will join us. So the cases that we have on show today for us, I'll just run through it so all of you know what to expect. A simple endoscopic adenoidectomy, followed by microlaryngeal surgery, recurrent papillomatosis, recurrent FESS surgery for chronic sinusitis with polyps. Then we have a parapharyngeal tumor, a large schwannoma, a carcinoma of the parotid, where probably the facial nerve will have to be sacrificed and resutured. We have a very unusual case, that is malignant otitis externa, which is usually treated conservatively, but there is a definite role for surgery in this. A draft 2, which people should know about because most of the people shy away from the frontal sinus problems in FEST, though everybody is doing FEST. So draft 2 would be very interesting to watch. A subtotal petrosectomy, which is more required in cases of extensive infections or in patients with problems where cochlear implants are to be done, but even for chronic extensive infections and in management of certain tumors in that area. And finally, I said we have to close with the cherry on the cake, and that's a stapedectomy, which is again something that almost all ENT surgeons would be doing, and it would be lovely to watch the expert, how he gets these fantastic results. So I request all of you to have, pay attention and join in from now till whatever time it goes on. You know, Satish, we can't keep a time limit on him. So we've said 9 to 6, but it's likely to go beyond. And once again, thanks to all of you. Before I hand over the mic and the floor to Satish, I would just like to say today in the morning, I read the news, 198 of our colleagues, medical colleagues, have succumbed to COVID in their efforts to give service to the people and their patients in spite of the risk to themselves. So we would really like to salute these colleagues of our medical practitioners and give a thought to them and their families in this difficult times. Our prayers are with them. Satish, the floor is yours. Please take over and start. Paromita will take questions and time to time pass on the questions, and we have a panel of experts who will give us their points of view as and when they see fit. There is going to be an interaction all throughout the surgical session. Satish, please carry on.
Thank you, sir. Thank you. And good morning, everybody. At the outset, first I would like to pay my thanks and regards to Kirtne sir for giving me this opportunity to be here with you all. and it's indeed a pleasure for me to be part of this event, which has been a very, very high-end academic event by Alchem. It's an annual event, and I have been part of this event earlier as well. Thank you, sir. And the first word, what Keithness sir told me when he planned this event, to keep a variety of cases to give delegates maximum possible in their routine practice, which can be useful. And this is what is commitment. The man who has revolutionized academics in our country for his continuous efforts for last so many decades. We salute Keithness sir for his efforts and persistence. Thank you, sir. On this day, again, he made memorable for me to have another opportunity to learn from experts. The people he has called is probably I see as my teachers in my life, wherein I learned so many things from them. Devendra Rai sir has been an amazing endoscopic surgeon we all know in Delhi. He has been organizing so many courses. Renuka madam has been our great teacher. Believe me, my journey into endoscopic sinus surgery started after reading her book on anatomical principle of endoscopic sinus surgery, which I have gone through not less than 10 times. And I highly recommend every junior guy who want to pursue endoscopic sinus surgery to go through those anatomical principles, which is the backbone in learning the endoscopic sinus surgery. Thank you, madam, for such a great gift. And she is known for her innovative work. We know her amazing work in Jain and other endoscopic surgeries. And today, we are here fortunate to have madam and sir for giving us more and more information and their expertise in endoscopic sinus surgery cases. Thank you, madam. Then we have Jhansi Ki Rani with us. Madhuri, you know, she has been amazing in her work. Like sir said, she's an all-rounder, doing amazing cases, amazing workload. And she has published now. She is in the process of publishing her 4th book on otology and lateral skull-based surgery. Amazing, amazing task. Thank you, madam, for being with us. And then my own teacher, Dr. Nupur Nerurkar. Nupur is a great friend, and we all know she's a phenomenal phonosurgeon. Her upcoming conference is coming on, I think, 13th of September. And we are all dressed up for that workshop. That's an annual event. And Nupur has, amazingly changed the concept of phonosurgery through her phenomenal work into this subject. She's a dedicated phonosurgeon. And I have always been in touch with her to learn some more and more things. Sometime, even if I'm not there physically, through telephone, through emails and so many things. And she has always been so open to teach. Thank you. Thank you, Nupur. And today we are going to have your expert opinion regarding during these cases. I sincerely request all the people to interrupt me any point of time with your comments, your suggestions, because that is going to benefit everyone, including me as well. Thank you. Then we have Amitabh Dada with us, who is, known for his phonosurgical work besides his expertise in other fields of otolaryngology. And Amitabh, thank you for being with us. Narayan, we all know, he has been in part of our previous webinar. I call him as an accomplished head and neck, the skull-based surgeon. Not only lateral skull-based, but he has a full expertise in endoscopic and open approaches as well. Thank you, Narayan. And this is amazing people sir is called today for the expertise. Thank you.
Satish,
yes,
Satish,
sir?
we have 2 more people. I got interrupted by a telephone call. I have to introduce.
Yes.
Pardon me, please excuse me. It's because there was an urgent phone call for somebody that I had to stop. There is Dr. Vijayendra.
Yeah, he is coming.
Who's going to join. And Vijayendra is one of the best, greatest teachers that I have seen in otology. He has kindly consented to join. Vijayendra, I hope you've joined us. Is he there, Vijayendra? Is he connected already? And the other person from Northeast to have great respect for, who's doing fantastic work in that area, is Dr. Gautam Khaunt.
Gautam is coming.
From Assam, absolute committed worker. So I made a last minute request to him and he was kind enough to agree to join. So I was waiting for Dr. Vijayendra to join. If he's not joined, I'm going to give him a call and ask him to join us.
Sir.
Okay?
Thank you, sir. So,
So Satish, did Vijayendra join and go off, or has he not joined us yet?
I think he has not joined us.
Okay, fine.
Probably
I'll
he will
just
be
give him a
joining
call.
soon. So, today's first case, first case we are starting with is a child with a disease we all know is a very frustrating disease, recurrent respiratory papillomatosis. This child came to us 3 months back with already 3 surgeries done. Then, like we discussed in our previous webinar about the role of surgery and the role of other adjuvant therapies. So this child who has undergone surgery with us as well 2 months back, 2.5 months back, wherein we removed the superficial lesions without going into the mucosa and submucosa at all. And then we followed with the monoclonal antibody bevacizumab injection. Then after the first, this is about the case detail. Then after the first surgery with us, after 4 weeks, we again evaluated under general anesthesia, were having minimal lesions, and we injected bevacizumab again in the base. And this is the third time the patient is on table now. And this is what I'm going to share with us, what we have achieved so far, and what is the current status of treatment of this dreaded disease, which preferentially affects the young children. As far as I know about the disease, presently there is no definite cure to this disease, though with the help of lot many adjuvant therapies, lot many research work done into that, we have been able to achieve much better results what we are getting earlier. But still, there is a long way to go. I had a lot of consultations with Nupur earlier about the various adjuvant therapies. She has a vast experience of dealing with this particular topic for years together. So before going to the Nupur, let us first see what is the goal of our treatment. As we all know, there is no definite cure for this disease. So the goal of therapy is very clear in our mind, and it should be to maintain the airway, because these lesions tend to obliterate the airway, and many of the children come with the respiratory distress because they arise preferentially in the glottis. Then the second is to preserve the voice, which is a very, very important function. And this is something we need to discuss today with Nupur, as the voice preservation is an equally important goal. We are not supposed to destroy the voice by means of a radical surgery, destroying everything, like we're removing a malignancy, that we go radical and assuming that we may get a cure with this removal, which is never going to happen. Rather, if you try to go deep into the mucosa and submucosa, we are reactivating more and more viral replication and leading to more severe problem. And secondly, at the same time, by giving that much of scarring, there is, imminent scarring and stenosis of the larynx, which is something we need to prevent. That is our goal of treatment. So what exactly this disease is? This disease is basically, the virus, when it invades the upper airway mucosa and submucosa, it is between the patient, the host, and the virus interaction that leads to this sort of a disease. Many of the people may be having this virus in their upper airway, but may not be having the manifestation of the disease. So it is purely immune interaction between the patient and the disease, and the goal of the treatment is directed towards immunomodulation, disruption of viral replication, the control of the secondary inflammation, and all is dependent on the neoangiogenesis, which is the target for the future now, because of or by means of various adjuvant therapies. So Nupur, anything you think differently, or the goal is, as I mentioned to me, is very, very, very clear with the 3-point target: preservation of the function and maintaining the airway. Now, what is your suggestion onto it? I will have opinion both from Nupur and Amitabh as well.
Satish, I think the points you've mentioned are absolutely something I agree with, that the aim of surgery, obviously in every patient, would be to maintain an airway, because we all need an airway to survive. As far as the second point you rightly mentioned about having a good voice, that is something which would be targeted from patient to patient, because somebody who is a villager working as an agriculturalist would have a different vocal need than someone who is a professional voice user. So the surgery for voice should be targeted only for the need of the individual, as you also rightly pointed out. So it isn't that we are trying to give the patient a perfect picture. We as surgeons always want to see a perfect picture at the end of the surgery. And that is what we have to really hold ourselves back from. We should not try to aim to see a perfect picture, rather what is sufficient for the patient. So the two important points, of course, which you're going to address and when you do the surgery, is that the anterior commissure should remain untouched, at least on one side, because this is a disease which is going to keep coming and we don't want to create a web. A web is always very challenging to treat. The second point we have to remember is that when we are operating, we never want to go beyond the basement membrane of the epithelium into the SLP or the ligament, because then the papilloma will follow right there and become intralesional. As far as debridement, yeah. Yes, Satish.
Made you change your technique, surgical technique sometime?
Yes. So earlier I used to stay completely away from the anterior commissure, but what I've realized is if I do that and I don't use any sort of injection of bevacizumab or cidofovir, then the anterior commissure will always be a problem. So therefore now what I do is I will remove all the disease, but I will take out the disease all the way up to one side anterior commissure, go back after 6 weeks and then tackle that opposite side anterior commissure. So I've become more sort of daring with the anterior commissure, and I reserve my cidofavirs and bevacizumab for patients who require surgery more than 4 to 6 times in a year, because
So
every medicine does have its own side effects.
That's a very, very important message from Nupur, that we should not fall upon this disease considering in mind something like radical resection. We need to understand that we have to preserve the function. Like she said, if there is a disease at the anterior commissure, she would do at one side only to prevent the stenosis and come back to the other side after some time. And it looks so, fascinating to remove the entire disease at the same time and get rid of the problem. One cannot. You need to understand the disease, nature of the disease. You cannot get a cure by removal of the disease radically. So Nupur, how do you prevent the, what is your recommendation for preventing the damage to the laryngeal tissue by means of using tools? Like what tool you recommend to remove the papilloma?
So
and
first
why?
of all, sure. So first of all, we have to understand that papilloma, unlike polyps and cysts, is an epithelial disease. It's not a subepithelial disease. So we have to remove the diseased epithelium. Now, what do we mean by diseased epithelium is where we are seeing the fronds of papilloma. The virus, unfortunately, may be living in all the normal epithelium also, but obviously it would be ridiculous to remove the normal epithelium. So we remove the fronds. My go-to tool, what you're asking me, is the microdebrider, the laryngeal microdebrider. I find it is very efficient. I use a tri-cut blade, which is very similar to your cutting burr for the initial debulking. And then when you have a carpet of growth on the vocal fold, I use the skimmer blade. The skimmer blade is like your diamond burr. So it has a different motion, and also the rotations per minute would be around 2000. That's up to you to handle. Once I've done that,
any reservation regarding or any role of laser, coblator, or anything you recommend?
Yeah, I'm coming to that. So for most of the people who come with very bulky disease, Satish, I'm using the microdebrider. But I have a lot of adult onset papillomas. In fact, we've just done a recent research where 70% of our patients are adult onset papillomas now rather than juvenile onset. So that's another story as to why that's so. Now, in the adult onset papillomas, we are seeing isolated fronds of papilloma rather than, fulminant disease. Over there, I'm very happy to do a subepithelial infiltration and do a CO2 laser microflap. What do I mean by microflap? We infiltrate and elevate the entire front of papilloma like a flap, just so that we can excise it. We are not going to preserve it. That works very well. Coblation, there are very many people who are happy using coblators. I'm very happy with the CO2 laser, so I don't use the coblator, but there's nothing against using a coblator. I just find it slower, and the wands are not beautifully made to the correct dimension that you want. There are 2 wands available, of course. So my go-to would be the micro debrider, tri-cut and skimmer, or in isolated fronts, I like to do laser microflap following subepithelial infiltration. Why is the subepithelial infiltration very important? Because you want to bulk up the SLP. As I said, we definitely do not want to lead the papillomas into the SLP, and we don't want to go deeper than the basement membrane. The papilloma is replicating in the basement membrane, because the basement membrane is what is replicating. So the virus will always replicate in the tissue which is replicating, but we don't want to go deeper.
So that the point is very clear. We are not supposed to go too deep unnecessarily. Amitabh, any change in your technique I mean, using the equipments, the laser, coblator, micro debrider, or anything else you recommend?
As far as the tools are concerned, I think as opposed to Nupur, I think we all use micro debrider to debulk the lesion first and then use a laser. That's similar. But for debulking, coblation is also emerging as a good tool, and because it is generally with a good control. But again, you should know how to use. One should know how to use that tool, because this is the one point that everyone is making, that this is an epithelial disease, and we do not want to turn this disease into a subepithelial disease. The number 2 point I want to make, I always tell that I have to have a very good anesthetist when we do these patients, because the tracheostomy avoidance is one of the paramount importance in this patient. So once unless a patient has a life-threatening, if the patient comes to a tertiary center, then we must avoid tracheostomy, because that is the most important thing.
Yeah, that's a very important message from him, to avoid tracheostomy as far as possible. Like I give an example in the last webinar, we demonstrated one case. Are you getting that on the screen? See this patient in the last webinar, 19th of July. This patient we operated as a huge papilloma with hardly any airway visible, and we could intubate. As Amitabh said, the anesthetist role is very, very important, and ultimately, like Nupur said, we use one and only tool, micro debrider. It looks like completely occupying the glottis and the supraglottis, and see how the debrider is an important tool. You can use the surface debridement without going to the submucosa, mucosa or submucosa. By any means, you can use just surface debridement, and see ultimately we get everything clear, rather going into the depth of the mucosa to give scarring and scarring. Unfortunately, these children come with repeated surgery with a lot of scarring already had taken place, and you have to respect that to prevent further deterioration. So this is something I wanted to point out. Like Nupur said, we should avoid deeper penetration of instruments to give laryngeal scarring. Now coming to the next point, besides surgery, these are the things we have been using in our practice together, because we don't have a single cure for the disease. So we have been using every possible thing to have any effect on these papillomas, and these are the 5 things we are regularly using on each and every patient to give I would say adjuvant therapy. Bevacizumab, which I am going to demonstrate today again on this patient, which we have already operated twice. Once operated, second injection, and now the third injection. And the celecoxib, HPV vaccine, the Gardasil 4, we have been giving to all patients, and there are a lot of publications supporting this. PPI and this all these drugs which have an effect on the estrogen, metabolism affecting the papilloma growth. Nupur, your experience using or not using anything, or additionally if you recommend any other thing, because lots of other things are there in the literature which have impact on the papilloma, prevention of the papilloma regrowth. Like you have already mentioned about the cidofovir, we used earlier, but no more now after the bevacizumab. I think you have been using, like you mentioned, still you are using. So your experience, what is your recommendation?
So my recommendations, what I like to follow in my practice, and I want to state here, there is no right or wrong, because nobody in the world knows the perfect answer. If we did, then we'd all follow that. So what I do follow is that patients are all microdebrider is what I use for debulking, or I use a laser. If a patient requires surgery more than 5 to 6 times in a year, then I would go to Cidofovir, because that seems to work better in my patients till now.
Are you still using Cidofovir?
If the patient requires 5 to 6 surgeries in a year,
No,
or if the disease is tracheobronchial.
Without the prior use of bevacizumab, your first choice is Cidofovir.
So we have had a group of patients in whom we used only bevacizumab, and a group of patients in whom we used Cidofovir. The numbers, Satish, are very small. We are talking about numbers like 5 and 6 in either group. And the group which had in which I used bevacizumab did not do very well at all. I want to just state here that this is intralesional bevacizumab I used in the patient. In no patient did we do infusion, which I know you're doing, and internationally that is what is showing a lot of result. So now if I was to use bevacizumab in a patient, I would use it intralesionally and also by infusion in 4 to 6 weekly cycles. So that was the difference. As far as the vaccination is concerned, there's no doubt we want to create a herd immunity, and everyone who is more than 8 years of age is vaccinated by Gardasil, or now there are even vaccines which have 9 viruses in them. I do encourage all my patients to have cabbage, cauliflower, broccoli, etc., but I don't give them any kind of medication. As far as reflux is concerned, Satish, there are quite a few papers which suggest that reflux and papilloma doesn't have any correlation. But having said that, in every patient who I operate, I always find that even a little bit of acid is going to cause worsening of the healing. So post-operatively, I would definitely give,
this is simply an assumption that a reflex leading to the mucosal disruption, mucosal irritation, which can help replication of the virus. That is the only assumption.
Agreed. And I really feel the side effects are very few. So I would agree with you that I would treat the patient for reflux. I'm not giving any other medication because I don't think there's any categorically papers which suggest a fantastic improvement.
And out of this list, have you ever used anything which you have now discontinued? Any pros and cons or any experience?
So,
interferon, have you ever used interferon?
No, I've never used interferon.
Because interferon has been talked about a lot in this disease. They are immunomodulators. They modulate the leukocytic activity, the immune response. That's a costly affair as well. The availability is a big issue. And the past literature talks about the interferon a lot, which is now reduced to a significant extent after the introduction of this monoclonal antibody bevacizumab. So for everyone, bevacizumab is a vascular endothelial growth factor receptor inhibitor, which incites neoangiogenesis, and prevention of neoangiogenesis is the goal to prevent the new papilloma lesions. And like Nupur said, had certain reservation about the dosing and the systemic infusion. We went to the literature. Nupur, this is our what we have been seeing in our series of around now, where we have introduced this bevacizumab. We use this in almost 30 patients now. We started with a low dose for the fear of complications, side effects. This drug has been extensively used by medical oncologists for various malignancies to prevent neoangiogenesis. This is like an adjuvant therapy with the radiotherapy, with the chemotherapy and other things. And according to them, it is pretty safe. What we are using as a local infiltration in toto, we started with 15 milligram and now we are almost using 50 milligram topically for infiltration, more and more at various subsites. Sometimes you have a lesion on the false cord, true cord, anterior commissure. Everywhere we are using separate injection. So almost in total 50 milligram we have been using now. And this high dosage regimen, we went to the literature and again confirmed has a positive effect. Secondly, this injection comes with a 100 milligram dosing. So what we started using, the 50 milligram is an IV rather than wasting it. The reason is, for the more severe papillomatosis like tracheobronchial and pulmonary papillomatosis, the sole treatment in the present literature which is most effective is bevacizumab, and that too systemic, because then you can't use intralesional in the lung or anywhere. And in the dosage schedule, if you go to that systemic doses for the pulmonary papillomatosis, is almost 10 milligram per kg weight. If your child is 15 milligram, you have to give almost 150 milligram IV, and that too pretty safe. The side effect of highest dosing of 10 milligram per kg in long run is 1.5%, and that too minimal hypertension or something like that. So it is absolutely pretty safe, and using a high dose regimen has a positive impact on the overall outcome. This is what we have observed. Yes.
Satish, I just would, because there's so many people who will want to replicate and do what you are showing.
Yeah.
Would you do this infusion? Local injection is one thing. Would you do the infusion in all the papillomas who are coming to you? Are you selecting the people who are very aggressive disease into the trachea, bronchi, or those who require repeated surgeries?
Yeah.
Because even though you mentioned the side effects are not many, which is correct, but there is a 30% and above possibility of proteinuria and WBC counts going down. There is a 10% chance of a nephrotic syndrome. There is a chance, very low chance, but there is a chance of long-term infertility problems in women and effect with their menstrual cycle. So we have a lot of young girls. So
those are Nupur, those are I mean a regular side effect profile of a drug when it is used for other purposes, not for papilloma purpose for that matter. If you go to the side effect profile of this drug, innumerable for every drug. Number one. Number two, coming to your question about the papilloma use in papillomas, we have been using this remaining 50 milligram as a systemic dose, which is hardly any, you can say 3 milligram per kg for the child, and the doses recommended for the pulmonary, this papillomatosis is up to 10 milligram per kg.
Yeah, 5 to 10 milligram per kg.
So this is just for an added effect. I don't know whether it is working or not, whether it is right to use or not, but there is no harm in using, I would say.
I hope you're keeping a complete record, because this will make for a wonderful
publication. That is why I am going to share this second stage of this patient, in whom before 2.5 months, we removed the papillomas and injected intralesionally once. Then after 4 weeks, in a planned way, there were minimal papillomas. We debrided, very minimal, and injected the drug again, and now this is the third time. There are a lot of studies
Satish,
done. Yes.
Internationally, what they're doing is after the first time when you debulk and inject it, the second and third time, if it is not a small child, if it's someone who's above 15 or 16 years old, one can do it as an office procedure where you don't have to take the person under general. Of course, children you have to take under general, but for adults, it's very easy. Like we know how we do injection laryngoplasties, and we can just inject into whatever area we want. So you don't need to give a GA. So you just call the patient into the office and give the Avastin or Cidofovir injection every 6 weeks or 2 months. So it really decreases the morbidity for the patient to a large extent. Obviously in the children, as Satish's patient is a child, he obviously has to take it. Till Satish comes back, I'd also like to add on that Dr. Steven Zeitels has done a lot of research where he has combined bevacizumab along with a hemoangiolytic laser, like a KTP laser, or you have pulse dye lasers, or now you even have the true blue laser. The advantage is that both of these actions work in combination. One, like Satish explained to us, is preventing the angiogenesis, because bevacizumab is an anti-angiogenic factor. The second, which is the hemoangiolytic laser, what it's doing is causing a destruction of the blood vessels without destroying the epithelium, because their wavelength varies from 485 nanometers
like
to
KTP or argon.
Yeah, like KTP or pulse dye or the true blue laser. So all of them attack the oxyhemoglobin. So the two of them together, Zeitels has published 2 papers in Annals, which has shown a cumulative effect, and you can do it as an office procedure. The fiber lasers, hemoangiolytic lasers are fiber lasers, and so you can inject also as office procedure. and you can also do the fiber laser. That is after you've done the debulking under GA the first time. Of course, in children, we have to again and again give GA.
Nupur, we are all set with the case.
Looking forward, Satish.
Yeah, and the last thing I want to ask here, how do you, treat the adult and the children differently?
That's what I was just saying, Satish, while you had gone to the patient, that in adults, if it is an adult onset papilloma, very often we see it as fronds of papilloma. So we excise it as a microflap, where we take a 0.5 millimeter margin all around. And I feel that a lot of nidus of the papilloma virus is around the papilloma tissue. So by taking a small margin, I feel the recurrence really comes down, following which the adults can be injected as an office procedure if one has to opt for the injection, or we can use the fiber lasers as an office procedure rather than taking it up for surgery. For children, we have to do the GA, and we focus more on the debrider and taking care of the anterior commissure.
Okay. Ma'am, I have a question for you from Singapore.
Yes, Paramita.
Yes, ma'am. So this Dr. Ravi from Singapore is asking, when you raise the microflap, as you said, so will you not be worried about creating a raw environment for implantation of the virus subepithelially?
So papilloma is an epithelial disease. Like I said earlier, the human papilloma virus is growing in the basement membrane, which is the deepest layer of epithelium. So you cannot be considering removing half the epithelium. Technically, you can't even do that. So the epithelium, which has got the papilloma fronds on it, has to come out. There's no question whether it comes out with microdebrider, whether it comes out with laser fulguration, whether it comes out with laser microflap, whether it comes out with coblator. It has to come out. So epithelium has to come out. After epithelium, the second layer we know is the Rinke space, which has got the superficial lamina propria. You don't want to take out the superficial lamina propria. So when we perform an infiltration, we bulk up this area so that we are operating on the the most superficial part of the SLP. There's no question about making it raw. We have to make it raw because we have to take out the epithelium. What we don't want to make raw is both the anterior commissure, both the sides. Up to one side, yes. All the rest over here, yes. Choose any one anterior commissure and keep that spot with the papillomas or with the epithelium. So you can make things raw because you don't have a choice. The epithelium has to come out.
Okay, ma'am. Thank you.
Hello.
I hope that answers
Satish, Satish, before you begin, we welcome Dr. Vijendra and Dr. Gautam Khan. Both of them have joined.
Oh, welcome, sir. Welcome,
Vijendra and
sir.
Dr. Gautam Khan.
Hello, boss. Welcome.
Yeah. Thank you. Carry on, sir.
Thank you. Are you getting the picture?
Yes, very clear.
Yes, we are.
So, this patient, as I told, come to us after 2 surgeries, 2 or 3, I don't remember. Then we did surgery, the first one, injected bevacizumab, the second one with minimal lesion, again injected in a planned way, and this is third one is again the planned. Now the lesion what I see here right now is, can you give me the vocal cord retractor? Can you see on the right side? See the lesion there?
Yes, sir.
Can you see the lesion behind, a small lesion?
Yes, sir.
On the vocal, I would say the supraglottis part, the false cord region here. One lesion here and one small lesion here. And look at the vocal cords. This is after 2 injections of bevacizumab, and see the preservation of the vocal fold. Though there is minimal scarring at the anterior commissure, we can observe when we do laryngoscopy, we find that minimal scarring, if you closely observe at the level of the anterior commissure, which had happened earlier. And this dramatic response with the bevacizumab. The first course, we injected 50 milligram. The second time we injected 30 milligram. And today probably I will be injecting 15 or 20 milligram. Because I will be injecting now only at these 2 places, not at the vocal cords which are completely gone. Vocal cord, the false cord anteriorly completely disappeared. Only lesion on the supraglottic part, the false cord behind towards close to the arytenoid on both sides. And if you see on both sides lesions, if you go to the what Durkhe's classification is, about the elevation of the lesion. On the left side is a minimally elevated, on the right side is Derkate 2 is the elevated lesion. So my target now today is only these two places. You know, this is again the planned one because we don't want the massive regrowth with resultant, you know, extensive surgery to this particular patient again.
Satish,
So,
before you inject,
yes.
Do you think it is at all possible for you to take a 0-degree telescope and just show us a picture closer to? I don't know whether you do that, but we like to do that routinely.
We can.
You know, so we see the subglottis, we see
Yes,
the
yes.
ventricles.
Yes, that is very important.
Because your injections have done such a good job that the disease is hardly seen now. So if we can see it under magnification,
yes,
that would be great.
And sir,
And
after
Satish, what was the status of the lesion after the first injection when you went in
minimal
for the second
lesions
time?
on the false cord and 2 lesions on the true cord on the left side, and now it is completely disappeared.
And which was how much interval after the first injection? Yeah, I mean the second.
yes, sir. What is the interval, sir, between these injections?
4 weeks.
4 weeks.
Also, Satish, do you have a picture before injections?
Yes, I tried to find out,
We
but
would love
I will show. Probably my colleague is finding out. Can you see lesion on the left side? Hello?
Yes, Satish.
Yes.
I think we can see fronds on the left arytenoid, just very few on the medial surface of the left arytenoid.
Yeah.
Is that what you're showing us? Is this the same patient you had operated on about a month ago?
Yeah, this is 5 weeks from now.
In
After
your
that,
last,
this is the second injection.
very
Injection was
aggressive
given
disease that time.
5 weeks back. Second injection.
Yeah, okay.
So we follow. We don't have a set
Satish,
protocol.
subglottis, Satish.
Yes,
Can
yes.
you show us?
Yeah.
Ventricle and
We
subglottis.
couldn't establish a set protocol so far because of the varying, recommendations and varying protocols from the literature. Let me remove this.
This
Some
telescopic
people,
picture which Satish is showing us, it's great to take a photo with a pre and post and give the patient in cases like this which recur. So even medico-legally you show them that you did do a debulking, because this disease comes back, Satish, so aggressively that sometimes a patient can say, "Aapne to kuch kiya hi nahi." You know, same with keratosis.
Yes.
So it's always a good idea to give them those photos.
Yes, that is very important. Now see, I am going in the subglottis.
Yes. Lovely.
That
We're
looks
just
good.
seeing
Lovely.
PKK, but
There's
very
nothing.
nice, very clean.
And earlier also he didn't have any lesion in the subglottis. Now the only 2 areas, that too having minimal lesions, and still I don't want to lose this opportunity to inject again, because otherwise it can come back with the same problem. Because this disease, is, we all know, is so frustrating. So there are some studies who did 5 injections of bevacizumab at the interval of 3 weeks, irrespective of the status. Some studies did 3 injections. So what we have started doing, after the first removal and injection, a second planned definite injection after 4 to 6 weeks, and the third planned, endoscopy, microscopic evaluation again after 4 to 6 weeks. If there is a smallest lesion, inject. Now once there is a small lesion, I will inject today, and again we'll see after 4 to 6 weeks. If there is no lesion, we'll observe. As simple as that. But not following with this infiltration and allowing the lesion to flare up to give the same problem, and then same major surgery, same, allowing the scarring and all the thing, everything is not something I would say recommendable.
What dose are you injecting today, Satish? Last time you injected 30.
Yeah, so even less today,
20 or 15?
Yeah, 15 or 20.
Good, great. Sometimes these injections, especially I know in Cidofovir, in a doctor patient actually, repeated injections took care of the disease but caused massive scarring of the superficial lamina propria. I had not done those particular injections, but the doctors following up with me, because his mucosal wave is almost absent. So, you know, as Satish is very rightly saying, if the disease is quietening down, he is decreasing the dose also. So that is a great idea. It makes sense.
Ma'am, what is the reason for repeated recurrence in spite of adequate clearance? Is it the strain of the virus, and do we send the specimen for viral analysis?
Paramita, good question. Yeah, so one is we must always send for viral typing. The first time the patient comes to you, not only histopath, you want to know whether it's 611, which is acceptable, or whether there is 1618. So we do a viral typing the first time. We don't repeat the viral typing unless we feel the disease pathology seems to be looking a little different. The histopathology also we don't do every time, we do it every third time. But there's no harm if you want to do it every time. Why we do it every third surgery is in case dysplasia is developing in or a carcinoma in situ is developing. Why does it recur? The whole problem is that the HPV virus is living in the basement membrane of apparently normal looking epithelium, which we've left behind. And therefore it grows. So therefore what Satish is doing, even when everything's looking more or less good and healthy, he's not only going to inject in the small areas, but a little bit all around. So the idea is to prevent, in this case, angiogenesis from taking place. So to prevent any possibility of that virus, which is present, which we can't see, from again growing back. Same principle for side of a.
Can you see?
Okay. Yes, ma'am. Yes.
This is right in the base of the lesion. I am not debriding it today. This is already almost close to the surface. The further debridement would allow the surface to, you know,
become raw.
Yeah. See this?
What is the injection needle you're using?
Yeah, this is what I'm using in the PCNL needle, which we get from our, urology friends.
Okay.
This
we
is
have
fine
other
PCNL
options.
needle, and see the lesion where I injected. This is 10 milligram.
10 milligram. Okay.
And now on this side, see the lesion on this side? Go to the depth of the lesion, just in the depth of the lesion. See this? See
Yes.
this?
So in the SLP is where you're injecting, which is just deeper to the basement membrane.
That's it.
And for people who don't have a PCNL needle, you can simply use a scalp vein by cutting the butterfly flanges.
Yes.
And here you can use a 25 number needle, because don't use very fat, because it's a very thin liquid you're injecting. Or you have 26 number long infiltration needles, which are locally available for 500 to 700 rupees, which we use routinely.
Yes. Now see, I've injected 20.
Excellent.
Without removal of the lesion. And this again, after, 4 to 6 weeks, we are just going to see this, whether the lesion is coming or not. See this elevated lesion a little bit. It prompts you to remove it, but believe me, it is not needed. This is generally the level to which we reduce in our initial surgery.
Okay,
Rather
Satish,
than going to the level of the mucosa. Yes, yes, madam.
do you take certain special precautions to avoid any laryngospasm in the post-operative period in such cases?
Never faced, because we have already given a dose of steroid
Okay.
at the time of intubation.
Okay. Okay.
So this is what the injection in the base of anti-neoangiogenesis factor, and this is what needed in this situation. You remember the last case, then on the 19th of July, we'll keep it after 2 weeks. You have all seen the kind of, extensive lesion it was. And after 2 weeks time, you see how it regresses, the same patient. It is dramatic. Believe me, it is dramatic. Besides this, not only this, the first time when the patient came, we gave him a dose of Gardasil, which is to be repeated after 2 months and then 6 months. The 3 doses of Gardasil. That carries, that's a quadrivalent vaccine against HPV 6, 11, 16 and 18. There is a bivalent vaccine introduced earlier that is against 16 and
Hmm.
This is for additionally for the papillomas as well. And nowadays the nonavalent vaccine has also come against the HPV strain 31, 33, 45, 48, 52, so many. There are more than 100 HPV strains discovered, and these vaccinations, there are certain publications showing the amazing immunity against HPV with three doses of vaccine in a known case of papilloma as a therapeutic use, not for prevention, as a therapeutic use. Secondly, we are giving all these pediatric patients the celecoxib, 100 milligram to these pediatric patients every day for at least 3 months. These papillomas are known to have, the COX2 receptors on which the celecoxib acts. And this is a good strategy to use as an adjuvant therapy, celecoxib, for these patients. So amongst the other therapies, a lot of people even recommended MMR vaccine, mumps vaccine, intralesional, so many things, but the effects has not been observed in the long studies. So this is the 5 things which we have been doing, which have proven to be efficacious against majority of the papillomas, and we are using all them together because we don't have any cure to these patients.
Satish, may I mention a couple of things?
Yes, please. Before you carry on, and our next case is ready. That is a adenoidectomy, which we have already induced, and we are going to start in a couple of minutes. You carry on, Nupur.
Yes. Thank you, Satish. So when we have disease in the anterior commissure, what we mentioned is that one can remove all the way one side anterior commissure. Just want to mention that please don't give these patients post-operative voice rest, because when you give voice rest, the chance of synechia formation are more. So don't give these patients voice rest at all. Secondly, Madhuri asked a question about laryngospasm, which doesn't happen very routinely, but we do a very simple thing of a spray with 10% lignocaine just before extubation to prevent a laryngospasm from taking place. And thirdly, want to mention the role of vaccination is really important in creating herd immunity, which will come in 10 years down the line if you start vaccination for all the girls, even if they're only girls and not boys. But vaccination is not therapeutic. What most of the papers suggest is the chances of the individual from getting a new viral infection will be absent most likely, and also the present or existing virus disease becomes a little less aggressive. That's what most of these studies suggest, because for vaccination it's not possible for it to be therapeutic as we understand.
Okay.
I'd like to thank Satish for a great job.
Ma'am, I'd like to take few questions quickly before sir comes in for the next case. There's a question from Malegaon by Dr. Mohammed is asking the role of CO2 laser versus the argon laser.
Paramita, yes, Nupur has already mentioned, and we have already so many times mentioned, the lasers have practically no role because we don't want tissue damage. Number one. Secondly, she has already mentioned the lasers, the visible lasers having affinity for the hemoglobin to target the vessels have some role, like argon laser, KTP laser if you want to use. But now once you are using the neoangiogenesis factor, there is practically no point in using all those lasers. Now coming to the last point, once you do a papilloma case in a theater, you should avoid taking any other case in the theater further for the day. You have to change the laryngoscopes and all. You have to change the circuit as well, because they may be harboring the papilloma in the fumes if you have, fulgurated, if you have debrided, if you have used laser or anything which is creating fumes which can come in the circuit. So this is something, an added precaution we must take once you do such a case, because to prevent, the cross infection to the other patient. This is very, very important. I don't know how, Nupur, is your recommendation, what you have been using in your theaters for all this?
I just have a question. Sorry.
Yes, please.
Satish, have you ever been concerned about any occupational hazards if you keep on operating on papilloma? Because you said
yeah, you have to be careful. You're right. You have to be careful, particularly when fumes are generating. So earlier we were very cautious, but nowadays we are not using anything creating fumes. Otherwise, you have to be wearing the protective equipments to prevent, inoculation.
Yeah.
So
We
what is the
fumigate the theatre after papilloma case, and we do a double sterilization of all the equipment. But we do a case then after. But as Satish very rightly said, it's very important to change all the circuitry. It's also very important for the surgeon when you're using a microdebrider, and especially in the COVID era, to use a PAPR, PARD air purifying respirator, which I am begging Satish to buy and start using.
A few surgeons, madam, wants to know what can be the cost of this injection per sitting?
So the cost of cidofovir injection is about 90,000. We don't dilute the vial. We keep the same vial, and then we use the same vial for the next after 3-4 week injection and after 3-4 week injection. So it will work out to about 30,000. And similar cost of 24,000 is for bevacizumab, but Satish manages to get it some 18,000 thing he had mentioned.
8,000 something. 8,000 something. 8,000.
So that he will let us know what is the name of that bevacizumab.
So we can carry on question, Pramita,
Yes,
during
sir.
our next case as well.
Yes,
And
sir.
I'll take whatever question you are having in your right now in your mind. Before that, we are all set with the second case. This is adenoidectomy. At the same time, the third case is again going to be a microlaryngeal surgery. So this case, because these are the small cases, children, which we want to keep in the beginning, and then we'll carry on with our long cases. So our next case is a adenoidectomy, which we are all set on the table. This is rather adenotonsillectomy for the obstructive pathology. Paramita, what was your question before we move on?
Sir, there was a question from Dr. Kaustubh Das from Kolkata is asking any role of bevacizumab in laryngeal hemangioma recurring after sclerosant injection.
Yes. Not only hemangioma in the larynx, anywhere in the body.
Okay.
Not only hemangioma, any vascular lesions. Like I've been using, for the hemorrhagic telangiectasias in the nose. Many of those patients have been cured. Even some of the patients didn't come after the first injection. It is so dramatic. You inject submucosally this injection, and it is something like a magic. For Osler-Render-Weber syndrome, or what we call it a hereditary hemorrhagic telangiectasia. For that matter, any vascular lesion, this has a role. Locally, systemically, and same way it has been used initially, how it was produced at an anti-neogenesis factor for the malignancies as an adjuvant therapy, post-surgery, post-radiotherapy, along with radiotherapy, along with chemotherapy in various ways. So it prevents neoangiogenesis, and looking at that role, it has been used for many other indications as well.
Okay, sir. Okay, sir. Sir, I think no more important questions. We can move with the next case.
Okay, and you can interrupt any time in between. Are you getting the picture?
Yes, sir.
Okay, let me tell you about this case first, and then there's a very, very important, and very common pathology we see in our practice to treat, that is enlarged or hypertrophic adenoids, but that is not the only indication. First of all, let me show you the picture and something about this case. This is a 7-year-old child, who presented with a history of mouth breathing, snoring, had adenoid facies now, and now he has come for this treatment of adenoids, and see the tonsils. They together are giving him the snoring and the mouth breathing. So, number one thing, adenoidectomy, as we all know, is mostly indicated for obstructive indications. And for obstructive indications, age is no bar. We have done adenoidectomy in a 1.5-year-old child. We have done adenoidectomy in a 25-year-old man. So age is no bar. Whenever there is an obstruction, obviously you have to take care of it. Particularly if it is endangering. Particularly in children, they present with like OSA. Many children we have seen with a back pressure rising, sort of core pulmonale with the pulmonary artery pressure shooting up, and those are the real indications in those situations. So obstructive in general are the common indications, but that is not everything. Obstructive, there are so many other indications which we need to know, and believe me, in our practice, non-obstructive indications nowadays are more prevalent as compared to the obstructive. So by and large, we divide into three categories. The one is obstructive, obviously you have to remove the adenoids, which we are going to discuss today. And the other are non-obstructive indications. The two important categories is one for the repeated otitis media or otitis media with effusion, with no obviously, so much of enlarged adenoids to give obstruction. And third is in pediatric population with recurrent rhinosinusitis not responding to medical treatment, and once it comes to surgical aspect, the adenoidectomy is the first surgical answer rather than directly venturing onto the face. The reason for that has been proven in a lot of meta-analysis, as the adenoids harbor biofilms which ultimately aggravate or perpetuate the chronic rhinosinusitis, and adenoidectomy as a surgical treatment in many of the patients avoids a formal sinus surgery in pediatric population. So there are three indications. So coming to the adenoidectomy, number one, how to carry out the adenoidectomy, a comprehensive adenoidectomy, and that has multiple goals. The goal is to remove comprehensively, number one, to prevent complications and to prevent so-called recurrence. For everyone, adenoid is just an hypertrophic lymphoid tissue, which normally has an immense role being a part of Walde's ring in children to combat, or as a part of the immune system, you can say, to deal with the allergy and inflammation which are very, very common in children. So adenoid tissue is just a hypertrophic lymphoid tissue. 60% of the component is B lymphocytes and 40% is T lymphocytes. Almost 3% are plasma cells. So it is just conglomeration of B and T lymphocyte. That's it. And it responds to allergy and inflammation and get hypertrophied. So it's a sort of vicious cycle, I would say. A persistent allergy or recurrent infection, inflammation leads to adenoid hypertrophy and then further symptoms, number one. And number two, adenoid itself, if they enlarge, obstruct the airway, they can precipitate the allergy and inflammation. So it's a sort of vicious cycle. So in order to break this vicious cycle, majority of the patient who is coming with the obstruction, we need to comprehensively clear the adenoids, number one. At the same time, post-operatively, to treat the adjuvant pathologies like allergy or any source of inflammation, lack of immunity, all those factors need to be treated post-operatively to prevent the so-called recurrence. See, this is not a tumor which can recur. This is a simple hypertrophic lymphoid tissue which, if removed completely and the cause is taken care of, cannot come back simply. And this is such a rewarding thing if managed properly. So today my goal is to demonstrate our technique which we have been using for years together, used in thousands of our patients, to comprehensively clear the adenoids, to prevent the complication. There are so many important things in the surroundings when we remove the adenoids, when we remove them, and you have to protect all those structures at the same time. And third thing, to prevent the possibility of so-called recurrence. See, a partial removal of the adenoids with not treating the cause behind it is the commonest cause of the so-called recurrence. It cannot recur. It's not a tumor. We have to address the pathology behind the development of the adenoids, and most of the time it is allergy. It has been proven. The IgE-mediated mast cells have been recovered from the adenoid tissue in those patients, and if those allergy part is taken care of, along with a comprehensive removal of the adenoids, you can certainly give, a long-lasting effect or a cure to these patients majority of the time. Third thing is the airway. You know, in children, particularly young children, the airway is sometimes so narrow. You have to be careful to prevent trauma to the surrounding structures in these patients. Wash. Yeah. Can you see the picture of the adenoids? This is without any preparation. No use of any, the topical adrenaline or anything. No injection, no infiltration, nothing. This is a simple primary picture. Be careful while doing adenoidectomy to prevent trauma to the nasal mucosa, to the turbinate septum, to minimize the trauma, to prevent the possibility of synechia in the post-operative period, which is something, again, a very frustrating thing to treat, because these children, you can't expect to follow with douching judiciously and all those things, and you have to be very careful during surgery to prevent the intraoperative trauma. That is something very, very important to keep in mind from the surgical point of view. So what I am doing, decongesting the nose. Knowing the fact that these children are known to have narrow nasal spaces, our instrumentation is very, very important. Still, in over 90% of the patients after the proper decongestion, we have been able to use the 4 mm regular endoscope in those patients, over 90% of the patient. Otherwise, we may have to resort to a 2.7 mm endoscope. At the same time, see the instrument what I am using is the Otolaryngology cuff forceps to prevent the trauma to the surrounding mucosa. Now I am using a adenoid pack from behind as well, just to decongest the surface mucosa. Now coming to the surgical technique. Now my goal is, first of all, comprehensive removal. It's not just the surface debridement to open up the airway. Majority of the adenoid surgeries are being done like that. You remove from the surface, the airway opens up, and initially the child recovers from the symptom he presented with obstruction, but that is not something, a long-lasting, treatment to the patient. So our goal should be a comprehensive clearance. Yes.
Satish, as you're doing adenoidectomy and tonsillectomy in the same patient, do you change the position? Because in adenoid, you may not be giving extension. Where
adenoid is a regular sinus surgery position, reverse Trendelenburg position.
So once you do the adenoidectomy, you change the position, then the tonsillectomy.
Yes, obviously.
Okay.
And see, there are so many techniques prevalent for the adenoidectomy. So many techniques. Earlier, used to be done by the, adenoid curate. That used to be most of the time a blind procedure. You curate out something, open up the airway as you get some tissue out, but this is never long lasting, and these children would again come back with a so-called recurrence. Then, with the advent of endoscopy, there are a lot of new tools coming up with a direct visualization during surgery, like bipolar cautery, coblator, debrider, so many tools, harmonic scalpel. People are trying each and every possible thing to remove the adenoids. This, our technique, is a combination, I will tell you the reasons why, is a combination of coblator and micro debrider for this purpose, special purpose, for comprehensive removal, at the same time prevention of complication. Comprehensive removal is a sort of, you can say, radical removal, at the same time preservation of the function. Because in the vicinity all around are musculature, vascular structures, the soft palate, so many things in the vicinity all around. See, this is after initial preparation. So I will tell you why we are using a combination of coblator and debrider. Obviously, the coblator is the most fascinating thing you can see nowadays, as it gives you a surgical experience without any bleeding. And that looks fascinating in the adenoid as well, because a lot of people are scared of bleeding in the adenoids, and these children, particularly very, very young children with low blood volume, you can't expect too much of blood loss, and that's why everyone is, going towards the cobblator. But the only concern with the cobblator is the charring, particularly charring in relation to the critical musculature, the soft palate, Eustachian tube, and if you give charring and resultant fibrosis is never acceptable. So we don't use cobblator extensively right from the beginning. At the same time, the microdebrider is a great tool in terms of it expedites the process, but the drawback is the bleeding. So we have to use these two things judiciously together to get the outcome. We'll be using the microdebrider in the beginning to get away the maximum bulk of the adenoids, and then right on the surface I will show you how the debrider can be used, and then in between the cobblator would be used, which is much better a tool for coagulation than any other thing for the hemostasis in between. Cobblator we never recommend for dissection as it leads to fibrosis, and that is inevitable. If I use the cobblator at the end of the surgery surface everywhere, the resultant fibrosis may lead to cicatrization and can lead to nasopharyngeal stenosis even. It has been reported. So this demonstration is to show a technique how you can prevent all the complication and get the adenoids completely out. So this is something important to understand. This is a very, very common surgery. See now, my red 60 debrider blade is coming from the oral cavity. Can you see?
Yes.
This is red 60 sinus blade.
Satish?
Yes?
So you must share with the audience what you are using 0 degree through nose and coming.
Yes, 0 degree, regular 0 degree sinoscope through the nose and regular red 60 sinus blade from the oral cavity. And this first phase, I will accomplish this surgery in 3, phases. My first phase is the fastest one, wherein I am going to remove this bulk of the adenoids quickly, because using the microdebrider is going to result in some sort of bleeding. So the faster you accomplish, the lesser will be the overall bleeding. So my first phase is the debulking, I would say. I will quickly carry out this debulking in few seconds, and then we'll, come on to the area of interest, that is the surface where these adenoids are attached to on the nasopharyngeal surface.
Yes, sir. So Dr. Sandeep Karmarkar is asking, we have been doing the same technique with great result. Have now described as combo adenoidectomy. Any comment on this?
Yeah, you can call it combo.
Okay.
See now, my constant irrigation is coming through my assistant all the time to maintain my visualization, and this is warm saline which helps in hemostasis as well, as I am using a tool which results in some sort of bleeding. See on both sides what I intend to prevent? The damage to the Eustachian tube. Can you see on both sides? This is the Eustachian tube torus, this is the Eustachian tube torus, and see the adenoids on the surface of the Eustachian tube torus. So this is my first phase with, opening up the airway. This is just opening up the airway. Wash. Can you see?
Yes, sir.
Even if you do this, the child no longer remains a mouth breather. It opens up the airway. See this? And majority of the people end up, this surgery at this point of time, and it gives a result, instant result, by means of opening the airway. See this minimal bleeding with the torus on both sides, under vision, protected, and a lot of adenoid tissue attached onto the surface of the torus. There are a lot of publications, citing the laterally hypertrophic adenoids section. Laterally hypertrophic adenoids cause of otitis media or otologic problems. See now what I am using, my saline adrenaline saw gauze onto the surface for few seconds. This I am going to leave for few seconds for the decongestion. Okay? See this gauze for few seconds.
Satish?
Yes, sir.
Just wanted to know, you use a nasal approach, and yet you said that there's a lot of, there's a possibility of nasal synechia formation.
Yes.
So why is it that you use this approach and not the other approach per orally?
Yes.
And taking the catheters to elevate retract the soft palate, and then totally doing the same thing under visualization without entering into the nasal cavity at all. Because small children, at times it's quite difficult to put in the endoscope in one side and then do it, after all, you're doing that per orally, the microdebrider.
Yes, sir. You're right. That's why I already pointed out that you have to be extra careful. You have to be extra careful while using the endoscope through the nose to prevent, damage to the mucosa. But it has an advantage of giving you the true picture in the 0 degree of obstruction. What otherwise you get from behind is not the true picture of the child which is experiencing as far as the obstruction is concerned. See now, after the first phase and the packing for few seconds, can you see?
Yes, of course.
This is the remaining adenoid tissue, and it looks like adenoidectomy done. You see the prominent tonsils below. See, my irrigation is the main tool for hemostasis, and there is hardly any bleeding now. Now this is my first phase. Now the actual adenoidectomy starts in the second phase. My second phase focuses the adenoidectomy in the center, and the third phase will follow laterally. So in second phase, what I mean to say, what we call it this term as a comprehensive adenoidectomy, to remove adenoid in the plane. See, what is there behind the adenoid tissue is the nasopharyngeal musculature. And separating from the musculature is the thin facial layer, we call it as a perimysium. See this adenoliths in between. These are just aggregation of the bacteria which calcify and lead to this adenolith like tonsilloliths, and they are the source of propagating the infections, So,
that's where the biofilms are, basically.
Yes, biofilms. Exactly, sir. So now, in order to do the second phase, this is the most important phase, I would say, in order to get rid of this adenoid tissue completely. See, if we leave this much of adenoid tissue, with the ongoing allergy and infection, this is bound to come back. So what you need to do to remove completely in the plane. My target is to remove the adenoids completely in the plane. I can do this bloodless with a coblation as well, but my coblation will inevitably result in charring the surface behind. And behind is the musculature, which I don't want to damage. That is not our target. Our target is adenoid only. So how you can remove in plane? See below, this is oropharyngeal mucosa, and what on the surface projected are the adenoids. What I am using the same rate 60 blade. Now I am using tangentially. See this tangentially, at one place I am trying to get into the plane. See, my cutting edge is towards me, not behind. I don't want to damage the musculature behind. So what I am trying? Keeping my cutting edge towards me. We never recommend the so-called adenoid blades because that has a rear cutting edge, and that is something beyond control, and you can damage the tissue behind. So at one place, see, going parallel to the oropharyngeal mucosa, just going parallel to the oropharyngeal mucosa, I am trying to develop the same plane, and then I am going to go up. See, in few seconds you will find the perimysial plane. Can you see this plane coming up?
Yes, sir.
See, all this tissue over this plane is adenoids. Only thing what I am, experiencing, if not using the cobbler, is a little bit of the oozing. At this cost of the oozing, I am able to prevent damage to the muscle, and that is what I want in long run. And we can, pay the price of this little bit of the oozing at the cost of preserving the function. Because, see this perimysium behind, very clear. See the fascia plane. Can you see? Can you see the facial plane?
Yes, sir.
And see, my cutting edge of the blade is towards me. So it cannot damage anything behind. Now I am more and more going up over the perimysium. My goal is to see my layer of perimysium behind, absolutely protecting the muscle, which is otherwise not possible by any means if you try to remove the adenoids comprehensively. But now, see the change now. As I go up, this muscle ends and the base occiput with the periosteum comes. How you can differentiate? How you can differentiate, my darling? See, this is the muscle. See, this is mobile structure. And what is there above? See this? This is the base occiput, which is not a mobile structure. Can you appreciate the difference?
Yes, sir.
So as I go up, now I have no fear of damaging any muscle. Can you see? I have no fear of damaging any muscle.
Yes.
See my irrigation. This is not bleeding. This is pure irrigation going on. Now see above, this is my periosteum plane. Can you see? Now since there is no muscle, I am staying little radical, combing through the periosteum. See, literally combing, hard combing through the periosteum to remove each and every bit of adenoid, because here I cannot damage the muscle. There is no muscle superiorly. Muscle is ending here. Muscle is ending here. Until then, I use in the perimysial plane very in a conservative way, protecting the perimysium completely. And above that plane, see this, that is the periosteum, where I am combing it very hard to get rid of each and every bit of adenoid tissue. I am not scared of damaging the periosteum here. The reason is periosteum is too resilient to be debrided by the microdebrider. And see, you can see the underlying periosteum and the base occiput. Now see the difference after the second phase. Suction. See, this is after second phase. Suction kar niche rakh. See, after the second phase, suction karna. Can you see the perimysium below? Hello?
Yes, sir.
And the periosteum above.
Yes,
See,
sir.
this is to give you an overall picture after the second phase. This is not all done. Now what all again I will do, like I did after the first phase, I will pack with a, the saline adrenaline gauze for few seconds again. And then I will show you the clear picture of the periosteum and the perimysium. Above is the periosteum, below is the perimysium, and you need to understand the difference. Because on perimysium, I have to be careful not to damage the perimysium. As long as the perimysium is intact, your musculature is perfectly intact. Above the periosteum, you can comb through the periosteum hard to remove all adenoid tissue. Now, what is the implication of these two differences? On the perimysium, if you keep the perimysium intact, there will be hardly any bleeding, because bleeding coming from behind is restricted by a layer of perimysium, number one. And you are not supposed to cauterize that surface too much to, coagulate the muscle behind. That is why we are not using the coagulator, because I don't want to char the muscle at all. Many a times you must have seen, I have seen in my practice, children got adenoidectomy done, who come back with a nasal twang of the voice, with nasopharyngeal stenosis, so many things. That is because of trauma to the surrounding muscles. As long as the muscles are intact, there is no residual damage, and these complications like nasal twang, which may be a little bit as you open up the nasopharynx initially, but it never be long lasting in case your muscles are intact. And the most important is the nasopharyngeal stenosis, infection. If you damage the muscle, we have seen even a patient got an adenoidectomy, the muscle was damaged and presented with a torticollis with retropharyngeal abscess. Every complication can be prevented if you stay in the perimysial plane and prevent the charring of perimysium. So that is my goal, and that's why I purposely used microdebrider. We paid the price of a little bit of the bleeding, but in long run, this is amazing. See now, this is after second phase. Can you see this?
Yes, sir. Yes, sir.
See the plane of the oropharyngeal mucosa. See the plane of the oropharyngeal mucosa. This is my cobblator now. I told you we will use cobblator in between for the minimizing the bleeding. See this minimal use. This is much better than any cautery, as it is always, irrigated. See the minimal use of cobblator, the perimysium is pretty intact all the way. Can you see this?
Yes, sir.
And here the periosteum. Now I told you a post-operative hemorrhage can be one of the complications in adenoid surgery, and knowing that fact, we need to do something during our surgical technique as well to prevent the post-operative hemorrhage. Post-operative hemorrhage may happen as the vessels may open post-operatively. Now, as long as your perimysium is intact, no bleeding can happen from this area. As the muscles contract and the bleeders close. In contrary to that, the periosteum doesn't have that ability to contract. And if you go retrospectively, majority of the bleeding in adenoids is coming from superiorly from the periosteal area, because this doesn't have an ability to contract. And since we want to protect the periosteum, perimysium with the muscle behind, periosteum is not so important as there is no muscle behind. So what we do here, we prophylactically coagulate. It's a sort of carpet coagulation of the periosteal surface. Only selected periosteal surface, not the perimysium at all, because we don't want to char the muscle. And why prophylactically? As we don't want any bleeding from the periosteal region. And this carpet coagulation has amazing advantage by means of ruling out the post-operative bleeding with no morbidity at all, because this is coagulation of the periosteum, not the muscle. Now see, after this, there is hardly any bleeding. Can you see?
Certainly, Satish, I think it's a very good technique that you demonstrated. And but like I have definitely been using coagulation for the last maybe I don't know how many years now.
Yeah.
And done about 2,000 of such cases, adenoids I mean. And rhinolalia is a factor which I have faced in about 3 patients, but they all recovered within about 3 to 4 months.
Yes.
And but there was never have been post-op bleeding at all. And if you restrict yourself to the perimysium and you have the right planes, because that's what any surgeon would be respecting.
See, what I intend to respect is this muscle behind. Now, without using the coagulator, this is 100% protected, not coagulated. With coagulation, this is inevitably charged, which may have implications. Like a person like you with the expert hand may not have that much of incidence, but this is something has an issue. And we are here striving for the best, for the technique which should be replicable by even the novice surgeon in the safest way. That is why we never advocate using anything on the perimysium to protect the perimysium and the muscle completely to prevent post-operative complication. To coagulate.
Satish, this is what I had wanted to say about you, that in your hands it looks fantastic, but I'm quite sure that a learning curve is required to that technique also that you're adopting. And the same message goes for everyone. Everyone has to respect the paramecium and the muscles and the pars ridge that has to be done.
Sir, if paramecium is injured, how can we handle it?
If perimysium,
yeah,
obviously you have to coagulate. There is no way.
Yes.
Okay.
And that is something, inevitably, something will be inviting some fibrosis, scarring, and all those problems are certainly need to be avoided. That is what we are emphasizing. Now my third phase is starting, which is again being neglected by majority of the people. That is laterally hypertrophic adenoids. And this has been, you go to the literature and in our huge series, it's been a major cause of so-called recurrence, so-called repeated ear problems. You know, Many a time this adenoidectomy is done along with the ventilation tube insertion. For the recurrent OME, and you do an adenoidectomy, insert the tube, and again the same problem persisting. And one of the cause for that is laterally hypertrophic adenoids, and the biggest cause of non-removal of these adenoids is the fear. It's the fear of damage laterally, and this is what I am going to emphasize, how you can remove it in the safest way. And this is very, very important. Then only a comprehensive adenoidectomy will be done. See now, again my red 60 blade. Can you see?
Yes, sir.
Now my phase 3 is starting. I am pressing on the musculature. This is my, the torus tuberis. This is adenoid tissue over the torus. And this is the adenoid tissue behind in the fossa of Rosenmuller, which I want to remove. The muscles in the midline, this is longissimus capitis muscle. And laterally I will show you the thick muscle layer, that is rectus capitis anterior. And in between this muscular envelope, we have to remove this adenoid. We are not supposed to go out of this muscular envelope to damage the vessels. So the fear factor is a huge one, particularly working laterally, the fear of carotid artery and all that. I will show you the relationship of the carotid and other things without, terrifying with all those things. So now my first thing is press on the muscle behind, and using, see, at a lower speed, control speed, allow the adenoid tissue to fall into your blade. What I want, press on the muscle. I don't want muscle to come in. See this. How much of the adenoid will leave behind? See this. Always keep the cutting edges in view. Don't push your blade too in blindly. Press on the muscle and allow the adenoid tissue to fall into the blade. See this?
Satish?
This is the technique to add on to the safety. Yes, madam.
Satish, that answers the question asked by Dr. Devender. Why are you using through nose? Because you can see the cutting edge of the debrider when you go.
All the time.
All the time it is in under vision. So you don't find any blunders.
See this, all laterally hypertrophic adenoids. Keeping my cutting edge all the time.
So anything specific you're using for irrigation, or it's just normal saline?
Normal saline. Normal saline or ringer lactate.
Okay.
Madhuri, this aspect is
Can you
also
see
very
the
well in
lateral
that,
muscle? Can you see the lateral muscle?
Yes.
That lateral muscle is the...
Hello, Dr. Devender.
Yeah. See, when you have the visualization with the endoscope, but orally also, you visualize these areas. And the area which Satish is at the moment working on is very well seen with the coablator. And the advantage is that the bleeding doesn't take place because you are after there.
Agreed. The problem with the coablator is you end up charring the surrounding surface. If I use the coablator in the fossa of Rosenmuller, I will end up charring the torus tuberis, the posterior muscle, lateral muscle, and that will completely obliterate the torus, the fossa of Rosenmuller. Because that charring is
very well.
inevitable. That is inevitable once you use the coablator. You cannot prevent.
Because my experience is different, but I am quite sure that your experience is absolutely valid also. I'm not denying that. But I mean, I've been able to remove the way you are removing all the adenoid tissue, and without the real charring taking. I mentioned about my cases of rhinolalia, of course, there, but no bleeding. So some charring may be there.
More than that, what you need to see all the time. What you need to see, I'm coming to your point, sir. What you need to see is the soft adenoid tissue. See, the muscle will not fall easily into the blade. It is the soft adenoid tissue which is going to fall, and you can see at the end of the surgery, in the depth, the entire adenoid jumped inside the blade and only the musculature remaining. And this little bit of the bleeding is, once you are using the debrider, it is inevitable, and how you can easily control in no time. I will show you.
So you're talking about the muscle laterally, the rectus cap.
See why we are, paying the price of this little bit of the bleeding is to preserve the musculature. That's it. 20
Satish,
to 30 ml of the bleeding is acceptable in such surgery using the micro debrider. This is under magnification, it looks more, but it is never beyond 20 to 30 ml. And believe me, this gives the children amazing post-op because there is no charring, no sloughing, the recovery is fast, the surrounding musculature is preserved, the long-term, the stenosis, scarring, all these things can be almost certainly prevented. That is the goal. That's why we are not using the cobbletter. Cobbletter is fascinating. It looks so good, then everything comes, bloodless. But the other aspect we need to keep in mind that the charring, that
Dr.
is some...
Satish,
Yes.
Satish, one place where I use the cobbletter in the beginning is
Yes,
when
ma'am.
we're doing children who are just 1.5 year old who have obstructive sleep apnea,
Yes.
where you need to remove the adenoids. And
Yes.
of course, the amount of blood loss that they can tolerate is very little.
Yes, yes.
Therefore, in the initial thing, when there's a lot of gross adenoid, that instead of using a debrider, I use a cobblator,
Yes.
shrink it, and to remove it so that that part of bleeding is taken care of.
Yes. Yeah,
And
that is a great idea. As long as you don't go right onto the perimysium.
And then when you have the residual adenoid, then I start using the blade so that you can skim off the rest.
Yeah.
And then at particular points, you may need to use the cobblator just to stop the bleeding.
Yeah,
But
that
the
is
gross
great.
adenoids
That is
I
great.
can remove with a cobblator in very young children.
Yeah,
So below 3 years of age, will we use debrider or I do not get it, sir?
See what madam is saying,
Yeah.
during the initial phase of debulking, in young children, even you want to avoid that little bit of the bleeding, right, going up to the perimysium, you can avoid that bleeding by means of using the cobblator, and then you don't go right up to the perimysium to damage it, but close to the perimysium and then take over by the cobblator, by the debrider. That is a good move. You can try. That is something really good. You can see my fossa Rosenmuller now completely. Can you?
Yes, very well seen. Very well seen.
Satish,
The issue is nowhere charring. That is something my goal.
Satish,
Yes, sir.
a lot of juniors, they are worried about using the debrider behind in that fossa of Rosenmuller. So at this time, it's a good idea to explain the carotid anatomy. Also,
Okay.
there are reports in the literature which report injury to the carotid, especially in children where the carotids are really very narrow. Occasionally, I'm not talking of.
Okay. Okay. Narayan, it's a good point. It's a good point.
The carotid
And
anatomy and
I
what-
will definitely explain it to shatter the fear of the carotid here.
Yeah, and shatter the fear of using the debrider in that area.
Yes, yes. See, the principle of using the debrider is very clear. I told you not to use it blindly, not to force it inside, keeping the cutting edges in view and allowing the tissue to fall into it rather than poking the debrider deep. That is the first principle. Secondly, about the carotid. I mentioned several times, if you remember, during the endoscopic dissection as well. The carotid artery, see, let me show you where is the carotid, what are the structures behind. This is the longissimus capitis muscle behind. This is a thick muscle, almost a centimeter thick. Behind that is the atlanto-occipital membrane and the arch of the atlas, anterior arch of the atlas. And this approach is a common skull base approach to the foramen magnum, that is the transodontoid approach, because behind the arch is the odontoid process. You drill away and then go to the foramen magnum from anteriorly. At the level of the arch of the atlas is the carotid laterally. Imagine what I'm trying to say. The carotid is 1 centimeter behind, besides laterally, 1 centimeter behind the plane of the surface of the adenoid tissue. From where my this section is, the carotid is exactly 10 millimeter behind and lateral. Now, how much lateral? This is the fossa of Rosenmuller, which, I am pointing out at the end of this section. The fossa of Rosenmuller, see far laterally, the carotid here is covered by 2 thick muscles. Number 1, the first thick muscle, as I said in the midline, is the longissimus capitis, and the other muscle laterally is the rectus capitis anterior. Number one. Sometimes the pulsation in this region terrifies you. The pulsations are all transmitted pulsations, for that matter. It is very, very rare to have carotid medially projected in the nasopharynx. We know lot of publication, lot of hear about the, the tortuosity of the carotid. Let me tell you how this tortuosity is. We have studied so many times in our dissection. The parapharyngeal carotid first below lies in lateral relation of the tonsil. Then it rises up. In lateral relation of the tonsil, majority of the loops, kinking, all coils of the carotid are in region of the tonsil, that is in the lower parapharyngeal space. There could be coiling, kinking, whatever to the carotid that can happen in that region. After crossing the lower parapharyngeal space, the carotid runs towards the carotid foramen, that is the temporal bone. And in order to run towards the foramen, it straightens up to run towards the foramen. And this is the area in the nasopharynx, the upper parapharyngeal space, where the carotid straightens up, because immediately above is the carotid foramen. So all those kinking, loops, all those things are likely to be in the lower parapharyngeal space, not in the upper parapharyngeal space, for that matter, number one. Number two, see, let me show you the muscle. Here, see laterally, that is the peak of the, give me some instrument, curved instrument, suction. See, there is hardly any bleeding, no bleeding at all. Panjal. People have a fear of bleeding in this, lateral space, with a fear of damaging so many vessels, no bleeding. See, far laterally here, here is the, the peak of this, this thing, the fossa of Rosenmuller. The carotid is 1 centimeter behind and lateral to it. Got my point?
Yes, sir.
And this muscle, this lateral muscle is a very thick muscle, is a rectus capitis anterior muscle. This is longissimus capitis, and this more than a centimeter thick vasculature separates from the parapharyngeal space. It is not carotid. First is the parapharyngeal space. And in that parapharyngeal space, the thickest area, the thickest thing which separates the carotid is the stylopharyngeal aponeurosis.
Yes,
the thick stylopharyngeal aponeurosis, if you do many a times when we do the endoscopic parapharyngeal tumor excision, believe me, it requires a lot of efforts to cut through the parapharyngeal aponeurosis. Stylopharyngeal aponeurosis, there is a thick sheet of aponeurosis that you have to cut through. Then there is a thick sheet of periosteum of the carotid, particularly before it hits the temporal bone. So this upper parapharyngeal space, paranasopharyngeal space, has a thick layers of structures over the carotid. And it really, even if you want to reach to the carotid from here, it calls for a lot of efforts to reach that area.
Okay. Okay, sir.
And for the adenoids, for that matter, for the adenoids, we are using our debrider. I told you, let me show you. We are using our debrider, that too under vision, like this, pressing on the muscle and allowing the, the adenoid to get sucked into the blade. That is such a simple, safe procedure without anything poking far laterally where the carotid can be. I hope it is clear.
Sir, here I have a question. If there are no ear complaints, no eustachian tube obstruction, still you will go so laterally to clear the disease?
So, what you are going to achieve without doing it? Once you are doing adenoidectomy, why you want to, leaving a possibility of coming back to remove the adenoids again? If you do it properly, there is no harm into it, and it gives a complete, complete clearance. See, the adenoid otherwise, in the same way, keep responding to the allergy and infection, keep giving the same symptoms, same problem, and at some point of time will again get hypertrophied. Okay. So in order to avoid the future problems, this is, we call it as a comprehensive adenoidectomy. See this under vision. This is on the opposite side.
Okay. So Satish, all those complications and calamities you mentioned can happen if you are using a reverse cutting blade of the microdevice.
Yeah, because then you don't have a control over the cutting edges.
Then
that's
you can
why
pass all the layers. Yes.
That's why we always condemn a so-called adenoid blade which is produced by the Medtronic. Use it. I am going to show you in the next case when we are very soon we are going to take a revision phase, and I will show you the utility of that so-called adenoid blade. We
So
call
what
it
about
as a skull-based blade.
Yes, sir. So few surgeons have this queries on the submucosal cleft palate. What precautions will you take, sir, for these patients?
Yes. See some of the vessels, small. Submucosal cleft palate is a cleft palate. It's a pure cleft palate, and it has to be treated like any other cleft palate for that matter. And once you are treating with any otology pathology in a cleft palate patient, you have to be careful, because all these patients may have a eustachian tube malfunction, because the muscles which regulate the palate or the eustachian tube may be not very developed because of the cleft, and then that may have an impact on the outcome of otology surgery what you do. That's why you have to be careful in all patients having cleft palate when you are contemplating any otology surgery, keeping the eustachian tube function in mind. See now. See the lateral muscle. Can you see very clear?
Yes. Oh, yes.
See my cutting edge with me. I am not poking in anywhere. That is something at lower speed, under vision, and you can certainly clear the fossa Rosenmuller completely. And this is what is expected from a comprehensive adenoid. I don't care about this little bit of the bleeding I told you earlier. I've shown you on the other side. This is bound to stop in no time.
So Dr. Jeevan Vedi has a query here. What will you do if there is enlarged tubal and lingual tonsils?
So this is tubal tonsil only, what we are removing. See, this Walder ring has many components. What we removed in the midline was the nasopharyngeal tonsil, that we call it as an adenoid. Then laterally in relation to the tube are the tubal tonsil. Then below, relation to the palate are the palatine tonsil. Then relation to the tongue are lingual tonsil on the base tongue. So these are the terminology. That is a part of the Walder's ring, and Walder's ring has an impact on has an immunological impact in the children, combating the frequent upper respiratory pathologies. So the goal is, see now, once I settle this oozing here, my goal will be complete. What I am going to achieve after this? First of all, comprehensive clearance of the adenoids to prevent the situation of so-called recurrence, number one. Number two, preservation of all surrounding structures. See my eustachian tube orifices on both sides.
Yes.
Pretty
Absolutely.
untouched, without any damage to the torus or anything.
Yes, yes.
And secondly, see the perimysium. Stand out perimysium all the way.
Bulging. Yeah.
Bright. As long as your perimysium is intact, your musculature is 100% safe behind. Now, when I've been using the cobblator and tried to remove adenoids, I had two options. One is to remove the adenoids from the surface without going to the perimysium, so as not to damage the perimysium, leaving some adenoid tissue, or to go in the perimysial plane, inevitably charring the muscle behind. That certainly those things can be avoided. See, this kind of perimysium achieved by any other thing than the microdebrider. That's why this technique, you may face some difficulty of controlling a little bit of the oozing. Believe me, our junior most, guy in our hospital is doing this adenoid surgery with the same efficacy, without doing any problem. So it requires for little extra time, number one. It requires for little extra safety, and that is what expected from a surgeon to give a long-lasting, morbidity-free outcome to the patient. See now the perimysium, amazingly standing out perimysium, and see this is planned charring, coagulation of the periosteum, which I don't want. That is the site of bleeding. Muscles contract, periosteum do not. And that is the source of bleeding in those patients.
Yes, sir.
My coblation was used intermittently, you have seen, for the oozing. See the fossa of Rosenmuller now? Completely opened up. This minimal bleeding will take care. And this warm saline has a huge impact. We have done through this technique thousands of the adenoids. See the fossa of Rosenmuller for everybody.
Yes.
Can you see anywhere any residual adenoid tissue now?
Absolutely clean. Satish, absolutely clean.
No fear of bleeding. Where is the huge bleeding?
Satish?
Yes, sir. Yes.
Satish, in an adult patient, if you have a nasopharyngeal mass, okay, just a quick word on it. How will you clinically diagnose what it is and radiologically? I mean, just some features for the youngsters.
Adult with a nasopharyngeal mass.
Yeah.
My MRI will differentiate what it is, Narayan.
Yeah, exactly. Just enumerate it for the juniors.
So MRI with a diffusion weighted sequence will clearly distinguish what kind of mass it is, whether it is benign or malignant, because many of the nasopharyngeal masses are lymphomas, which I can almost always pick up with a diffusion weighted MRI only. Lymphomas are most cellular tissues, most cellular. Out of any tumor in the body, out of all tumors in the body, lymphomas are most cellular, and they show the highest level of restriction of diffusion on MRI, and you can pick up solitary, the lymphomas very, very clear. And then you don't have to, once you know could be lymphoma, you are not supposed to do any radical surgery. Your goal is to take a biopsy, get immunohistochemistry done, and then direct the medical therapy over it. So, the imaging has a big role. Now see the final picture. Can you see?
Yes, yes, Satish. Very good.
See my goal of adenoidectomy. Both sides, torus intact, completely eustachian tube intact. This is my soft palate, completely preserved. This is my perimysium, completely preserved. This is the periosteum, is coblated. And these are the fossa of Rosenmuller, which are completely cleared off. And without giving any charring to the muscular area, I don't expect any sort of nasal twang or any sort of, stenosis, any sort of infection, any sort of too much of what you call that as, slough and anything is not expected from these children. So a right technique is required to prevent all these issues, and see, we all are striving for the betterment, and this is one of the propositions from our side, and this is our, time-tested technique which we have been doing for years together to prevent problems in these children. You can just do it, send these children back home in the evening and forget about anything. What we do post-operatively, that is our set protocol, because we are all, concerned with the allergy and the inflammation. Post-operatively, we get a complete allergy workup done. We get a complete immunology workup done, as many of these children are immunocompromised, which go undetected, and then completely follow that treatment. And as far as the medical treatment is concerned for long term, we give them mometazone nasal spray and Montelukast. Montelukast has turned out to be a major drug for the lymphoid hypertrophy. It has been proven by the literature, even by the meta-analysis now. Now I am, irrigating the nasal cavity.
So,
see, there is no trauma, hardly any trauma. Yes.
Satish, just ask you about if there is a infant, let's say 1 year or less, would you be adopting the same technique, number one? And would you be adopting the same technique even below 1 year of age?
Yeah, see, little different in the sense, in below 1 year, the only indication is obstruction. There is no other indication to do an adenoidectomy in a child below 1 year.
Exactly. I'm talking, there is an indication, obstructive lesion, and we have operated many kids below the age of 1 year. So that's why I'm asking that question, because we
in
do a
that
different
situation,
technique.
yes, you can avoid the lateral adenoids in a 1 year below child, except that everything is same. Only thing is the lateral component can be avoided because in below 1 year, the concern is the obstruction, which you can obviously accomplish by the midline removal of the adenoids rather than doing laterally hypertrophic and giving more operating time, more morbidity, more blood loss to those children below 1 year. So you can stay in the midline for those.
Would you like to then to use a coablator for such children, or would you like only this, or have you used a coablator in infants?
Yes, coablator, very well. See, this use of microdebrider in those children, the 10 to 15 second use of microdebrider and packing, that's it. That doesn't lead to more than 5 ml of bleeding. Believe me, only once use, but it gives you a confidence, it gives you a security that you have not damaged anything behind, because that is our concern.
I agree, but I'm just talking about now the people who are infants. I'm just talking about a particular set of people.
Yes.
And second, I'll ask you about the second set of people is the Down syndrome. Would you be using the same technique?
Which syndrome?
The Down syndrome.
Yes. Those children, we don't go so extensively.
Because in a coablator, you can be extensive.
Yes.
That's the reason
With
I'm asking.
Coablator, because Down syndrome has many implications as far as the adenoid is concerned. The anatomy is concerned.
Yes.
There could be aberration in the anatomy of the carotid artery, could be aberration in the anatomy of everything around. So you have to be very cautious, you have to be limited, because the goal is to just give airway and then follow with the medical treatment rather than going so extensive.
Because with the coablator, you can go more extensive with a better removal. So just wanted to put a point in view, nothing beyond that.
Yes,
but excellent. I mean, I'm amazed at the way you operate, and it's an excellent presentation, of course.
Thank you, sir. Our next case is ready.
That
is a microlaryngeal surgery with a laser. Yes, Paramita, we can carry on with the question.
Sir, is there any adverse effect on immunity of patients after adenotonsillectomy? Dr. Sudeep from Jodhpur is asking.
Yes, that is a very important concern, and that used to be a big, question from the attendants as well. That this is a part of the immune system, and it can have an impact on the immunity once you remove this part of the immune system. See, this is not only the immune system in the child. This is just part of the Waldeer's ring. And the adenoids normally, which do not give rise to any problem, are not need to be removed. Only those adenoids are harboring biofilms, giving problems, giving immunological problems, giving obstruction, giving sinusitis, giving ear problems, those need to be addressed, which are actually not serving their own purpose. And that's why they need to be knocked off. Adenoids harboring biofilms, adenoid harboring so much of immunoglobulin E or something are giving problems and need to be removed. In normal function, adenoids synthesize immunoglobulin A. Almost 15% of our total body immunoglobulin A is secreted by the adenoid tissue only, because 60% of the adenoid is B lymphocytes, But once they are affected by the inflammation and the allergy and get hypertrophic, involved in the infection, they no longer serve their purpose. So we have to convince them. Many times the patient relative come and ask this question up front. You have to counsel them. आपका चौकीदारी चोरी करेगा तो क्या करोगे? This is something like that. See, you have to knock them off once they are not serving any purpose and rather creating problems. And there are many, immunogenic tissues in the body to take over that function rather than adenoids only.
Okay. So many were actually requesting to have an external view of the endoscope and the debrider that you've been using. So maybe...
Satish, good morning.
No.
Good morning, Satish.
Yes.
Yeah. See, in my experience, I have seen when conventionally they done adenoidectomy, the damage the station tuberifeous area, and that would have caused stenosis and synechiae, and that permanently damages the station tuberifeous, and then they'll have a lot of ear problem for lifetime.
Yes,
so, in such situations, do you have any solution for this once you get such cases?
That is, your concern is very important, and because of that concern, I am not using anything carrying this problem. Believe me, if anybody going in the fossa Rosenmuller with the cobbleter and try to remove the adenoid extensively, completely till the muscle surface, it will end up giving, you know, I would say extensive fibrosis, irreversible fibrosis once it heals up, and that is something difficult to treat. That's why, for that reason only, you are using the debrider and, you know, paying the price of this extra little bit of the bleeding to prevent that complication. Now, there is no charring. The healing is so amazing, with everywhere the perimysium intact, muscle is not damaged at all, and there is no question that kind of fibrosis or stenosis.
Yeah, now what you did is excellent. Suppose if you get a case where it has been done by a surgeon by conventional technique and it has been damaged, do you have any answer for that?
Yes, if you have happened to damage that area, what you can leave for the time being, you can leave a piece of silastic and pack for some time, and then you can come back and remove and give lot of irrigations in the post period to prevent that stenosis, to minimize that. You cannot prevent that, but you can try to minimize by doing all these things. But I am not sure how they are going to help it or not. But this is something we have never done.
Okay. Satish.
Yes, sir.
Satish.
Yes, ma'am.
So we had done a study once where we first did a blind curettage of the adenoids till the surgeon felt that he'd done a complete job, and then we used an endoscope to see what is residual adenoid tissue was remaining behind, and as to whether there was any damage to the eustachian tube. And what we found was that we didn't find a single case of damage to the eustachian tube, because the surgeons tend to remain away from the lateral and
Yes.
stay only in the midline.
Yes,
And
ma'am.
therefore, always there is tubal tonsil remaining behind. And right at the very apex of the nasopharynx, close to the posterior end of the septum, is where the tissue remains behind, because the curette doesn't have an angulation which reaches almost up to the posterior end of the septum.
No blind instrumentation can achieve this kind of clearance.
Yes, yes. And therefore, the two main areas we found were the tubal tonsil and very close to the posterior end of the nasal septum on the absolute roof of the nasopharynx.
Yes, madam. Agreed. Absolutely.
Sorry, Satish, because a study has just been quoted. We'll quote our thesis study also,
Yes,
in
sir.
which we compared microdebrider versus the coablator, right? And we did a post-operative flexible laryngoscopy. That's a nasal examination, seeing for the fibrosis, especially and all that. None of the patient had a fibrosis as far as coablation concerned. On the other hand, I did not use the same technique as you using. We were doing the adenoidectomy as such. Some of the tissue was left with the microdebrider, because during the surgery, this is what I'm rightly so. That's the reason why we left doing that adenoidectomy with the adenoidectomy blade as such, provided the Medtronic, because somehow or the other we used to enter into the paramecium. The bleeding used to be far more, and we found the coablator far a better technique than the technique that we were using. Your technique is very good, there is no doubt, but I think the coablator still has a good place if a person learns it well.
Coablator is amazing tool. See, if you find anywhere some excessive bleeding or anything excessive oozing anywhere in the field, you can immediately use coablator. Such an amazing tool. I've been using coablator in a skull base like anything as a main tool.
I know you've used it extensively.
Coablator is amazing, but here once it comes to function preservation in these children, we are little scared about fibrosis. That's why we are giving preference to the microdebrider. On the other hand, these are different tools, different advantages and disadvantages. We cannot compare them. It is like comparing apple with the orange. These are different tools at all.
Right.
Coablator has a different ability, microdebrider has a different ability. We cannot compare them. Both are so useful. Only thing is, in our practice, how we can get best of the results by optimum use of both of these tools. Both are equally good. Both are amazing. I am not saying any tool is bad. We have to decide ourselves where can be used, what tool can be used where, and with the optimum results.
Sir, there are few surgeons who also want to know the preference of Dr. Kirtane, sir. So there have been few questions. So what is your preference, sir, on this?
Sir.
No, we,
Kirtane, sir.
Like what Satish has shown, we use the microdebrider with a 60 rad blade. The only difference is I do it per orally. We put catheters, just lift up the palate and use a 70-degree scope through the mouth. So I don't have to go through the nose and worry about damaging the nasal mucosa or synechia. And I think even there, as Devinder said rightly, the tip of the blade can remain under vision without any problem. Satish, just one quick question. Can you tell me what are the next two cases that you're going to do? So I'll tell the...
Sir, so our next case is going to be a microlaryngeal surgery, a benign lesion, benign nodule, and then would be a revision phase.
Okay, and after that you'll start with the parapharyngeal tumor?
Pardon? Yes, after that would be a parapharyngeal tumor.
Okay, fine. So I'll inform the concerned people accordingly that Dr. Devendra Chowkar can come in at that time.
Yes, sir.
Sir, how long will you prescribe Montelukast post-operatively?
Yeah, Montelukast at least for few months, because meantime we work up for the allergy and the immunity.
Okay.
Many children who have a history of repeated, infections, we get the immunoglobulin levels done, and many times we found issues in the immunoglobulin levels as well. So allergy, many times adenoids are associated with the house dust allergy, They have a family history of allergy, and you will find if you elucidate the family history of the children, many a time you'll find a clear-cut association of allergy in the parents, and that is how the adenoids are, given in the children because of the allergy which is transmitted.
Okay.
So allergy, yes.
Sir.
So we are all set for the third case. Paramita, you can carry on questions.
No, sir. I just wanted to tell to the viewers that the ones who have joined late, the talk on the scope and the type of blade has already been described, and many more questions that they've asked has already been described. So I think we'll move ahead with the next case, and the ones who have missed, they can again watch the video later. Yes, sir. We can move on.
Yeah, it will be available on YouTube.
Yes.
Regarding the laryngoscope, there are a variety of laryngoscopes, needed in different situations. We have almost 16 variety of scopes. And this I learned from Nupur, who has even more. In what situation, what kind of laryngoscope, the advantage, disadvantage. Is Nupur online?
Hi, Satish.
Hi,
I
Nupur.
think, having an array of ML scopes is great, but for people who are starting out, there are two laryngoscopes I would suggest. One is the regular Klein-Sasser laryngoscope, medium size, because our Indian population doesn't really need a large size even for the adults, and a small size. And the other is a Dido laryngoscope, which I find has saved me in a lot of difficult situations. That's a Storz scope. I'm not trying to market for anybody at all, but it's a scope which has really helped me out in many occasions. So to begin with, I would say these two scopes are great to have, small and medium size.
Yes. So last time in microlaryngoscopy, we showed a T1 vocal cord cancer and did a cordectomy, type 4 cordectomy with removal of the muscle, part of the muscle. We have now in the coming webinars, we'll be having a variety of laryngeal situation, type, the grade 2, grade 3, grade 4 cancers with different approaches. This time here is a very simple situation, very common, which Sir had asked me to keep, which is very, very useful in our regular practice, is a benign nodule. Are you getting the picture?
Very clear.
Very clear?
Yes.
So, this is a benign laryngeal nodule in a person who is not actually a, professional voice user, but he had, when I elucidated, had a history of voice abuse. This is not a classical nodule which you will see in a patient with a voice abuse. Nupur.
Satish, if I may suggest, we should not use the word nodule when we see this kind of
Yeah, this is
lesion
not
on a
nodule
striking
actually.
zone,
Yes, exactly.
because the classification of benign lesions has been made quite nicely. Nodules should always be the typical bilateral at the striking zone. So benign lesion at the striking zone, or a vascular lesion at the striking zone, because when we say nodule, most of us think of typical nodules.
Yes, exactly.
You have a feeding vessel for this lesion coming from anteriorly.
Yes.
Many surgeons would make comments that they would like to do subepithelial infiltration and do a laser fulguration of that feeding vessel to decrease the chances of recurrence. What are your thoughts on that, Satish?
Yes. That is something, one way. And Nupur, since we have to show various techniques and variety of situations, this nodule, this lesion, my question to you is, would you go with a cold steel or with a laser, and why?
That is exactly what
I am going to show with a laser here.
Right.
For that matter.
I think vocal outcome measures would be equal in the. It depends on the surgeon's hands and capabilities, etc. But one can achieve fantastic results with cold steel as well as laser, as long as you have a good quality laser, as long as you follow the phonosurgical techniques of infiltration, elevation, staying superficial. The only issue is
and I am not going to do anything.
The only issue is the feeding vessel. A laser would have the advantage of being able to just, what we say, laser fulgurate it at one or two, like spot welding kind of thing at one or two spots, so that the feeding vessel is also taken care of.
Yes, agreed. So now we'll have variety of benign lesions and we'll be showing it differently. Here I am showing in the most, raw way, without infiltrating, without doing anything, with a simple laser, with the principle of minimal wattage of laser. I will tell you the advantage. I can use a high wattage, high depth of the laser, but here I am going to use the minimal wattage with a minimal length. The reason is, I am going to stick to the superficial lamina propria. Can you see the laser beam?
Yes, sir.
Yes.
See, this lamina propria has 3 layers. See the most lateral, the superficial epithelium, then in the superficial lamina propria, then in the intermediate lamina propria, and the deeper lamina propria and the muscle. So here I am going to say very superficial. See the minimal watt. Why I am saying minimal wattage? As not to damage anything underneath. I am retracting it medially. This is the simplest of the benign vocal situation, not I would say lesion situation, you can think of. Pulling more and more medially, and this is the minimal wattage with the depth 1 I have kept. You can see.
So
see my lamina propria opening up.
You're using an acu pulse, are you not?
Yes.
Right. So are you at 10 watts, Satish? You're using a scanning system or a non-scanning?
Yeah, scanner.
So with the scanning system, you're using, ideally we use, so just want to clarify here that when we have a scanning system, typically we don't use a low wattage. We have to work with the fluence of the system. The fluence is the wattage, the depth of the penetration, the time on and the time off. These 3 parameters give us the fluence. And because a scanning beam is scanning a surface, we don't have to use a minimum wattage of 1 or 2. We work with 10 watts because it's
minimal is 10 watts here once you use a super pulse.
Excellent. And you're using one depth, which is not 1 mm, but 250 micrometers.
Yes.
And probably your speed on and speed off may be 0.03 and 0.3. I don't know.
0.3.
Yes. So wonderful, not a dot of char. What a wonderful job you've done. We've got a completely straight vocal fold. There is no charring whatsoever, and very efficiently performed surgery.
See, what I wanted to show here is
excellent.
What I wanted to share is, by pulling it medially, I didn't inject any saline or anything. I just tried to stay in the superficial lamina propria. And that is something which is something which has the least chance of giving any kind of scarring. If I go in the depth of the lamina propria, I may leave some scarring, you know. My goal, because I told you this was the simplest of the lesion one can think of. And in such patient, you can expect a very good voice immediately after the surgery as well. Because I just went through the superficial layer of the lamina propria. Can you see, Nupur?
Yes, fantastic. You've shown very important points, that you stay superficial, that you do a surgery which is totally char-free, so there's no heat dissipation. Patient will do excellently. I don't know whether you believe in voice rest or not, but this patient will do excellently. And you'll probably want to give some voice therapy so that there is no recurrence because of vocal abuse and misuse pattern.
See, the beauty of the laser is, and particularly with this scanner system from Luminous, you can target the lesion the way you want. Had I been doing some, chordectomy like you saw last time, I was using a continuous, power with a power of 14 and was a continuous laser, and I could go all around the lesion. That was a different pathology, different aim, everything different. Here the aim is preservation of voice. The sole aim is preservation of the voice. More you traumatize the vocal cord fold, vocal cord layers, vocal fold, worse the results you are going to. My goal was just to stay in the superficial lamina propria and get away from this. That's it. I could do with the cold steel as well with the similar results. What do you say? Any difference in outcome with the cold steel with such a lesion, such a superficial lesion?
I do not think so. Just the feeding vessel, one may or may not want to laserize.
That could trouble. That could trouble.
Yeah, but I don't think there would be any difference whether it was cold steel or laser. One can have equally good results.
Yes. So this
was. I want to ask the panelists and to you especially that what precaution will you take now during this COVID pandemic situation while doing these airway surgeries?
Same. Yeah, a lot of people are recommending respirator. There are many ways. We are just using level 2 PPE, not respirator. For that matter, we have a suction evacuator attached to the laser at the same time to prevent the fumes coming out. That is the only thing we are doing. Otherwise,
Paramita, ideally one should use a PAD air purifying respirator. I really think Satish also should.
Yeah, you sent me that picture, I remember.
So there are two varieties. One is you get a type where you have a helmet with the HEPA filter on the helmet itself, and the other is where you've got the HEPA filter on your waist. So you can choose whichever type you want. We have all varieties, and the reason is because we as ENT surgeons and especially airway work and laryngology are directly in the line of fire, so to say. So not only is it very safe for you, but also you are not experiencing hypoxia of any type. Now, someone like Satish who's operating from morning to night, he obviously cannot be wearing an N95 and surgical mask and operating. But if he wears a PA5...
I am wearing N95 and surgical mask.
but with a PAPR, Satish, one would be so much more comfortable because it's positive air, simply for that reason. So I encourage you all to do that. The advantage with the PAPR on the waist is that people can share it because the hood is disposable. It's a 500 rupee hood which you just throw. So you can have colleagues sharing it also. So, there's a company in Bangalore which makes it, and the other one is in Bombay. Anyone interested can email me.
Nupur, can I ask a question?
Satish, congratulations. Sure.
Thank you.
Super job is what I wanted to say.
Thank you. In the last LChem, conclave last year, Nupur had demonstrated some phenomenal surgeries from Bombay Hospital. And Madhuri Madam demonstrated from, I remember, from Hisar. And you demonstrated one micro flap as well.
Yes.
Remember?
Yes, I do.
My question is for the audience, when do you recommend a micro flap technique in benign lesions of the vocal cord? Maybe a nodule, maybe a cyst, or maybe other benign lesion. Whatever you classify.
So you can call any lesion which is epithelial. Obviously, you would be taking the epithelium off. So even though papilloma is a benign condition, we are not talking about that. Nodules I've hardly ever operated on because I feel they all respond well to therapy. But polyps and cysts especially lend themselves beautifully to microflap because they lie underneath the epithelium. They may or may not be attached to the ligament, but they lie in the SLP and they lend themselves beautifully to microflap, classical microflap. In polyp surgery, Satish, what we are doing is we create a microflap, but we've realized that the larger the polyp, the more the redundant epithelium. You don't have to bother to save it all.
Yes.
So only you have to save the infra, like you did a polypoidal lesion right now. One only has to make the effort to save what we call the infraglottic epithelium, barely 1 to 2 millimeter. You know what is lying on the undersurface. If you just save that, it drapes beautifully on the raw edge, so you get a zero raw edge. So that is more important. So we do microflap in sort of, modifications of it. So you're just trying to make the raw area less.
Okay, ma'am.
Satish, can I just add to that?
Yes, please.
Yeah, just when we talk about microflap, essentially we mean that microflap dissection, not microflap reposition always, as we have earlier thought. In early 80s and 90s, people thought microflap is synonymous with elevating a flap and putting the flap black completely, like Nupur said. But now microflap means that if you think the lesion is deeper and if you're going to be working in the superficial pinky space, then you want to dissect it as far as possible, and then whatever redundant mucosa is there, you remove it or you can reposit. So not always, it is the dissection which is microflap, it is not the reposition which is microflap always.
Ma'am, I will come back to you again about the voice rest. As you said, after surgery, for how long will you give and how beneficial it is, ma'am, in this surgery especially?
Paramita, before that,
yes, sir. Yes,
can
sir.
you define the vocal rest, Nupur?
Yes.
Voice rest.
I'm just coming to, there is a dichotomy in opinion to begin with, whether you want to give any vocal rest or not. There's some surgeons who believe in giving zero voice rest, some surgeons who believe in giving voice rest. In voice rest, you can have a complete voice rest, or you can have a patient talk in what is known as a confidential voice. Confidential voice is you're talking one-on-one. There's one person sitting, which is not a whispered voice or a breathy voice. A lot of research which has been done actually shows that the maximum amount of healing which has to take place starts actually within 24 to 48 hours. Okay, and they have done research papers where they've shown one arm which took voice rest and one arm which did not take voice rest. And some of these papers have shown that it didn't really make much of a difference. So I think it's totally on the surgeon to decide whether they want to give voice rest at all or not, because there are enough papers which show the vocal outcomes are the same. I personally like to give voice rest to each and every patient of mine, and I have specific reasons why, and I give it for 7 days. But I tell them for the first 5 days, I want you on complete voice rest. After 5 days, you will start on confidential voice. Start talking 10 to 15 minutes per hour, and every day you double it. So 10 to 15 minutes an hour on the 7th day, 8th day will become 20 to 25 minutes, keep doubling. Why do I believe in voice rest? Because I feel Indians talk too much and they talk too loud. And this is like a cultural thing, and I feel that the way we talk, the speed with Indians talk is very fast, the volume we talk, and we are a talkative race. So I feel the amount of understanding also, when we say to patients, they may say, we will talk 5 minutes, but they will talk 50 minutes. So in my group of patients, and I feel Indian patients in general, better to tell them voice rest. By default, they're going to be talking a little anyway. That's my take on it. Satish and Amitabh, I would love to know your take on it.
Yes.
I think for me, it is just slightly different. Only instead of 5 days, it's 72 hours, 3 days absolute voice rest. And rest of the things are all fine, but it is also important to customize the voice usage depending on the patient, because a person who is going to sell fruits in the market will have a different kind of a voice rest, and compared to a person who would be working in an environment where he's doing board meeting all the time with microphone on. So that is the only thing I would consider, that to customize. But first 3 days for me, absolute voice rest for the epithelium to heal and not to have any hemorrhage and that because of strain, and then gradually take it over depending on the plan. We call it planned returning to voice. That's the term that we use depending on their profession.
Dr. Yogesh from Erode is asking what size of endotracheal tube are used for microlaryngeal surgery? Is there any specific that you would like to say, ma'am? Sir?
Typically 5 and 5.5. I mean,
Okay.
5 for the female adult, 5.5 for the male adult. Of course, in children, you will go 3, 3.5, depending on what is the age of the child.
For the
And
last
these
case,
are
so
with
what
a
I
larger
used was a
cuff.
laser tube.
Okay. Sorry, sir?
The last case, what I used was a laser tube. It was
Okay.
5.5.
Okay.
And this laser tube has two, bulbs to inflate. One containing methylene blue and one saline. And this is
Okay.
what the advantage of the laser tube to prevent a laser fire in case the laser by mistake fires at the bulb. Still you can appreciate as the first bulb ruptures. That is the advantage. Nupur, before we move on to the next case,
Yes.
any tips to deal with the scarring,
Yes, to prevent scarring is more
No,
important.
the scarring has
than
happened to occur.
Okay, so if the scarring, you catch it early on, then injection of steroids into the superficial lamina propria and even injection of hyaluronic acid may help because there is some amount of growth factor also in it. So a combination of hyaluronic acid and steroid into the SLP area after 3 to 4 weeks when you catch the early scarring. You can even do 4 to 5 repeated injections of this in a prevention of. If it is very long term, then of course you're talking about like a scar or sulcus which has formed, then growth factor injections, which are not always available, but they are available in certain situations. Injections of growth factor into the superficial lamina propria have been described. You can also do things like fat implantation, small pieces of fat, you chop them up, or fat injection into the SLP. So these are options for scarring, early and late.
Okay, that's great. And I think it is a very, very difficult problem to treat for anybody.
Yes.
And it requires some repeated efforts.
Yeah, prevention is always
the best thing.
Better.
Thank you, Nupur. Thank you.
Thank you so much, Satish. Wonderful being with you.
Thank you.
Thank you, ma'am. Thank you so much.
Thank you, Paramita. Thank you to Dr. Kirtan.
Always a learning
And Alchem.
experience when you interact with Nupur, and it is something amazing. Thank you.
Thank you. I would like to thank Sir and Alchem. Thank you.
So now we move on to the next case. And are you getting some
Thank you, Nupur. Thank you very much.
Are you getting something on the screen?
Yes, we've got the CT picture there.
Okay. So this patient has undergone sinus surgery somewhere a year back and now presented with a full-blown disease. And you can imagine what kind of the work was done. It was something like a polypectomy or a little more onto that. Nothing much. For sinus surgery, when we discuss, so this is for revision. The most important thing is the planning. Planning from diagnostic point of view, not only the scan gives you a roadmap, but other planning to go into the, the pathophysiology of the disease. Like we discussed in our first webinar, you need to get certain tests done to find out the particular endotype of the sinusitis. If you find the particular endotype and follow it, then only you can expect a good result, because this is a medical disease for which the medical treatment is the treatment. Surgery has a role to facilitate the medical treatment most of the time. Like many of the patients, we have shown the allergic fungal rhinosinusitis. It has a different endotype because the patient has a allergic to the fungal antigen. AERD is a different endotype where the patient has a fault in the, the arachnoid acid metabolism, where a lot of leukotrienes forming. So there are a lot of endotypes, and you have to actually go into the pathophysiology to get good outcomes. And when it comes to surgery, today here we are going to discuss the surgical aspect. The most important thing is the surgical planning, and for which the radiology is most important. And the simplest radiology what we need is a non-contrast CT scan. CT scan gives you a path like Google Map, believe me, provided you have an adequate and optimum radiological investigation done. So we always recommend, or whenever we order a radiology, to get the entire data in a DVD in DICOM format to get complete three-dimensional dynamic information. And this is what the need of the time. The reason is, when patient bring you some films, like 1, 2 or 3 plates, having 15 to 20 slices, almost 50 to 60 slices is too inadequate an information. Here in this particular patient, if you see, the 0.7 mm scans done, this area of the paranasal sinuses when you scan is almost 20 centimeter or even more. 20 centimeter means 200 millimeters. How many slices you need? For that matter, in this particular patient, even scanned even a bigger area, and you know, in the axial section, these are always shot in axial plane. See now, in the axial 423 slices. Imagine how much the data it has been having, number one, to give us complete information. Secondly, we need this information in all planes. Now with the DICOM format data, we can easily reconstruct through our software. See now, I can reconstruct in 3 planes, like axial, coronal, sagittal, and you can see every structure 3-dimensionally in each plane. And that is an amazing tool to have in your mind the 3D picture of the anatomy of the particular patient, about the disease. And this is an amazing teaching tool as well to teach the colleagues that how to read a CT scan as well in all planes. So this dynamic information cannot be achieved with the plates in hand, with the printouts. And number 3, the information in different, window settings. Sometimes you have an information in bone window setting, you want details of the soft tissue window. From this software, you can easily change into different window settings. From bone window to soft tissue, this is soft tissue window now. See this, the soft tissues are seen much better than what earlier. Now I can change to the bone window. Now the bone is more prominent and seen better than the soft tissue. You can yourself reconstruct. If you have a printout, you need 400 slices in axial, 400 in coronal, 400 in sagittal, 1200 in bone window, 1200 in soft tissue window, 2400, and to carry those slices, patient will have to carry a huge bag, which is not possible. And that too, not a dynamic information. That too, impossible to read for a surgeon. That's why the first message is to get the information in DVD, a complete fine section in the axial plane, and then we can reconstruct our own. See the soft tissue window setting. You can see all soft tissue details better, and this is otherwise you don't get in bone window setting. So this is the first thing, what kind of a CT scan is required, and then quickly how to read in dynamic fashion. Earlier we used to follow each and every structure in a static way from one film to another, that this could be the drainage pathway of particular sinus. Let me show you how easily you can see the drainage pathway of any particular sinus in all planes. Let me show you in all planes. For example, the frontal sinus for this particular patient. For this frontal sinus for this particular patient. See, this is the, if I come from anterior to posterior, this is the beak, the nasal bone anteriorly, the beak behind, and see the 2 frontal sinuses with unequal, appearance because of the intersinus septum. Now, how to see the drainage pathway, whether it is medial, lateral, where it is going? You can easily see. Let me show you on the coronal first, then we'll go to the all planes. See this, I am going behind, this is my frontal sinus. Now see this additional septation coming as I go behind. I am going behind. So this is incomplete septa giving rise to this intersinus septal cell. Can you see this very clear? Now we need to know where this intersinus septal cell is opening to. See this intersinus septal cell, and see now this is opening into right sinus. Can you see very clear? You can see it in the dynamic images very clear where it is opening. Now see the drainage pathway of the frontal sinus here. See this frontal sinus, the drainage pathway of the frontal sinus as you go behind, this is frontal recess. This is incomplete septation, and this is your drainage pathway medially. So for every sinus, see this frontal sinus, this is opening in this intersinus septum, is opening in the frontal sinus, and this is the median drainage pathway of this, the right frontal sinus. This is median drainage pathway. Why? This is the agar cell which is going up and inserting onto the, lamina papracia, and this is your middle turbinate, and this is your medial drainage pathway. So, about the cellularity, about the drainage pathway, every information you can get in a dynamic fashion when you have a good dynamic, CT scan. Now, going back to the soft tissue, see the advantage of soft tissue settings. This is soft tissue window. I am coming from anterior to posterior. Now, the soft tissues are better characterized, Now, look into the orbit. What I want to show in dynamic way. We all know, we want to see, it may be a fascination, it may be a requirement, whatever. We every time want to positively identify the course of the internal anterior ethmoidal artery. Best is go to the soft tissue windows. Why? Go to the orbit, because we know the intraorbital course of the anterior ethmoidal artery, where it comes out, is given up by the, I showed in one of the CT angiogram in a Jain case in one of our previous webinars, how to trace the ophthalmic artery, and from ophthalmic how to trace the anterior ethmoidal artery going to the orbitocranial canal. So as it comes out of the orbit, as I go behind, this is medial rectus, this is in soft tissue setting, this is superior oblique, and as I go behind, see this, as these two structures come close to each other, see here, this is the canal, that is the coning of the orbit. As these two structures come together, this is the coning of the orbit from where the anterior ethmoidal artery leaves. This may not be prominent always, but yes, if it is prominent, you have to be careful. You have to give importance to it during surgically, that you are not supposed to damage it, maybe in mesentery sometime. This is the way of finding the artery, that's what I want to say. So anything in the sinuses, you can see dynamically if you have a dynamic scan, and that is what the need of the time. Rather than the static picture, I am not going in the details of the reading the CT scan. These are just few points, but in this particular patient, what I see positive finding is a complete whiteout picture bilaterally, complete whiteout, complete preservation of the all septation. You can imagine what was done during the previous surgery, you can think of, and then some, I was trying to see if some heterogeneous opacity to see or to pick up if there is any fungus inside. See, this is the way in the soft tissue window setting. If you find some heterogeneous opacities in the sinus, see, these are the sinuses, and I don't see any major heterogeneous opacities signifying any fungal disease. Can you see this? It is not. Yes. Otherwise, in a fungus, we have shown earlier the allergic fungal sinusitis and those cases where the lot of heterogeneous opacities signifying the fungal disease. So this you can pick up very well on the soft tissue imaging. Then the deviation of the septum, the turbinates, the situation of, all these things are important, because sometimes you have to counsel the patient pre-op that we may have to add on a septoplasty, we may have to do a turbinoplasty. It has its medical legal implication also nowadays when the informed consent is has a value. Then there are some osteitic picture. See this, what I want to show as I go behind, I see some sort of osteitis, patchy osteitis somewhere. Osteitis is something signifying a depot of cytokines. That signifies the huge eosinophilic disease as well, and you have to remove all those septa signifying this osteitis to completely get rid of this, depots of cytokines. Otherwise, the persistence of the inflammation will bring in the disease again, and that is something you need to prevent. We need to see all septations by and large are, protected. Nothing, hardly anything was done during the previous surgery. I can see the turbinates. I can see the pissed off turbinate because of the polypoidal masses. They have been, atrophic, I would say. And then the completely, white out picture everywhere. This is your the rostrum of the sphenoid. looks pneumatized in the center. You have to be careful in these situations because sometimes you look for the sphenoid and you end up opening a rostrum and avoid the sphenoid opening. We have to be careful. This looks like onodi situation this side, and this is the sphenoid with intersphenoid septation, and this is now this is the optic nerve impression. There is hardly anything significant. The only thing is I can see the little bit of the lateral recess on the left side and complete whiteout. So my goal is to do a complete full house FES. Complete full house FES. I will demonstrate here for the sake of demonstration on one side, and then we'll move on to the other case as we have to finish the other cases as well. The other side will not demonstrate, and one of my colleague will finish off the other side. So one side will discuss in detail the surgical part. See again the orbitocranial canal. Can you see here?
Yes.
The anterior ethmoidal artery emerging out of here. This is medial rectus superior oblique, and see how the artery is running. The movement where the artery runs out, this is posterior ethmoidal artery. This is posterior ethmoidal artery. The anterior ethmoidal artery is much anterior. This is here. Can you see both arteries?
Yes, sir.
This is anterior ethmoidal artery, and as I go behind, this is posterior ethmoidal artery. So the another thing is the moment you see the anterior ethmoidal artery and go behind, then is your posterior ethmoid starts. This will confirm endoscopically as well when we operate. Anterior ethmoidal artery runs through the posterior most part of the roof of the anterior ethmoid. And behind that immediately is the beginning of the roof of posterior ethmoid. And this has an immense significance as we work anteriorly into the frontal sinus. We will see the artery is miles away behind. Once you use a 70-degree up, the artery remains behind in a different trajectory because it passed through the posterior most part of the anterior ethmoid. And when you use a 70 degree for the frontal, you are more anteriorly inclined, even anterior to the anterior ethmoid in the frontal sinus. So that kind of fear you can easily remove by means of understanding this anatomical information. So here my goal is to do a full house FES on one side. Any questions before we move on?
Yes, Satish. What is the medical therapy you have given this patient, and what is the timing of your CT scan? When have you done this? Yes. Can you throw some light on that?
Yes, yes. That is very important aspect. You know, this patient has been under pre-operative management for last 7 days. We have given him initially 3 days a broad spectrum antibiotic tablet for 3 days. Then we stopped because our focus was on the inflammation, and these are not infective cases. We have been giving him Visolon for last 7 days. We have been giving him the saline irrigation. Earlier, when this patient contacted before coming, we started the doxycycline as well. For some time, doxycycline has a role in polypoidal sinusitis to reduce certain inflammatory markers in the polypoidal disease, not in the polypoidal, not in the non-polypoidal, but in the polypoidal only. And this is what the medical management we did. He is a young patient, 18-year-old, and without any other systemic diseases. So it's a straightforward case. And looking at the massive disease wiped out with the previous surgery done, our goal was to do a complete full house FES, and then we'll follow post-operatively with the steroid irrigations. So here the goal is a full house FES. Now we'll not leave any opportunity which prevents accessing the sinuses post-operatively in your OPD. We'll open a frontal wide opening of all sinuses because this is pure massive eosinophilic disease which requires steroids. And once you remove this disease, that will make the topical steroid penetrating deep into the cavity. That is what we want. So this patient will not require any systemic steroids later on. Rather, from right now, the locals, the topical steroids are not going to penetrate because all sinuses are choked. Because the only thing which works here in this disease is steroid. And right now, your only option is oral steroids to control the symptom. The moment you do a full house FES, open up everything, and then the topical steroid will penetrate, and then there is no need of giving oral steroid after some time. So that is our goal. So the goal of surgery is not everything, is not the cure. Goal of surgery is to reduce this inflammatory load, to make the topical steroids penetrable, and to facilitate the medical treatment much better than now. That is the goal of surgery. And that is how we have to counsel the patient. If you counsel the patient that will operate, you will be all right, it's a joke. Biggest joke. The role of surgery is to facilitate medical treatment. That is the goal of surgery. Any other question?
Yes, Satish, what is the serum Ig level of this patient?
This patient Ig was significantly elevated, yes. He has a eosinophilia, serum eosinophilia as well. We are going to get the tissue eosinophilia as well, as we are going to take a representative biopsy sample from one of the polyps or some mucosa. This patient immunologically, since is a young patient, operated earlier with this massive disease, we evaluated for the other history. He didn't have any history of asthma, so we ruled out AERD. Any patient with polyp with asthma, we must rule out aspirin sensitivity.
Test. Yes, sir.
That is essential, otherwise you will miss a major diagnosis, a major endotype, because AERD, the kind of inflammatory spectrum in any sinusitis disease, the massive or the most severe is in AERD. The massive eosinophilia, AERD patient, the pathophysiology is in the reason is aspirin sensitivity and the COX hypersensitivity, COX inhibitor hypersensitivity leading to leukotrienes. If we don't correct that, if we operate the patient 100 times, he will come back again. It is bound to come back. So we have to target the pathophysiology. So we ruled out because of there is no history of asthma.
So what about CRP and vitamin D?
CRP was normal. Vitamin D was low, already started in the sachets. Not significantly low, but it was low. We started and CRP was normal. There was no. That's why we stopped the antibiotic. 3 days.
Okay.
We started earlier for 3 days oral, then we stopped.
Okay, sir.
So this is not infective disease for that matter. This is inflammatory disease, which is driven by certain cytokines. It has a, it has its own, the cascade of events leading to this clinical manifestation, and that's why the antibiotics have practically no role. Antibiotics can be used judiciously in the event of associated infection, sometime to prevent secondary infection, post-operatively, and all those situations. But primarily, antibiotics are not the first line, treatment.
So what
you can
about
carry
the
on
dose
question,
of,
Paramita. I'm washing up. You can carry on. Yes?
Yes, sir. So what about the dose of doxycycline and how long? Dr. Rajat Jain is asking.
We give at least for 3 weeks, 100 milligram BD.
Per day.
And this is what evidence says it has a role. It has a role in reducing matrix metalloproteinase is a important, cytokine in inducing inflammation and all. And that is something important. And many of the borderline polypoidal diseases, if managed properly with a appropriate medical treatment, using saline irrigation, judiciously using steroids, doxycycline, vitamin D, many of these patients we can even avoid surgery. But in such massive disease, even if you try to avoid, this is going to come back. The moment this will require steroids and again to control the symptom. That's why in the Western literature, the biggest indication for a sinus surgery now in such polypoidal disease is any patient requiring oral steroids again and again. To me, any patient requiring oral steroids to control his or her symptom more than twice in 3 to 4 months is an indication for surgery to make him use the topical steroids. That's it.
And
so that is a straight away indication now.
Yes, sir. And so the histopathology, as you had said before, that the histopathology is important.
Yeah.
To decide the lifetime treatment.
Yes. The patient always is full of questions. How when you start counseling that you need post-operatively steroid irrigation, you won't need oral. The next question will be how long?
Yes.
You don't know how long. You don't know the profile of the inflammatory profile of the patient. That mucosal histopathology, mucosal eosinophilia will give you the inflammatory profile, how much is the eosinophilia. Like for example, to me, any patient having more than 10 eosinophil per high power field, I'll tell him, boss, you may need even lifetime. And mind it, don't try to get away. The moment you stop, you may develop the disease again. This is severe. So you have to take a call accordingly. This is something like in malignancy. You then know what is the, the immune profile, marker profile, the lymph node profile, the lymphovascular invasion, perineal, so many criteria that you get ultimately in the final histopathology which warrants the adjuvant therapy. So here is exactly same. You can't say anything beforehand unless you have the full information.
Yes, sir.
Yes, so Dr. Devendra Rai, any other different methods by which you would treat these patients pre-operatively or post-operatively, any markers that you would follow? Yeah, you'll have to unmute yourself, Dr. Rai.
Hello, yes. Frankly, I think very extensively placed by Satish.
Pardon,
this
sir?
Exactly. I mean, we have to look for the inflammatory reasons why we are operating and what is the follow-up, because the endotyping is extremely important. I think these are the markers, and we also tend to do that. So I'm totally agreeing with that.
The most of the time, the
yes.
cause of failure in these patients is not the surgical. Surgical, yes. Obviously, in this patient, the inadequate surgery is the obvious cause of failure. With this much of the inflammatory load, what the medical treatment is going to do? So, surgical causes of failure are obviously there, but inadequate workup, inadequate understanding of the disease profile is the major cause of failure.
I totally agree with you, Satish. The disease is basically a medical thing, and the surgery is to just open up the anatomy so that the therapy can be placed on a topical basis rather than a systemic one.
Yes, now the steroids, once you open up, the steroid will penetrate deep into the sinuses.
Yes. So I think we need to understand more medically today. And of course, surgically, yes, surgical skills are required, but medical treatment is at the forefront.
Yes. Can you see the
yes,
picture
certainly.
now?
Yes, we can definitely see.
This is unprepared picture. We haven't used any topical or any infiltration or anything. This is the first picture with the introduction of telescope. Can you see?
Right. You can see the mucin coming out.
Yes. How is the picture, sir?
Picture is actually fine. Good.
Let me do some white balance. Oh, so light come karna. कम करो. Yes, बढ़ा दो. Now see, this is the right side. The preparation, like Narayan asked, is very, very important. So that part of the pre-operative management, to give some steroids, saline wash, some antibiotic, is a different aspect. The goal is, whatever pre-operative preparation you do, pre-op or intra-op, the goal is to improve the surgical field, because this area is rich in vascularity, and too much of bleeding intraoperatively will prevent identification of your landmarks, and that is the major cause of either the disease, leaving behind the disease, or inviting complications. So the goal is to improve the surgical situation, and that's how the preparation starts way before. This intraoperative preparation is equally important. The reason is, in this intraoperative preparation, you have to further improve the mucosal condition, because this the bleeding in this surgery is mostly because of the capillaries, not because of the larger vessels, unlike tumors like Jain and others, which are solely, where the source of bleeding is solely the larger vessels, arteries. Here are the capillaries. So you have to do certain maneuvers intraoperatively to reduce or to minimize the bleeding. This is what I am doing. I am using this Merocell. I generally do, what I do. See this 2 Merocell cut into different size number of pieces, soak them in solution of saline and adrenaline. This being a young guy, I am using 1:1. In elderly, I may be using even less concentration, 1:4 or something, but always topical. We never inject. And it has been proven, we have even seen in our number of cases and literature, you see, the ultimate field is same, provided your pre-operative preparation is good and other parameters, the anesthesia parameters and others to take care of. So my first is this preparation with the topical saline adrenaline. See the field. And the second is to take care of the venous bleeding. You just keep the patient in the reverse Trendelenburg position by means of keeping the head end. We are here, we are keeping 15° up. And third is the anesthesia part, because here we are always grateful to our anesthesiologist to give us a good field. And what we want from them is the, the reduced cardiac output by means of reducing the heart rate closer to 60 or so, not the blood pressure. This is not arterial bleeding where blood pressure directly would have a significant impact. Rather, it can put the patient on risk if you try to reduce the blood pressure too much. So the blood pressure is not a concern. This is a benign disease. We can't afford to push our patient to unnecessarily cardiovascular risk by injecting adrenaline, which can go to the systemic circulation, or by means of lowering too much of the blood pressure, which can have its deleterious effect on the cerebral circulation, as well as on patients who are, cardiovascular liable patient, borderline patient. The reduced cardiac output can have an impact on the coronaries and can be a disaster. So we don't want the blood pressure to be low. We do in a normotensive conditions. What we want is the heart rate towards lower side. That is what we expect from our anesthesiologist.
Satish, what solution are you using for the decongestion?
The simple saline and adrenaline, sir. 1:1. 1:1.
1:1. Right.
But only topical. I am not injecting at all.
Right. And these Mirocell packs which are giving,
yeah.
I mean, I see that there is no thread attached to it. Do you think that is important, or?
Yeah. There is a count which is important.
Yes. Sometimes.
So at the end of the surgery, see, I am removing the same pack. We rinse in the saline like this. Rinse in the saline, squeeze the same solution, and we can reuse again and again during the same surgery.
Absolutely.
At the end of the surgery, when you need packing the model cavity, you can use the same solution, the same packs.
Right.
So there is no additional, I can say, the financial burden on the patient as well.
True.
I said I'll be demonstrating on one side. Yes, Paramita.
So, Dr. Kranti is asking about the role of macrolides.
Macrolides has a significant role, I would say. That's a good question from Kranti. Dr. Kranti Bhavna from AIMS, Patna, is it?
Yes, sir.
So, but macrolides have proven their roles by means of having effects on certain cytokines, and those are involved in the neutrophilic activity. So this is more of a value in non-polypoidal sinusitis, where role of neutrophil is much more than the role of eosinophil. So macrolides to all patients with non-polypoidal sinusitis, for that matter, and in majority of those patients, we use clarithromycin, low doses for few months. And what we ensure before we starting is to have the patient's IgE low or normal. That is essential, otherwise macrolides are not effective. And
Yes.
once we use, the inflammatory profile is, drastically reduced. And majority of the patient, in our selected patients, we have been able to avoid even any surgery in those patients. Once the inflammatory load is lowered with the macrolides, you can continue with the saline irrigation and the topical steroid. See, it's a sort of trade-off between the inflammatory load and the need of surgical treatment. If there is too much of inflammatory load, you need to reduce by means of surgery to make your minimal medical treatment effective. If there is too much of the inflammatory load, whatever minimal treatment you can give with the steroids, your topical steroid cannot be so effective. So you can reduce the inflammatory load and continue with your topical steroid. Can you see
Yes.
the picture now? Much better?
Yes, sir.
Now what I am going to do is I am going to debride the polyps. I told you the turbinate is so compressed because of the polypoidal mass. Can you see here?
Yes.
That is the middle turbinate which the patient is having polyps on either side of the middle turbinate. You see this?
Yes.
And middle turbinate is so compressed. The micro debrider is an amazing tool. Be careful. Keep the cutting edges in view all the time. See this? This is the interplay between both the hands. Wherever your debrider is going, you have to give visualization through your opposite hand and keep the cutting edges in view so that you don't result into any significant damage. And see, this kind of messy polyposis, you have to be extra careful because it results into distortion of the anatomy as well. So here, and this is a revision case. See the middle meatal antrostomy?
Yes, sir.
In revision case, you have to be more careful about the landmarks because you never know what the previous surgeon has done exactly, and obviously the anatomy is distorted.
Yes, sir. So I would like to ask Brado, madam, ma'am, what about your protocols regarding revision cases, ma'am?
Yeah, so I have a way of doing revision cases in a slightly different way.
Yes,
I call it actually step-by-step surgery.
Okay.
Not step-by-step, stepping stone surgery.
Okay.
That instead of going like we do in a normal fest, through uncinectomy, frontal sinus, then the bulla, and sequentially anterior to posterior, I first find one landmark, then I use that landmark to find the next one, and then that. It's not that you can very well do it this way, but especially when I'm teaching and someone who's junior and is beginning, they get daunted by the fact that there are so many polyps and I can't see where the uncinate is. I can't see where, sometimes you even can't see the middle turbinate. So the way to do that would be first to go along the floor of the nose and next to the septum, because that's the place which has no important structure. So you go along that, debride all the polyps along the floor and close to the septum all the way to the back till such time that you see the roof of the posterior choana. Now, no matter how aggressive the previous surgery has been, the roof of the posterior choana is always there.
Yes.
So you get an idea of what is the depth at which you're working.
Yes.
So when you start operating in the other areas of the nose, you have always a comparison of the posterior choana to know how deep inside the nose you are. The next thing I do is, because we have removed the polyps, the next thing you can see is the inferior turbinate. Now, we know that the inferior turbinate lies just below the maxi-sinus ostium, right?
Yes.
Because in these revision cases, quite often the uncinate has been partially removed, either completely removed, partially removed. And if there are a lot of polyps, there's a chance that a novice surgeon may go through the lamina papyracea in trying to find the normal ostium. So usually the normal ostium has been opened, but you don't know what level the lamina papyracea is and where is the opener. So I usually open the maxi-sinus just above the inferior turbinate with an instrument which points anterior-inferiorly. Once you open the maxi-sinus and you can see inside the maxi-sinus, you can see the roof of the maxi-sinus, that is the floor of the orbit. So now you have an idea of lateral to medial. So if the choana gave you an anterior posterior direction. Once you see the maxillary sinus, you know where the maxillary sinus is open, the medial wall of the maxillary sinus. So you now know that the lamina papyracea will be either at the same plane or lateral to it. Because if there are polyps, it will have bored out towards the orbit. So now you know, now that you have an anterior posterior and a medial lateral orientation, that's when I start removing the polyps from within the middle meatus. What I'm saying is actually the way I teach my residents.
Okay? That is important. That is important, madam. That is absolutely
about an experienced surgeon. We're talking about someone who's beginning. So once you have a medial, lateral, and anterior posterior, that's when you start removing the polyps in the middle meatus. And as you remove them and skeletonize them, you'll start seeing the middle turbinate. You'll start seeing the uncinate, and then you can proceed further with the steps of the surgery as one would routinely enough.
Yeah. So the important point is what madam is saying, and that is true. This is a surgery of landmarks. You know, for every next step, you have to have some landmark in your view. And in revision, this becomes more important. And like madam said, we take into consideration, there are certain landmarks which are always present in spite of repeated revision surgeries. We have operated a patient who had been operated earlier 20 times. Yet there are certain landmarks which are always present. Like madam said, choana. Choana is always present, and once in such multiple operated cases, choana is present, you can go along the choana, medially along the septum, and find the sphenoid ostium about 1.5 centimeter to 2 centimeter above. Once you find the sphenoid ostium, you can go along the skull base and find the skull base and other sinuses. One landmark can accomplish you the entire surgery in most difficult situation. Inferior turbinate is another preserved. Then middle meatal enterostomy itself is a landmark. If you have a middle meatal enterostomy at the medial end, you can go up and find the lamina papyracea and then go along with the ethmoidal dissection. And the most important landmark, which is never destroyed by any regular sinus surgery, is the nasolacrimal duct or the frontal process of the maxilla. It is always preserved. In any number of repeated surgeries, it is always preserved, and once you get this, in your view, find it, follow it above to the level of the beak, find the frontal sinus, and then the rest of the sinuses you can easily accomplish. So this is a surgery of landmarks, wherein you have to look at the landmarks all the time. The madam raised a very valid point. We need to understand this is a surgery of landmarks. Now, what I have seen after this luminal clearance, this is our middle turbinate, which is compressed, I told you, and this is something floppy as well, and we'll do something to it to prevent falling it laterally at the end of the surgery, because now we can't take a chance of, a revision further. We'll do something, we'll ensure that post-operatively our irrigation reaches everywhere effectively. 40. So now, my second landmark here is inferior turbinate. Suppose you don't have any other landmark, follow the inferior turbinate in the middle of the course, just go superolaterally, and you will be right in the maxillary sinus. Now in this patient, see this, even the uncinate process was not completely removed. See this? This uncinate is such an important anatomy to open up your ethmoidal labyrinth. This was not even laterally completely removed, and this is what I am going to show you. This is your middle meatal enterostomy. Second thing, see this, the compartment in the maxillary sinus not completely taken care of. See, these are two compartments which were not joined. Can you see? Can you see this?
Yes, we can, Satish.
Now I am giving him a complete, and in this case particularly now, I intend to give him a mega middle meatal enterostomy, because I want, this is a massive mucosal disease, and I want the steroids to penetrate into the sinuses freely later on. Freely, आज वाली है, सो बंद कर, just a minute.
Ma'am, what about anesthesia? Will you prefer hypotensive anesthesia?
Pardon?
What anesthesia? Yeah. Yes, ma'am.
No hypotensive anesthesia, Paramita. Never,
Okay, okay,
never.
okay.
Normotensive with reduced, heart rate.
Okay.
Our goal is to reduce the heart rate so that the cardiac output is relatively less.
Satish, you mentioned that you want to make it a mega osteum.
Pardon? Yes, sir.
You wanted, you said that you want to do a mega osteum of the magni sinus. Am I right?
In this particular patient, yes, sir. Pandal.
I mean, even though there's a disease which is not so much there in the magni sinus, except for the missed osteum sequence which was there.
Yes.
Do you sort of subscribe to the fact about the nitric oxide also as an anti-inflammatory agent which should be there?
Yes, sir, I agree with your point. That was the theory initially believed to be, which is not been given too much of importance now. My reason for the middle meatal enterostomy here is not only to ensure the penetration of the steroids properly, because this is a eosinophilic disease, number one. And this is a revision situation. And number two, for the surveillance, for the post-operative surveillance as well, I need a mega middle meatal enterostomy. Had this been a primary situation with properly done surgery with a regular technique, I may not have, gone to the mega middle meatal enterostomy. But in a revision situation, with this kind of massive disease, see this mucosal disease everywhere, why to take a chance? What I want post-operatively is my steroids penetrating the disease, penetrating the sinuses freely. Topical steroids. That's
Satish.
Yes. Yes,
we
sir.
Normally do this part with the straight blade, but I can see that you're using a slightly angled blade. What blade are you using?
Yeah, this is red 40. This is more versatile because I can, work in the angles as well. See, this is my middle meatal enterostomy. At the same time, what I discovered is my lamina pepperaceae. See this. And this is a very, very important landmark for me for the further work. See, my micro debrider, another advantage is it is cutting sharp. It is not peeling anything. I am preserving the mucosa at the end of the day when I am cutting with a micro debrider rather than pulling anything, out of it. So that is something, a mucosal preservation tool. That your micro debrider is. Always try to preserve the maximum possible mucosa, because it is the mucosa which is important to prevent further issues. Mucosa which is important to serve the further functions. Everything distorted because of the mass lesion. See this? This is my middle turbinate. Now what landmark I need to take into consideration here while I am working here at this level? I need to stay medial to the middle turbinate, and I need to keep my lamina pepperaceae as my lateral limit. And if I stay in between, I am pretty safe. I am pretty safe in the sense to avoid complications. See, this is my lateral wall. Lateral limit, that is lamina pepperaceae. This is my medial limit. I am still with a 0 degree. And at this point of time, I was going quickly because there was nothing much here. I needed to debride all these things, whatever coming in the way, preserving the mucosa. Debrider. And now I will move up. This is just opening up the corridor. Now you can see the corridor between the middle turbinate and the lamina pepperaceae. You can see very well. I hope the picture is good.
Yes, sir.
Now at this point of time, I am not doing anything at this plane with a 0 degree. I will go up with a 70 degree to show you something which can really help you opening the frontal sinus at this point of time easily. too much of the polypoidal disease everywhere. See how the turbinate, disease medial to the turbinate. You have to be careful superiorly when you try to remove the disease medial to the turbinate, as otherwise you may end up injuring the olfactory mucosa unnecessarily. That is something you have to respect. Even with this ventilation established to the olfactory region, with the minimal, mucosal hypertrophy left in that region, with the irrigation coming up, is going to take care of that rather than staying radically on that area to damage the olfactory mucosa. See, this mopping with the marrow cell is game changing. Again and again you can use this to mop up the field and minimize the oozing. This is just simple soft application of this marrow cell, this adrenaline to the surface. That's it. It is not that something you have to tightly pack it. That could be counterproductive if you pack it tightly, because that may lead to venous congestion, and that may even lead to more frustrating bleeding than otherwise from the capillaries. So you have to be careful. Just simply introduce and apply the adrenaline on the surface rather than tightly packing it. See, in no time the field dramatically improves. Now I am using the 70 degree here at this point of time to take you to the frontal. Our next case is going to be a draft 2 for a type 4 frontal cell.
Satish?
Yes, sir.
In this, it's a revision surgery.
Yes, sir.
I mean, you're going after this step to the frontal sinus.
Yes, sir.
Because the previous teaching has been to go to the sphenoid and then go to the, the posterior ethmoids, and then go to the frontal as a last one. So what is your take on that?
See, the reason is previously the frontal sinus was considered to be very, very difficult because of many reservations, Now with a better understanding.
I'm also talking about the people that were watching, for them also, because going to the frontal sinus without getting one of the other landmarks like the sphenoid sinus, I think you should tell us on both the aspects. The beginner and
that's
as an expert as you.
That's why to simplify. Right. Now, this simplification has come with the use of 70 degree, I tell you. See, with this 70 degree, why we are scared of the frontal sinus? Your question is valid. Why we are so scared of the frontal sinus? Because of possibility of giving certain complications, because of its strategic location and identification, because of its close proximity to certain vital structures, like orbit laterally, like skull base medially, like anterethmoidal artery behind. All these things are making the frontal sinus surgery, something like terrifying some point of time to the surgeons. Now, keeping the 70 degree in view, giving the visualization from the 70 degree, keeping all the 3 landmarks for the 3 important structures in view, 3 limits, you can certainly avoid those complications and carry out the frontal sinus surgery in no time. Let me tell you exactly what I am going to do now. Now, for the fear of injuring the orbit, what I will do with the 70 degree? I will keep my lamina papyracea in view. Can you see all the time? Yes, as long as my lamina is in view and I don't cross it, see this, I don't cross it laterally, I am not going to damage the orbit. This is my middle turbinate. As long as I stay medial to the middle turbinate and not crossing it medially, I am certainly not going to damage the skull base. And for the anterethmoidal artery, I have already told you, with the 70 degree direction up anteriorly, anterethmoidal artery running in the posterior part of the ethmoidal roof is miles away, is in a different direction at all. Now, the important relationship which I am going to unveil here, see this, again, just to simplify, I am defining my lateral limit. This is lamina papyracea. Can you see very clear?
Yes, sir.
Now defining my medial limit. That is my middle turbinate. You can see very clear. Anteriorly, anterior limit is your beak. See this? The beak forms the floor as well as the anterior wall of the frontal sinus. Now, as long as I stay between these two limits, I can never damage anything. See now, I am close to the turbinate. As long as I stay close to the turbinate and don't cross it, I cannot damage the skull base. See that? And soon I am going to be right in the frontal sinus. See my direction of the 70 degree to the frontal sinus. What I need to keep in mind is my lateral and medial limit. See, this is the part of the remaining part of the Agarneji, and this is my pathway to the frontal. Can you see up?
Yes, sir.
Can you see up? Now what I am keeping in mind here, again before I remove that, this is my medial limit, that is my turbinate. Can you see this? Just stay flush to the turbinate. My lateral limit is the beak, or the lamina papyracea. I will remove these septations, you know, these septations of the, incomplete septations from the lamina papyracea, just staying parallel to the middle turbinate. Nothing else. Anteriorly is safest. Anteriorly is my beak. There is nothing to be something I need to worry about anteriorly. And see anteriorly, what I have seen is my beak. Can you see my beak now? This is my beak. See my beak. Now, having seen this beak, a beak as my anterior limit, I am already inside the frontal sinus. So simple. This is how the draft has, devised lots of procedures keeping this beak in mind. As beak, as you go anteriorly, is the safest area to drill away, as there is no important structure. Now see with 70 degree, that is my frontal sinus. And what all I can see is some landmarks again for you. See what I was keeping in mind with 70 degree. This is my turbinate medially. Can you see? All the way. Flush, mucosalized turbinate. Can you see? Where I am running my suction. This is my turbinate. Can you see or not?
Yes, sir.
This is my turbinate. As long as I keep my turbinate as my medial limit and don't cross it, don't worry about anything.
Yes, sir.
As long as I keep my lamina as my lateral limit, don't worry about anything. And this is something you need to discover your beak. See the beak?
Yes, sir.
This is lateral limit, this is medial limit, this is the beak, and anything cannot be there in between these three. It has to be a frontal sinus. That's it. And this
Satish,
is,
I totally agree that the way you are doing it is, is absolutely correct. But see, everyone is not going to be an expert. Now, let's say people are not expert. Would you say that this would be the first thing that they should do, or should it be a sphenoid? That's the only thing which I asked.
yes, I got your point. You can come from behind. You can come from behind, but see, now we have an added advantage of identifying our skull base at this point of time. And this has a significant impact because as I go behind my identification, 120, my technique of identification of the sphenoid and all is different. In the simplest way, I am going to explain you. But this is something in the beginning of the surgery, you can open up this space thoroughly. See this?
Okay.
Only thing it calls for is a 70 degree.
Yes,
you
sir.
have to be well versed with a 70 degree. That is something very important in this situation, because that's why I always tell everybody 70 degree is the most important sinus, most important telescope. We need to be used to 70 degree. And you know what blade I am using now? 120 degree.
120. Yes, sir.
So I can be working right inside the sinus. See this?
Yes, sir.
See this?
So Brado madam has to say something. Yes, ma'am, you were saying something.
I was saying that not in revision surgeries, but in primary surgeries, one of the landmarks that one can use for the frontal sinus, which I use, is the anterior wall of the bulla. So we use I prefer an intact bulla technique as far as possible.
And revision many a time, but that may not be patent, madam.
Right. That's what I said right in the beginning, that I'm not talking about revision, but I'm talking about primary surgery. Since we're talking about the different landmarks in the frontal recess area to reach the frontal sinus, the anterior wall of the bulla plays a very important role, because the anterior wall of the bulla is the posterior limit of the frontal recess. And so any opening which lies anterior to the anterior wall of the bulla is the frontal sinus or a frontal cell. If the anterior wall of bulla is removed and you see an opening, or you see an opening behind the anterior wall of the bulla, that is usually the supraorbital cell or the suprabullar recess if there is no supraorbital. And what happens is, when you remove the anterior wall of the bulla, you remove the bulla completely. And if you are a beginner, you will see 2-3 openings in the area of the skull base. The supraorbital cell, the frontal sinus, the frontal cells, and then it can be confusing as to where to go to open the frontal sinus completely. Therefore, if the anterior wall of the bulla is there, you know that the openings anterior to the anterior wall of the bulla can only be the frontal sinus or the frontal cells leading to the frontal outflow tract. And therefore, that's one landmark that I always keep in primary surgery. In revision surgery, of course, you don't have that. Also, the other thing is, in this particular case, the axilla of the middle turbinate has been pushed a little anteriorly. And therefore, the distance between the axilla of the middle turbinate and the frontal sinus is a little longer than it would be if the axilla was exactly in the area where it hadn't been pushed anteriorly by the polyps. Satish, do you agree with me on that?
Yes, exactly. Absolutely.
Renuka, taking up from where, when you said that if the bulla has been removed, you lose that one landmark, then saying what Devinder said, that if you start with the sphenoid and come forward, then you already know where the skull base is. You're coming along the skull base. Then from behind forward, you identify the anterior ethmoidal artery. And once you've identified the anterior ethmoidal artery, that's a very important landmark for you to come more anteriorly and get your frontal sinus.
Sir, adenoid blade.
Yeah, you're using the adenoid blade now for the posterior part.
So I call it as a skull base blade. And the reason why it is so useful here is, with the 70 degree, I can make it front facing. Now see this. This becomes front facing. This is no more a rear facing blade now. Can you see?
Yes.
And not only front facing, the cutting edge facing me is away from the skull base.
That's right.
So that makes the skull base, when you work along the skull base, very, very safe as well.
Yeah. Satish, when you use the 120 blade, can you just show us, when you go into the frontal, how you introduce the blade inside from outside, as you go inside?
I could show. Actually, we are not having the external camera in the theater. What I will do in the next case, I'll keep some mobile camera or something and show you.
Okay.
Satish?
Yes, madam.
Satish, in this case, because both surfaces have become raw, both the lateral and the medial wall.
Little bit. Yeah.
Visualization suture doesn't give the gap in between. What extra?
No, I will do something. I told you at the end of the surgery to the middle turbinate. To me, this middle turbinate can be problematic in the post-op, being a little bit floppy as well. Not only, it may restrict my, the flow of steroid irrigation into the sinuses freely.
Yes.
So I will do something to trim this turbinate to make a free access to the sinuses as far as the irrigation is concerned post-op. And now see, madam, what you were saying. It is hardly any raw area on both sides. Now see the orbital area. Can you see?
Yes.
The mucosa. See the turbinate area. Can you see the intact mucosa?
Yeah,
see,
very clearly.
There is hardly any raw area, by and large, you can say.
I was talking about the entry point in the region of axilla.
Yes. And for that I am going to do something. I told you about the turbinate.
Okay.
Because I don't want this turbinate to be a problem. Because that may defeat my entire purpose of surgery.
Yes.
My purpose of surgery is to give access to the topical. Got my point?
Yes.
And here, at this point of time from the ethmoids, I am taking this, mucosa for the histopathology. Now coming back with the 0 degree. Now since I have done the frontal work above, I have already done the maxillary work, I have already done the anterethmoidal work. Now the last work left behind before we move on to the draft case, the next one, would be a little bit of the remaining work of the sphenoid and the ethmoid. And here I am going to tell you how I am going to deal with the turbinate. See this, all this, you have to be careful not to give too much of raw area. See everywhere, even if somewhere you find a little bit of the polypoidal mucosa, you don't have to be, something very radical about it. Once you have established the ventilation and drainage, once you have established the introduction of the steroids deep into the sinuses, well, this is going to be taken care of by the topical steroids. You don't have to be very much radical about removal of each and every swollen mucosa.
Okay, there are few queries about what precautions that has to be taken to prevent damage to olfaction. Is there anything?
Yes, I have already mentioned. That is an important question. Our olfactory cleft is here. See medially up there. And see this polypoidal mucosa, this and that. If I try to debride these polyps and giving some fibrosis here, this is something not wanted. I don't want any kind of trauma in the olfactory region for that matter to give this patient any olfaction loss. This olfaction loss is of two types, like our hearing loss, conductive and sensorineural. Conductive was when the air is not reaching to the olfactory receptors. Because of the massive polyposis, the air was obstructed to reach to the olfactory cleft, which you have opened by means of removal of the polyps, This way you can take care of the conductive olfactory loss. Got my point?
Yes,
but
sir.
Because of the eosinophilic disease and the inflammation in the olfactory mucosa here, see this inflammation, you never know what kind of irreversible inflammation, long-standing inflammation has already taken place. It may be reversible, it may be irreversible, you never know. And that's why you cannot commit your patient about the olfaction. You can try to. Some patients are very much, maybe because of their profession or any other needs, they are very much concerned about olfaction and what you can give them. You can give them a trial of oral, steroids for a few days, 2 weeks or so, to improve the inflammation. If the olfaction improves with that, you can imagine that your sensorineural loss is not irreversible. Got my point?
Yes, sir.
So there are two aspects of the olfaction, the conductive and sensorineural, and you have to be clear about it. Now see, you have to be very careful in this region, in the revision, because from the post-ethmoid you can enter accidentally into the sphenoid, and that can be a disaster if you don't know. And like in the primary situation, I always tell, follow certain landmarks. Here it is not possible. You have to stay extra careful. Now, at this point of time, what I am going to do is, I will reduce this turbinate. See this. There are a lot of studies now with the partial resection of the turbinate to improve the access of the topical steroids, has a positive impact. I am not chopping off the turbinate. See this. Can you see?
Yes, sir.
This is partial resection and it has a significance. It has a positive value because you can now ensure that your turbinate is not going to bother. Can you see now?
Yes.
For identification, for other things, your upper end of the turbinate is always there, intact. Only thing is, now our turbinate is not going to, be a obstruction to the penetration of the steroids. Can you see such a good airway now?
Yes, sir.
Upper part, I told you here, I am not going to be, doing anything here. this mucosa, this everything will subside. Believe me, as the steroid penetrates deeper, it is bound to subside. So you are not supposed to be very, very radical about it.
Satish, do you remove, partially resect the middle turbinate in every case?
Not every case. In messy mucosal disease, and when the turbinate becomes floppy, in messy mucosal disease, this is one of the strategy now. See, this is sphenoid sinus.
Yes.
The only thing is about the sphenoid sinus is, see, like madam said in the beginning, sphenoids, the coina, 1.5 centimeter to 2 centimeter above, and stay close to the septum. See this mucin, and stay close, flush to the septum, and that is how you can easily enter into the sphenoid. In revisions, you have to be extra careful about all this.
So what about the edematous mucosa or the cobbled mucosa?
Yeah, that will subside. See now what you have achieved. You have achieved the ventilation and drainage, number one. See the cells behind the ethmoidal roof. See all the cells. What we have achieved to improve the situation of the mucosa. First is establish the ventilation and drainage of all the sinuses, which we are doing. And second thing is making the topical steroid accessible to all areas. Once your steroid reach freely, everything will subside. See this? Lot of skull base cells. Under vision, with debrider control movement, you can actually excentrate all these cells, because if you leave the unaerated cells behind, again the same phenomena can create problem. So here I need to be, that's why I mentioned full house. With this full house fest, I'll show you at the end of the story, when I do, you can see your all sinuses right in your outpatient department without the need of radiology in the future. What you are supposed to ensure is to see this cell which is opened up. You are not supposed to damage the mucosa. Mucosa is something you have to keep intact. If you remove the mucosa, where the function is going to be served with. This is functional endoscopic sinus surgery, where you are supposed to preserve the function by means of preserving the mucosa, which is going to function by means of mucociliary clearance. If you remove the mucosa, then it is not fest, then it is mess, total mess. The raw area will invite lot of fibrosis, lot of crusting, a lot of infection, lot of secondary intention healing, and that is something not warranted. This is functional surgery. Everywhere you have to be, preserve the mucosa. This, for preservation of mucosa, this microdebrider is the tool. So we have to preserve the mucosa everywhere. And once this cavity, which is, well accessible to the topical steroids, see this, mucosa serving the function, what all patient needs to do is to irrigate post-operatively. We reduce the frequency as per the mucosal condition after few weeks, and accordingly you can take a call. If the patient is in close follow-up and the mucosa is good, you can afford to reduce the frequency and concentration, and if anything goes wrong, you can again increase, but it is overall going to be topical, so it is quite safe. Through cut. So the goal is to switch the topical, the oral steroid to the topical steroid. That's it. Because right now there is no other weapon than the steroid to deal with the cytokines which are involved in the pathophysiology of this disease. Though in the future the targeted therapy is underway, is already approved for some indications, and probably That is going to be the future. You can even treat this disease even before the clinical manifestation happens to occur with the targeted therapy, but it's still a long way to go. Until then, the only weapon we have is the steroids. And for that, we want to avoid the use of, oral steroids. They have their own adverse effects. We are just switching over them. See, this is Silcut. Yes, Paramita.
Dr. Ajay Shedge from Mumbai is asking what is the dose of Budicort Respules and how it is administered after effects.
No hard and fast, but yes, like in this patient, we'll start with a 1 milligram per 500 ml, like 2 milligram per liter, and we'll use 250 milligram of irrigation every day. That will include 0.5 milligram of steroid, just 0.5 milligram of steroid, and that too topical.
Okay. Are you using 0 degree now?
Yeah.
Okay. So there are a few queries about the macrolides which you said. So when serum IgE is high, the macrolides will not be effective.
Not at all. Yes, absolutely.
And when it is normal or reduced, we can
must
keep
try.
patients on macrolides.
Yeah, we must try.
Okay. And sir, what about vitamin D? As you just said, but there are a few queries. What is the role of vitamin D?
Vitamin D has an effect on certain cytokines and has a role in improving the sinonasal immunity. So anything, see, this is an immune complex disease. Anything which improves the immunity overall will have a positive impact on the overall outcomes. Anything which has a negative impact on the immunity will have a negative impact on the outcome. So that is what the steroid is the treatment of choice, and vitamin D has been proven to have certain immune protective effect by means of having effect on several cytokines, by means of having effect on improving the sensitivity to the steroids. In severely deficient vitamin D deficient people, even many a time they become sensitive. So that's an important hormone. Vitamin D is a versatile hormone having an impact, overall impact on over 205 genes in the body. I am not saying that that is the only thing responsible for everything, but it has a definite role.
Yes, sir.
So here in the sinonasal immunity, it has a huge role.
Okay. And so the treatment of the aspirin sensitivity test that you had already said before, you can just repeat once again, sir, this time, about the Montelukast that
see, for aspirin sensitivity, at the molecular level, the pathology is what? The COX-2 inhibitor hypersensitivity. COX-1 inhibitor hypersensitivity. So, the more leukotrienes are formed, less prostaglandins are formed. So, basically you have to revert this pathology by means of aspirin sensitization, desensitization. I told you over almost now 300 patients are on aspirin desensitization. And that is the cure. That is the only cure to this disease, because the moment patient starts tolerating the aspirin after desensitization, your leukotrienes stop forming, the prostaglandins start forming, and the entire pathology is reversed. So aspirin desensitization, because we need to start oral aspirin, we reserve it for the post-operative period. Until then, establish the sinus mucosal drainage like this, establish the patency, remove the inflammatory load. How is the picture?
Excellent.
See the choana,
Very
the
clear. Yeah.
maxillary sinus, sphenoid, entire skull base, and that is the frontal sinus above there. Can you see with a 0 degree only?
Yes.
This is my orbit. See this? This is my remnant of the middle turbinate. That is axilla, and that is the olfactory region which I don't want to even touch, because that is going to, I believe, come back, and that is the only way I can hope, by preserving this. Any more questions before we move on to the next case?
Satish, how long does your nasal irrigation, how long do these nasal irrigations? Lifelong? Post-operatively, I'm talking of the steroid nasal irrigations.
Yeah, that depends. I told you, depending upon the patient's, eosinophilic profile and the regions to the eosinophilia.
Yes.
No, Satish, a very good and excellent surgery. Everything, all the sinus is very clear, and with the 0 degree, it's a real full house.
Most of the mucosa has been preserved, and that was my goal.
Yes.
To preserve the mucosa. I don't want the healing by secondary intention and crusting. Anybody who has operated, and if you are following that patient with too much of crusting, that means the quality of surgery is never good. You can assess by means of level of crusting only.
Satish?
Yes, disconnect.
What is the frequency of follow-up for the patient for the rest of his life?
Hello, madam?
Hello, huh? What is the frequency of follow-up for the patient for rest of his life?
Connect. Frequency of follow-up?
Yes.
This is like, for massive mucosal disease, it is almost lifelong. But the frequency and intensity is governed by the, the inflammatory profile of the patient.
Okay.
Like patient with minimal inflammatory load or the eosinophilia, you can keep on increasing. You can keep on increasing the follow-up duration. I mean the time between the follow-ups, and you can keep on decreasing the intensity of the solution. I mean the concentration.
Okay. And second thing is,
this is like you have to counsel your patient. Yes. Surgery is to facilitate the medical treatment. If you don't follow the proper medical treatment or follow-up, you may come back with the disease. This is what cardiologists say. When you get your heart stented, what do they say? You have to start aspirin, otherwise the stent may get blocked. And people have to follow it. Everybody is following that. It is the matter that how you counsel them. Nobody wants to undergo surgery again. The thing required is you have to counsel properly. You have to emphasize more on that part. The problem is the surgeons, most of the time the surgeons keep on emphasizing on the importance of the surgery. So patient ignores the other aspect, that the surgery is the most important thing, not the other thing, and that is the reason for, not following up properly and coming back with the recurrence. With this kind of a cavity, with a full house fest, once it heals up in 8 to 12 weeks, believe me, you can tell your patient, keep irrigating. You can reduce the frequency on your own if you are absolutely symptom free. If you find problem, you can your own increase the frequency of irrigation. I have seen patient even who has not come to me for last 2 years, himself managing the intensity and frequency of the solution. Some patients are so quick to understand. They are doing so well. And worse to worse, suppose some patient who has not done any kind of, irrigation, lost to follow for 2 years and come back with the polyps. What can you do? Since the entire bone work is already done, we have already reached to the limits all around. That's why it is full house fast. What is left for the future surgeon? What you can do, again start the irrigation, give oral steroid, the things will open up. What all you need is, with under Xylocaine spray in your office, you can debride some polyps, that's it. And again, the patient, you can say indirectly, you can give an indirect guarantee to the patient that you will not need a formal sinus surgery if this full house surgery is properly done and provided you follow up properly. That is a sort of indirect guarantee, I can say, in those patients, because there is no scope of future sinus surgery now once you have gone up to the limits. What is there left to remove for the future surgeon? There is no septation at all.
Okay. So what have been your results?
Pardon?
Satish, what have been your results related to sublingual immunotherapy after the surgery? Do you find them?
Yes, amazing. This is for only those patients having associated allergic rhinitis. See, this disease is like a syndrome. You have to treat all associated comorbidities. Like patients who are allergic, post-operatively you have to get skin prick allergic testing done. in the proper condition after withdrawing all drugs and everything. If it is, suppose is allergic to house dust, pollen or something, you have to follow with the immunotherapy. That is the only thing which can change the natural course of disease.
And what makes you decide that now the surgery, revision surgery is again needed? Because what level of polyp make you decide? Because many of them settle down with the douching only.
It is not the polyps, with this kind of work, polyps will never decide the need of revision surgery. It is the neo-osteogenesis or anything which has happened because of the lot of raw area you have left around, because of the inadequate penetration of the topicals, because of the improper position. We have to train the patient properly in what position you have to, douche to allow it to reach everywhere in all sinuses. We have to train. After sinus surgery, we additionally keep for an extra day to all patients in our hospital to train them themselves. They start doing douching so that they can do later on at their home. So this is most important part, because the goal is to allow the the steroid to reach everywhere. If that is not happening, your purpose is defeated.
Right.
Yes, sir.
Thank you.
So how is the Budecort respules administered after FES? Can you just repeat?
Pardon?
The Budecort respules, how is it administered after FES?
Yeah, in mix in saline or ringer lactate.
Okay.
DVD में
there's a question from Dr. Geeta Lima, New Delhi. She's asking that do you use Hetrizin pre-operative in cases of raised IG? How much and for how long? At
Not
what
really.
IG level are you comfortable operating?
No, operating you can do at any level. That is
Okay.
no issues. But once it is a high IgE, you have to keep in mind various possibilities. And that you have to counsel your patient as well. Because without that, it may be a big problem. The reason is, high IgE could be because of allergy, like Madhuri Madam said. If the patient has a allergy to certain thing, grass pollen, dust or anything, can lead to high IgE, because that is IgE mediated reaction. High IgE could be because of Staph aureus infection. Staph aureus can lead to polygonal expansion of the IgE, and you have to keep in mind. So if there is obvious infection on culture and it is Staph aureus and there is high IgE, you should keep in mind the Staph aureus infection leading to polygonal expansion of the IgE. And if it is low IgE, then obviously you have to consider macrolides. So IgE is very important in decision making. Before surgery, that's why there are certain list of investigation you must get done to take a call or for decision making, I would say. Can we move on to the next case? We can carry on questions.
Yes, sir. Yes, sir.
Satish.
So, yes, sir. Yes, sir. Please.
So we are doing the draft 2 next.
And the next is the Hughes parapharyngeal schwannoma.
Okay, fine. So this draft 2 will not take much time because most of the dissection.
Not really. This is just mechanical now.
Okay.
We have discussed a lot.
So I'm just going to ask Dr. Devendra Chaukar to join now.
Yes, yes. Now, this patient has come to us who has recently undergone surgery somewhere, and the guy who has started doing endoscopic sinus surgery has done a reasonably good work. This patient happened to have a type 4 frontal cell, which was beyond his limitation. This can happen with anybody, it's a learning curve for everybody.
I think he is almost finishing this case. So next 20 minutes to half an hour.
Yes. Yes, sir. So I am just going to take care of this type 4 cell and why it is so important. This rest of the work is reasonable. It is recently done. Can you see? And see on the right side. See on the right side, can you see the isolated cell?
Yes, nicely visible.
Can you see? Though there is frontal sinusitis on the left as well. But look at the right side. This frontal cell is so difficult, it's not all that easy for everybody. Because it has its own challenge. The location, the need of angle instrument, the need of a bigger access like draft or something, you know.
Satish, can I show us a sagittal view of the same? So you got the
yes.
three, yeah.
Sagittal is the best for seeing the frontal cells.
Let me take you to the cells in all view. And now you see in the sagittal plane here. See this cell which is rising so high up here. Can you see?
Yes.
Rising so high up. Now imagine you are coming from here and you have to go right up there. You have to deliver this cell septation to allow the frontal to aerate distal to it. That is our goal. And the biggest obstacle is what?
The beak.
This beak. So that is what we need to take care of. See, this is the beak, thick beak. If I am coming from here and remove this beak, I will be straight away, right onto the cell. And this is on one side, so my procedure will be a simple draft 2. Draft is divided into variety of, access to the frontal sinus. What I had shown right now, you can say is draft 1. When you work right to the level of the ostium, the initial teaching for the frontal sinus surgery, when Messerklinder and Stamberger devised, their goal was for the major sinuses to establish a drainage system rather than going into the sinuses and allowing the ventilation and drainage so that the pathology reverts on its own. Now we are one step ahead and go right to the frontal sinus ostium and widen it to allow the steroids to go inside, which was not the previous concept. So what I had done in the previous case, right to the level of the ostium, was draft 1. Now we saw the beak. Anterior to the beak on the one side. On one side, suppose I remove this beak completely. Let me show you. On one side, if I remove this beak completely on one side, this is draft 2. And that will give marsupialization of the sinus right into the nasal cavity. That's it. It will allow the steroid to penetrate freely. This gives a huge access inside the sinuses, and this opened up a new gateway to deal with the frontal sinus pathologies. Like, new gateway means now there are more and more extended applications for this draft procedures, like to deal with the CSF leaks, to deal with the tumors. Next Sunday, we are keeping in the series of inverted papillomas a huge inverted papilloma deeply infiltrating into the frontal sinus and from there up from the orbit, up from their sinus into the orbit. And that will be tackled by the extended procedures like orbital transposition or something with the draft. So this draft has opened up the new gateway of applications to the various frontal sinus pathologies. And here, for this cell, you cannot easily remove. You can try with your long instrument, this and that, and ultimately you may end up damaging the mucosa. The best is to open up, widen the access, and then everything will be in front of you. So this is draft 2A. 2B, if you stay on one side, you can go up to the intersinus septum. And draft 3 is a simple Lothrops which were described 100 years ago by Lothrops. There you remove the entire floor of both frontal sinuses along with the intersinus septum and the part of the nasal septum and allow them to drain into the nasal cavity. That is Lothrop's procedure, which was initially described from above, outside, and now this is from inside. That is modified endoscopic Lothrops. After that, there are so many modifications we'll discuss during surgery. Subtotal Lothrops, modified central Lothrop, modified hemilothrops. So many things have been described and used for different indications. And we have already earlier kept a case of orbital transposition. And in next week or so, we'll keep some draft 3 and more indications. So here is a straight away situation. We have to remove this barrier to get into the sinus. Is that clear?
Yes, sir.
Any question or do we go ahead?
Now, please go ahead.
Okay, sir. You can carry on the discussion, question, answer with Renuka madam and
yes, sir.
Ravindra sir. In 5 minutes time, I'll be back with the surgery.
Yes, sir. So there's Renuka madam. So how is your post-op follow-up protocol for? Ma'am, you have to unmute yourself.
So basically, see, one thing that I do ask patients when they come for revision surgery, and suppose the first surgery has been done somewhere else, I ask them two questions. One is that immediately after surgery, were you completely well? And if you were well and completely well, then how long was it after that first surgery that you started getting symptoms again? Now, that if the patient says that, doctor, I wasn't completely well, and the symptoms came back within 2 to 3 months, the chances are very high that this surgery was not done completely. And usually the CT scan will show septations, various things which tell you that the sinus may not been opened well. Like in this case that we saw.
Yes.
In which case you can prognosticate to the patient, I think after this surgery you will have you'll have to stay under follow-up. You will be needing to take medication, but I think we will be able to keep you completely symptom-free.
Okay.
The other side is the patient says, immediately after the surgery I was absolutely well. And it is about 2 years after that, or maybe a year after that, that I started having symptoms. And if on the CT scan you see that there are no septations, that all the signs have been opened well, now this is the patient where you have to give a guarded prognosis, because they are not surgical factors which are responsible for revision, but possibly medical factors, allergic factors, eosinophilic rhinosinusitis, which are responsible for this problem. So these are the patients where we give a relatively guarded prognosis.
Okay, ma'am.
And we say that we need to follow you up more regularly.
Okay.
Routinely, my patients, after the surgery is done, I call them after a week for cleaning of the sinuses. Like Satish, I'm very keen that all the sinuses should be well marsupialized so you can see into the sinuses. Of course, I don't do a full house kind of surgery for every case. It depends on where the disease is, and I'll go one cell more.
Okay.
I don't do an entire full house for every case.
Okay.
It depends. Suppose there's only anti-ethmoid disease, I would open up to the posterior ethmoids, but I would not open the sphenoid if not necessary.
Okay.
After 1 week, once we clear so in that 1 week, the patient does a lot of douching. The douching contains butyrate respules. And then after 1 week, when he goes off, he continues the douching. And we see him after a month. And then subsequently, we see him once in 3 months for about a year. And then he follows up with us once in 6 months or once a year, or as and when the symptoms come back. We've made it very clear to them that they must follow up as soon as the symptoms come, because in that case, we can manage them medically. The problem is if the patient is from out of town or has a poor follow-up, poorly compliant, and they come back with a nose full of polyps again. In which case, if we've done the surgery and we know that all the sinuses are well marsupialized, then we would treat them medically. We will try as far as possible to treat them medically, but when you have a situation where the sprays, the douches don't reach into the sinus, the patient would need a revision surgery. So we explain all this very well to the patient so that he understands that if he wants to avoid any further surgery, he needs to follow up as soon as the symptoms come back.
Okay, ma'am. So, Madhuri ma'am, in OPD, do you debride polyps under local spray or something if they come for follow-up, as you said?
ठीक है, अभी दिखाता हूँ. इसमें लाओ वीडियो.
Madhuri ma'am, you have to unmute yourself, ma'am.
ये स्क्रीन कैसे दिखाएंगे?
So, Paramita, we are
yes,
not.
अभी कौन सी स्क्रीन जा रही है, ये या वो?
OPD, we always take the patient to OT because
OT.
Change to this screen.
Because we may do a bit of intensive surgery which may not be possible in OPD. So
Hello.
Take it in the OT and do it. But
yes,
before that, I have seen that the douching, well done douching, can really make the polyp disappear, and is a great alternative to second or third surgery. We must try douching first nicely before we go over and do the.
Hello.
Okay. Yes, Satish, we can hear you.
Yes, sir, we can hear you.
Yes. So, are you getting any picture, sir?
Yes, we've got a picture of the thing. It's a small picture of the endoscopy. Then you've got your navigation thing on the side.
There was a lot of demand about to show the navigation system, because in our previous webinars we couldn't demonstrate. I don't use much, but this is a situation where you can see the importance of navigation. So a few words about the navigation. See this. Navigation improves your localization, and we have to use the pre-operative CT scan data to feed into it. See, like this, I am at the frontal process of the maxilla here. Can you see in all three planes where I am?
Yes.
So this improves your localization. Once we go in the frontal sinus, you will get to know where exactly we are. So this is to improve your localization. That is what the navigation. See on the tip of the nose. See in all planes?
Yes, sir.
See in all planes. And you have to register the pre-operative data, the radiological data, that DVD, into the system, and then you register with the patient's head. The navigation system you have to register with the patient's head. So generally there are two kinds of navigation system. One is this is the electromagnetic system, and other is the camera system. What do you call that extra? Optical system. So this is electromagnetic system, which I have been using this navigation for last 13 years. This is from Medtronic. The other is the optical system, wherein the camera which detects your instrument in relation to the patient head. So anything comes in between, the system doesn't work. So that are certain limitations, advantages and disadvantages of both the systems. So this is electromagnetic ones. Now coming to the right side of the nose, ye badi wali kar do. I'll keep coming to the navigation in between to show you where I am, just to improve your orientation. Badi wali kar do, ye wali. Are you getting the bigger picture now?
Yes.
So now see this this kind of a work done. See, this is reasonably good work done. Can you see?
Yes, yes.
With some raw areas. See this will subside. This is the raw area. See how the raw area heals. You can make out what the previous surgeon has done. See, all mucosalized areas are healing so well. Can you see?
Yes.
Yes, sir.
And see this raw area now. What is happening there? See this osteitis. Leading to a lot of crusting, infection. This is something not warranted. So in sinus surgery, the quality of surgery, you can see if somebody has done by means of the raw areas he has left behind. See the skull base work, done amazing. See this, all sinuses are void and amazing. Everything good. And this frontal sinus, see, this is far up there. I am with a 0 degree. And what is the obstacle? This beak. So my role here is to marsupialize this region so that I see my majority of the work will be done with a 0 degree only. So once I remove this bone, I need to remove this mucoperiosteum quickly. See this? There are many ways to carry out the same procedure,
Outside in or inside out?
Yes, this is the traditional approach, inside out, which I am going to show you, and simplest to learn for the beginner. Outside in is good one. It is propagated by Richard Harvey, and is amazing, and that's a good concept. I will show you once I go up to the frontal sinus level what is the difference. And then the other approach nowadays he's been propagating is the Caroline's window approach, where you make the window at the level of the axilla to go into the floor of the frontal sinus for the limited lesions, not so for all lesions,
He doesn't want that much removal. He wants it through a window.
Yeah. But that can have a good, implication, good, indication in certain limited indications, limited disease indications. You can use that. So what I am using right now, using the coblation, I am removing all this mucoperiosteum or the bone which I am going to remove. Okay?
We're using ablation.
Yes. Quickly. See, this is some of the mucosa over the nasal septum, and over the beak, all this region. See that? And this mucosa, what I have to decide is, see, behind the frontal sinus, we all know the ethmoidal roof starts. We all know.
Yes.
Behind, we have to be careful not to damage the ethmoidal roof or the cribriform plate.
Yes.
And for that, we have to define our posterior limit. And it is better we define in the beginning, you know. So here I will define the beginning of the cribriform plate by means of demonstrating the first olfactory neuron.
So what were the complaints of this patient?
Headache. See the floor of the frontal sinus exposed?
Very nicely.
Now if I go behind, see this, keep going behind, as the frontal sinus ends, will be the beginning of the, you know, cribriform, and that will be depicted by the first olfactory neuron. There are two structures that you need to keep in mind, not to get confused with. The lateral one coming is a branch from anterethmoidal artery, I will show. See all this mucoperiosteum at the level of the beak.
Satish, hello, Satish.
Axilla. Yes, madam.
Satish, first you do all the ethmoidectomy work and then you start doing draft 2?
Ideally, it should be like that. So you get a good orientation.
Both sides you can compare the levels.
Yes. Now see, our goal is to go up in the frontal sinus, you know. See, don't get disoriented. Our frontal is, see here, up here. This is our obstacle. This is our frontal up. So I am denuding all this bone by means of removing this mucoperiosteum.
Yes. How far anteriorly you can come, and posterior limit you have told?
Anteriorly is safe. You can go right up to the skin. I will show the outside skin. That will be my limit. Laterally, limit again is the skin. Outside again is the limit, skin anteriorly. Posteriorly is important, and that should be your limit as a first olfactory neuron. You have to be careful. Can you see?
You show
So
us the...
at this point of time, you are not supposed to go behind that. Now let me take you first into the frontal sinus from beginning. Now see, this bone has to go. Simple understanding. My lateral limit, as madam has mentioned, is the skin. So I will first show my lateral limit, and along the lateral limit then I will go up to my anterior limit.
Yes.
And see, easily you can enter into the frontal sinus. Believe me, for sinus surgeons, the other sinus surgery may be difficult, but this is not. Number one, the reason is, this is absolutely safe zone.
Yes.
There is no critical area above. Can you see here? Nothing. Only thing is, lot of drilling. That is sometimes frustrating, and for that, we have a state of the art, this, what I've been using is the Karl Storz, this thing, the Medtronic, you know, the stylus drill, where I am going to use the RPM of 70,000, and that works like butter. That is, though it is a diamond drill, but it cuts like butter. I will show you.
So you were showing us the level of anterethmoidal artery in close association with the olfactory neuron.
Yeah, see at this level, as you go behind, I will show you.
You should.
I had shown in the cadaver in the previous case as well. That is important to know. When you come from anterior to posterior, you may be, because you are always looking for the neuron. So don't get confused with a neuron. There are two structures come in the way. The lateral one is the branch of the anterethmoidal artery, the small branch, and the medial one and behind is the neuron. At this level, see, the medial structure will come is the neuron. Give me the suction periosteum. See carefully. Can you see medially where the neuron is coming out? There are two openings. Can you see?
Yes, Satish, we can see everything.
This laterally is a branch of the ethmoidal artery and the nerve along. Can you see this?
Yes.
And that medially and behind, that is the first olfactory neuron. So don't get confused. Come later.
So we cauterize it here, the anti-ethmoidal arteries.
Yeah, you can, this vessel you can cauterize. No issues at all. See now, during surgery, I will not come from here to behind this level. Anteriorly, you play your game open. There is no critical structure at all. So now, how to go anteriorly? See this. This is my, 15-degree curved stylus. Now see, I am starting below. This is my level of the axilla.
Yes.
To orient you, any sinus surgeon watching this should be able to do the draft after this. Believe me, you can do it yourself. No need to look up at anybody. You can do it. It is simple, it is not difficult.
Yes.
You don't need to refer this to anybody for the draft. Believe me. See, I am going laterally, and what I am going to look up here is the outside skin.
And anteriorly, we have to take care of the lacrimal apparatus.
See this, the color change will show you the outside skin.
Satish.
Yes, dear.
Sometimes juniors ask where is the lacrimal system. So can you just show them in relation to the lacrimal system, where are you drilling?
Yeah? What?
Sometimes juniors ask where is the lacrimal system. So can you show the relation of the lacrimal system?
Lacrimal is far below, man.
Yeah. So
I am going up. This is the frontonasal process which was housing the lacrimal system below.
Yes.
My orbit is below, lacrimal system is below. See the maxillary sinus there.
Yes.
See the level of the maxillary sinus, the lacrimal is here, and I am working right up there.
Correct.
Yes, lacrimal apparatus.
Yeah. And can you see the outside limit here?
Yes.
Skin. This is skin. Let me show you from outside. Can you see?
Yeah, we can see that.
Yes.
Come later. This is my lateral limit to begin with. Okay? Now, keeping this lateral limit, you keep on removing this bone superiorly. There is no hindrance at all. There is no critical structure there in this way. See this. I have cobbleted that. Now see. Staying medial to this limit. See now? Staying medial to this. Now I will show you how you can remove this bone so easily. Now you have a landmark laterally that you are not supposed to cross. Okay?
Yeah.
And now see. See, this is diamond burr.
Beautiful.
So this is a coarse diamond burr?
This is a coarse diamond burr. And see the control over the burr. It is so, see the handpiece. It is so sleek you can hold it like a pen. You can have a very good control. It has a self-irrigation system as well. See now, staying medial to your skin. I have defined my lateral limit. Keep going up.
This mucosa is coming in the way, septal mucosa, I think.
Yeah. Say this, remove everything, whatever is coming medially. This bone.
And we are working almost superior to the axilla.
Yeah, see, I will keep going superiorly like this. It is simple. What I have defined is only lateral limit. Keep removing everything medial to it. And keep going anteriorly to the anterior skin. See, it is cutting like butter.
Satish, all your tools cut like butter.
Pardon?
All your tools cut like butter.
Yeah, this is amazing. Stylus is something, a boom for the skull base. You have seen me doing that the pituitary or any skull base approach. This is the burr. For Jain is drilling the pterygoid. Anywhere in the skull base is a...
No, I agree your instruments are good, but your hand makes it look better.
See, the beauty is, it has an inherent 15 degree, see this, 15 degree curvature. See this?
Yeah.
So that is so important, your shaft doesn't come in your way. If your drill shaft is coming in your way, that obliterates. And that is something you don't want. Cobblator. Pani. See the skin, subcutaneous tissue outside.
Yeah. Satish, where's the middle turbinate? You've resected
middle turbinate was, during previous surgery, you can see the part of the middle turbinate.
Yeah, yeah.
So Dr. Abdullah from Iran is asking, role of balloon in such case?
Balloon.
Balloonoplasty.
What will balloon do? We have to remove this cell and go beyond that. What will balloon do?
It cannot handle the bony obstructions.
I could never understood why balloon is introduced. See now. See, this is the bone I am removing. See, this is the beak, which is our obstacle. See this?
Yes, sir.
Yes.
And keep removing. See, keep removing, keep going anteriorly. See, just hold it like a pen. Keep doing. There is no critical area here. You can see yourself. Only bone and bone.
So Satish?
Yes, madam.
How do you explain to the patient about this all post-operative crusting may be there, which is not usually in routine FES cases?
Post-operative?
You prepare the patient for, to face the crusting, excessive crusting after surgery, which is usually not seen in routine FES cases. In these cases,
you have to, counsel them. You have to train them. You have to involve them.
Yes.
You have to tell them the importance of that, because that is something. See the skin, which is going anteriorly.
Yes.
Yeah.
So my limit is skin all around. Sometimes if you are using the cutting bar, you may give a button hole in the skin, then you may have to suture from outside.
So how long does it take to everything gets...
Pardon?
Healing, how long does that healing take place in such cases?
Like first 8 to 12 weeks. It heals. See now, with the irrigation, healing is no more an issue, provided the patient is irrigating thoroughly.
That is very important.
Drill. See, I am going more and more anteriorly now.
Yeah.
I am almost in the frontal sinus here. See this?
Yeah.
Yes. This is
anteriorly also you take it right up to the skin, right?
Pardon? Yes, skin, anteriorly as well.
And this is the nasal beak you are drilling out.
Now I am coming medially as well.
Yeah.
Now what is outside in? Let me tell you at this point of time, which Richard Harvey is introduced. Give me this. Yes. See, you have seen your posterior limit here. What he would do, he would not start from here, he'll come here in the end. What he'll do, looking at the posterior limit of the olfactory neuron here, he would go up and open the medial part of the frontal sinus.
Okay.
And from there he will go like this and like this. So that is outside in 40 then.
That is it.
Got my point?
Yes, yes.
So his idea is to find the frontal first and then keep widening.
Okay.
From outside in. See, this is frontal. That is the cell wall which I intend to remove. See the cell?
Yeah.
It could not
Can you
have
see
been
that?
Yes, yes. It could not have been reached.
I am working with a 0 degree right into the frontal sinus. You can see.
With 40 rad.
See, like I am sitting in the balcony now.
So this is 40 rad.
This is with a 0 degree. And
No.
this is the cell.
Blade is 40 rad.
See this cell?
Yes, Satish.
Yeah, this is coming out. You know? That is my frontal sinus now. And this is the entire cell. See the frontal much better now.
So actually, many are requesting if external camera can be.
Yeah, I am acquiring a mobile system because we didn't have external camera here. Yes, I will. See my widening of the frontal sinus from inside with probably partial removal of the cell wall. I am not sure of the complete removal. I am seeing with a 0 only. See that now? See this interior of the frontal sinus with 0 degree. Can you see?
Yes, yes.
Nice.
Now, let me widen it. Devai. See, so simple approach. Just define here, lower down your lateral limit. Following the lateral skin, you keep going up, removing this bone. What I have done, I removed this bone. Okay? Keep on removing this bone, keep on going medially, keep on widening.
Paramita.
Yes, ma'am.
So while he's drilling, I just thought we'd discuss this.
Yes, ma'am.
That the difference when you're looking endoscopically and the surgeon is not sure whether he's in a type 4 frontal cell or he's in the frontal sinus. So when you're looking from down, it looks like the frontal sinus cavity, but you're not sure about that.
I remove the part of the cell, madam. I will show you inside. I can still see partly the cell wall inside.
Yes, okay.
And I will show you after that the complete interior of the sinus.
So, Satish,
Yes, madam.
I think she's trying to tell when we are not doing draft 2. That is what you meant to say, ma'am?
I was talking about endoscopically when you're looking.
Endoscopically,
One of the
when-
major concerns that people have is, am I in a type 4 frontal cell or am I in the frontal sinus itself?
Yeah,
Yes, ma'am.
I am in the frontal. Your point is valid. I will show you. That's why I mentioned in the beginning, in the middle, when I remove partly the cell wall. Yeah.
Ma'am, you wanted to tell something?
Yeah, that is a part of the cell wall above. I'm improving my access more. See this? Everywhere the skin. Except the skin, I am going to remove the entire bone. To keep widening. Because once you are doing this, leave the widest possible opening. Earlier, there were a lot of discussion on the re-stenosis part, this and that. Believe me, with nowadays, with the concept of irrigation, that era is gone. Now you irrigate with the steroid solution and forget about the re-stenosis. That itself takes care of the neostenosis. That was the time when, this technique was introduced and the concept of, irrigation was not prevalent. A lot of people face the restenosis.
So Dr. Ravi Shankar from Bangalore is asking how to manage if one does not have a stylus drill.
Then your regular drill. The debrider bar has a speed of 12,000 RPM, you have to keep drilling for hours and hours. Yeah, look, drill the debrider.
I think you need to have specialized drills because a regular drill will not go in through the nostril and reach that area. A regular drill is quite thick it blocks the whole nostril.
See the rest of the wall, can you see?
Very beautiful.
So in a uninostril technique, it's very difficult to do it with one of the...
Can you see the cell wall now better?
Very good.
I will show you the angle scope later. Our next case is induced. It's a very interesting and I would say rare case as well, because in our series of parapharyngeal tumors, we have already demonstrated 2 or 3 carotid body tumors, vagal paraganglioma from the parapharyngeal space, then vagal schwannoma, and today is a sympathetic nerve trunk schwannoma, which is a rare, less than 50 cases have been reported worldwide so far.
You did FNSC and found it?
Pardon?
How did you make your diagnosis?
Radiology.
So that will be interesting to go through that.
Yeah, the pre-op diagnosis is very important because of from the counseling point of view to the patient. Now see, the frontal sinus, still I will open it. I am still using 0 degree. See that? Inside the sinus. I will still widen it and then I will show with the angle. Everything, all limits. But I hope everyone is getting the concept how you can easily do the draft. If somebody can do this draft too, just do the same thing on the other side. Remove the part of the nasal septum and the intersinus septum, that will be draft 3 or modified Lothrops. You can do it. Once you can do draft 2, you can do more Lothrops as well. Nothing great. See, while going posteriorly, you have to be careful. See, that is the posterior table of the frontal sinus. You are not supposed to damage it to give CSF leak. You are not supposed to come far posteriorly to damage the olfactory neuron. Can you see my limit of the olfactory neuron here? I have reached.
Yeah.
Now with this access, you can do anything inside the frontal sinus. You have access with a 0 degree. You can remove, seal any CSF rhinorrhea you can deal coming from the posterior table. This is posterior table. See this? Any CSF rhinorrhea coming from this, that will be the closure of any CSF leak if you have this access. It's a matter of access. Any tumor going into it, you can remove best with this access.
Was the interfrontal cell draining on this side or the other side?
Yeah, if you drill the interfrontal sinus septum, you will reach other side, which we are not supposed to go. See the same skin which is going. See this? Can you?
Yeah.
Anteriorly. Same is turning anteriorly. And see the limits anteriorly as well. Now, sometimes there is a decision making which has a role whether to go by, draft or by open approach. See the sinus from inside?
Yes, yes, very beautifully.
So, ultimately you have to give a adequate size opening, in the sinuses which are very narrow with a small anterior-posterior, distance. Now I am using an angled one. See this?
Yes.
नहीं रुक पहले मेरे को दो debrider. Give me the cobblator and then I will show you. See the interior of the sinus so clear?
Yes.
Yes.
No, थोड़ा wash कर दे.
So can we show with navigation now? Is it connected or?
What navigation? Yeah, I am going to show you.
Yeah.
It is connected.
Renuka madam, you were saying something about the cells, ma'am. You can just say it again.
We were talking about, we are discussing here because there's a surgery with a type 4 frontal cell and a frontal sinus. I'm not talking about the draft procedure. I'm saying that when you're doing it,
that is an important distinction you have to make.
Yeah.
That is our goal of the surgery.
Yes, ma'am. Yes.
And you can distinguish a cell from the sinus from the look as well. The cell wall is never so thick as compared to the wall of the sinus, because the cell wall is translucent,
Also, the posterior wall of the frontal sinus is always convex because the frontal lobe is there.
See the remnant of the cell. See the remnant.
Yes. Well seen. Well seen.
Now, can you see the sinus itself now? Madam, convinced?
Yes, yes. Absolutely.
Satish, let madam finish her point. Yeah, madam.
Yeah, so whereas a type of frontal cell, no matter how large it is, it will always have a concave posterior wall because it is lying within the sinus. So the main thing is that the posterior wall of the frontal sinus will be convex.
You can see the scallopings. Concave posterior wall, thick wall.
And you can see, and the second point is you can see the scalloping of the frontal sinus, which is never there in a type 4 frontal cell. So these are the two main ways by which you can differentiate between a type 4 frontal cell and the frontal sinus itself.
Okay, ma'am.
See, for this patient, my job is done. If we can do a lot of variations from here. If I remove the intersinus septal cell, along with the opening in the, the nasal sign, the septum, to come from opposite side. Suppose I have to go far laterally here, for the instrumentation from the same side, I may not be able to reach. What I can do a septotomy and come from the opposite side with that angulation. And that will be a hemilothrops. If along with that opening, I make an intersinus opening to drain the opposite sinus as well, that will be modified subtotal lothrops. There is one situation which I love doing many a time because we get a lot of revisions. If suppose somebody had done surgery on this side with orbital entry, orbital fat prolapse, lot of scarring and the frontal ostium completely scarred, closed. To drain the frontal sinus, now I will not come from this side, reverse the no. What I will do? I will not disturb this side of the frontal recess for the sake of preventing complications. What I will do? I will come from the opposite side, which is a virgin area for the frontal. Come from the opposite side and do a draft and remove the intersinus septum to drain this sinus. Without touching this, that is known as modified mini lothrops. When you come from the normal side to drain the opposite side, because the opposite side has a lot of scarring in the frontal outflow with the possibility of complications. See my reverse blade?
Yes.
Now see the frontal sinus from inside, all cell completely cleared. That is the skin, outside skin, anteriorly, laterally, everything. Wide opening of the frontal sinus. See this.
Yes, Satish,
well done.
Hello.
See this. If my section is 4 millimeter, the tip is 6 millimeter here. 2 or 3. This is almost 1 and 1.8 centimeter, so more than 1.5 centimeter anterior-posterior distance, and that is good enough to keep. Now see, this is visible with a 0 degree. You can irrigate. Your sinus is well mucosalized from inside. Can you see? It is marsupialized in the nasal cavity. That is what draft. Okay.
Satish.
Yes.
Satish, just one thing more. Do you feel that? Hello.
Pardon, sir.
Yes, sir.
Do you feel that there is a lot of raw area which you have drilled? Do you think a free mucosal graft would be a good thing here?
Yeah, a lot of people are trying. You know, we have also tried. What I can do, not only free graft, sir.
Right.
When we are doing a draft 3, we need to remove this part of the septum.
3, yes,
and
but
what you can do, I can rotate this septal flap.
Right.
Vascularized flap on the raw area, number 1. Right. I can bring the free mucosa from the turbinate, from the floor, and to mucosalize it. But believe me, with irrigation, in no time it mucosalizes. This is the, we have seen in our hundreds of cases, sir. It mucosalizes. Right. No need to do anything. Even if you don't do, you do, it is good. You don't do, nothing is required to be done. Only thing required is douching. Only thing required is the douching and drill. That is most important. And here I will show you the navigation. You wanted to see where I am? Can you see? Can you see where I am?
Yes, sir.
In the sinus. See this? Far superiorly in the sinus. Can you see in the sagittal?
Absolutely.
Yes.
Yeah.
So that is how you can reach everywhere in the sinus. This is my navigation probe. That is the way to the intersinus septum. See that? That is, you can see. So whenever you are in fix, you are in doubt, you need help, navigation is there to assist you. That is what the navigation system is.
Yes, sir. Sir, Dr. Talak from Islamabad is asking, will there be any external deformity post-operatively?
Not really. Why? Chala. ये कैसा आएगा drill? See this little bit of the bone I am removing, you know.
Dr. Ahilya Swami from Chennai is asking your incidence of stenosis in draft 2? No?
Negligible now with the thorough, you know, irrigation protocols. Negligible. See now, even this bone I can remove to widen it further. This millimeter bone. See this? See the amazing opening you have. Drill.
Satish, has an attempt ever been made to put a split thickness free skin graft?
Yeah, not that is not needed. Why to?
No, not needed. But has there been attempt in literature?
Yeah, I mean, attempted, but better to that to put a piece of free mucosa. You can acquire a free mucosal graft from the nasal floor even.
Okay. Now I'm seeing this like such a dense bone drilled like the atresia that we do. And the incidence of this free skin graft taking on such a dense bone which is drilled is less than 17 to 22% take rate.
Yeah, that is not needed. That was a small septation. See that?
Yeah.
See the size of the cavity. Draft 2, everybody can do who is doing fast, because there is unnecessarily fear amongst the people, I believe, not able to do the draft. This is the simplest of the sinus procedure because you are working in the safe zone. See, there is no critical structure in this region. Absolutely wide. Okay?
Yeah.
Any questions or we move on to the next
Uh,
case?
Yeah, Satish, we'll move on to the next case. Would like to welcome Dr. Devendra Chaukar from
Hi,
Tata.
Devendra, has he come?
Yeah, he has joined, and Dr. Bumkar also has joined.
So, hi Ashish, how are you?
Hi, good, all good.
Always good to have Ashish. Ashish is like, to me, is my mentor. I believe me.
Oh.
He has been a big source of
We are just friends, yeah.
always encouraging,
Sir,
Can I
in the
see Devendra? Has Devendra come?
Yeah, Dr. Devendra Chaukar is here. He's very much there. We
Hi.
can see him.
Hi.
Hi.
Good to have. He is one of the person, believe me, what a surgeon he is, besides what a human being he is. He is presently heading the Department of Surgical Oncology, head neck oncology at the Mecca of Cancer, Tata Memorial Center. And he has always been a, guide to me in my head and neck oncology ever since I had been in Tata in '99. And his amazing experience of thousands of head neck cancer procedures. And now under his mentorship guidance, they have started MCH programs, skull-based unit, which Prathamesh is carrying on, and so much of work. So it's always good to have. I remember in last one of our webinar when he was here, it was such a great learning experience from him. It's always when he's around. And besides that, he is our important part of our cricket team. He's an amazing cricket player. So our 2 series have been postponed because of this COVID. Otherwise, he was supposed to be in Jaipur for the match. So welcome, boss.
Thanks, Satish. Good to be here. Narayan, hi. Good to see you after a long time.
Sir, in the previous
Good to see you again.
Satish sir.
Yeah, निकालो उसको बोलना कहाँ है उसको. Hello, yes, Paramita.
Sir, Dr. Kripamoy Nath from Silchar had this query actually in the previous case he had asked, I missed it. He was asking about role of drug-eluting stent post-operative.
Drug-eluting stents have a role, yes. There are certain stents which have been approved by the FDA now. Stents are serving their purpose by both the effects. Number one, they are eluting the drug that is steroid on a periodical basis. Like mometazone eluting stent, the most popular one is Propel, which is approved by the FDA. It keeps on eluting mometazone for a period of 90 days. At the same time, by means of its spring action, it keeps on, the ethmoidal cavity open. That is an added benefit of the stent. And after that time, it self-involutes. In our country, this is not feasible all the time because the cost is a limiting factor. The one Propel costs almost now 1,000, I don't know, something like 10,000 rupees or so for us. And that every time you have to change. But it is good concept, but still the irrigation is superior because it goes freely into all sinuses as compared to the stent. So this is a part of the development going on for the betterment. The stents have been developed. So are you getting the scan pictures?
Yes.
This is a very interesting case. As I told you, in the series of parapharyngeal tumors, we have already demonstrated 3 carotid body tumors, vagal paraganglioma, vagal schwannoma, and now why I am saying it is a sympathetic schwannoma. Now I am coming to the radiology. Radiology is the key for a diagnosis, and there are certain features we need to keep in mind once we deal with the parapharyngeal tumor. There are certain concerns because there are a lot of critical neurovascular structures in close proximity to these tumors. So this tumor is obviously a schwannoma. You can look at the contrast MRI because it has a central necrotic areas because of hemorrhage or necrosis, whatever you can say, with enhancement. Schwannomas always enhance because of their blood supply, but they are not so vascular like paragangliomas. So how can you differentiate from paragangliomas? I will tell you when I go to CT angiogram. CT angiogram will give you a picture of a classical, that salt and pepper appearance of the vessels. You can get in T2 in the contrast as well. And see in the contrast, what you are getting is a variegated appearance of a classical schwannoma. Now why? The question is, why it is sympathetic schwannoma? Now if we look at the anatomy in the parapharyngeal space of the great vessels, the post-styloid compartment, anteriorly is the carotid, medially, and laterally is the the jugular vein. In between and behind is the vagus nerve, and sympathetic trunk is outside the carotid sheath but behind the carotid vessel and little medially as well. Now if a tumor arising from these structures, how will they displace the vessels? You can imagine. Suppose, like I will show that again, the vagal schwannoma which we discussed last time. When the vagal nerve schwannoma arises, how the schwannoma arises? Schwannoma arises from one of the fascicle of the nerve and displacing the other fascicles out onto the periphery of the tumor. Tumor arising from one fascicle and rest of the fascicles are compressed outside. Now if the schwannoma is arising from the vagus, how will it displace the carotid and the jugular? Because the vagus is behind, in the middle. It will displace the carotid anteriorly and medially and displace the jugular anteriorly and laterally. As simple as that. When the tumor is coming from the behind, from the vagus. Now where is the sympathetic trunk? Sympathetic trunk is not in between these two structures. It is behind the carotid and little medially as well. So the tumor arising from the sympathetic trunk, how will it displace the vessels? It will displace the carotid anteriorly. Obviously it is behind the carotid. But since it is little medial, it will displace the carotid now anteriorly and laterally.
Okay.
The vagus schwannoma was displacing the carotid anteriorly and medially. Got my point? And this was displacing the carotid anteriorly and laterally, and the vagus, the jugular will remain laterally, always behind. Now look at this. How we can see vessels? I will show you in the MRI as well as CT angiogram. Now you may ask, why did I get the CT angiogram done once it is a schwannoma? First of all, you have to prove it is a schwannoma, and that vascularity is classically seen on CT angiogram in a paraganglioma, because the first differential diagnosis is with a paraganglioma. See this. This is CT angiogram which I am going to share with you. This is not paraganglioma, you can see very well. Had this been paraganglioma, there would have been bunch of flow voids everywhere. It is not. Can you see?
Totally absent.
Now see the displacement of the vessels. Let me tell you. This is so important to understand because it has an implication in management, in the implication in counseling the patient. Because if it is a sympathetic trunk schwannoma, ultimately the function of the sympathetic trunk is going to be going to be lost. So we have to tell patient in advance that the sympathetic trunk symptoms are going to come post-operatively, like Horner syndrome, ptosis, anhidrosis, the anophthalmos, meiosis, all these are symptoms. Now look at the vessels first, why it is sympathetic schwannoma. Can you see this CT angiogram?
Yes, yes.
This is your vega, the jugular vein on this side, and this is the common carotid artery. Okay?
Yes.
Now I am moving up. See now the carotid, where it is going. The tumor which is coming from behind and medial to the carotid, what will it do? Now see, this is the tumor. See, it is displacing the carotid laterally. Where was the vagal schwannoma displacing the carotid? It would have been displacing the carotid medially. Such a simple way to differentiate. Number one. Now see, as I keep going up, now it has divided into external and internal carotid. Can you see?
Yes, yes.
External and internal carotid. This is the jugular behind. Because jugular, this tumor has nothing to do with jugular. It is further displacing posteriorly and behind. Because jugular is away laterally and behind. On the other hand, this tumor coming from behind the carotid and medially displacing the carotids laterally. What an amazing, straightforward diagnosis. Now, imagining this tumor coming from the sympathetic trunk, where is the vagus? This tumor at the same time, since it is coming from deep to carotid, sympathetic trunk is outside the carotid sheath. Yes. Vagus is within the carotid sheath. So everything in the carotid sheath is displaced, Yes. So vagus is also going to be displaced anteriorly. So somewhere the vagus is going to be here displaced between the carotid and the, jugular anterolaterally. And this you can pick up if you have a good sonologist by means of using a good, the neck probe like 7.5 megahertz. You can pick up the vagus now anterior to the tumor. And that will confirm the diagnosis if you have a good sonologist. Had this been a vagal schwannoma, the vagus would not come anterior to the vagus, would have been in the tumor. So if vagus is anterior to it, it is sympathetic schwannoma. So the first thing is displacement of the vessel, how it is. Is that clear?
Yes, sir.
Is that clear?
Hello,
Yes, sir.
Satish.
Yes, madam.
The nature of schwannoma is it is from the nerve sheath, not from the nerve fibers. So usually the functions of the nerve can be saved while removing the schwannoma.
See, that is something so interesting. Like we have shown the schwannoma of the 8th nerve in the CP angle in one of the webinar live surgery, acoustic neuroma. The same schwannoma. We have seen the vagal schwannoma. Everywhere the pre-op function was intact. Because these nerves have the enormous capacity to expand, stretch.
Yes, right.
Schwannoma, this nerve has a number of fascicles. Schwannoma arising from the epineurium of one of the fascicle is displacing the other fascicles out. So like once the tumor grows, all the nerve fascicles are around the tumor. So that's why in the vagal schwannoma I showed the intracapsular enucleation, so it preserved all the branches around. That is what I am going to do here as well.
Yes, I just wanted to ask you, because they are in tunnel, bony canal, 7th and 8th nerve, so they don't have a place to expand more, so the nerve goes off. So we are unable to save the function of 7th and 8th nerve. Whereas the vagus or sympathetic, there is a lot of space, so chances of saving the function of nerve are there.
No,
is it?
It is chances of saving the nerve is there, but the neurons are splayed around like a very, very thin bundles of nerves, difficult to identify.
Yes.
And that manipulation of those, when you remove the tumor, takes off the function. But like vagal schwannoma, believe me, with that enucleation technique which I demonstrated, 70 to 80% of the time the function can be preserved. Not always. Here also we will try to. I am not very sure. You never know the nerve behavior.
Right, you're right, absolutely.
Now see the same structure, what we have seen in CT angiogram, in the T2 weighted MRI. See, this is the nerve, this is the vein, this is the carotid artery. Can you see?
Yes, sir.
Now I am going up. See the carotid, where the carotid is going? Can you see? Lateral. And where the tumor is, that is why it is sympathetic schwannoma. The second thing I want to know here is the displacement is one thing, the upper extent, because it has a significant impact on the planning, surgical planning. See the tumor upper extent, it is going almost to the skull base. Can you see?
Yes, yes.
Yes.
So, to access that high parapharyngeal lesion, you may have to do certain maneuvers. Like we have been seeing in other parapharyngeal tumors. The first maneuver, once you start, removing this tumor, the first thing comes laterally. In this tumor, everything is lateral to the tumor. The carotid is lateral to it, the vagus is lateral to it, the jugular is lateral to it, the hypoglossal is lateral to it, because it is coming from far behind.
Yes, yes.
So, in order to expose the upper part, the first thing we will do is we will divide the digastric to go up. Then we'll certainly in this case will divide the styloid complex completely with the muscles and the stylomandibular ligament to go up. And then we'll go up the tumor to the top of the tumor. If we still are not able to go up, preserving, keeping in view the carotid artery, because in any given situation you can't take a chance on the carotid. You can't remove blindly. What I will do, like I told last time, I will go inside the tumor, take my micro debrider inside and hollow it out from inside for the tumor to allow it to fall from above.
Collapse.
And then I will separate with my finger from above easily, rather than the radical approaches people previously used to take, the mandibulotomies.
So what is your...
Mandibulotomy is the last resort to me. Before that, even if I am not able to remove through that, I will do a VRO, vertical ramus osteotomy. Will divide the ramus of the mandible through the notch down to the angle and open up the space. But mandibulotomy certainly I want to avoid. Yes, if you have to do, the paramedian mandibulotomy is the answer. And boss, Devendra, you must be doing paramedial for many regions.
So Satish, a couple of points, and you've explained the radiology beautifully. Just for people to understand, as you said, sympathetic is outside the carotid sheath. Yes. And that is why when you see them push the vessels, you said laterally and all those things. Yes. But usually when the sympathetic pushes the vessels, the carotid sheath vessels are together. It never splays, or very rarely splays.
Yes.
Even if it has to splay, it will splay the external and the internal, not the common and the jugular. If the vagus has to grows, it will splay the jugular with the common carotid or the internal carotid, depending on the situation. Yes. So this is an important point, because sometimes when they grow large, yes, this lateral and anterior pushing goes away, and you can see them pushed posteriorly. But when you see that the carotid sheath contents are together and not splayed, it gives you a diagnosis of sympathetic versus if you see a splaying of the common or the internal carotid with the sympathetic.
Amazing point.
Jugular, it's a vagus.
Amazing point. Can I add on one thing here?
Yeah, Satish, I'll just complete, just for completion of investigation. You said that angio is a good investigation. Yes, if you cannot differentiate between schwannoma and paraganglioma, the next step that you take is do a DSA. In an angio, you will see a flush on a paraganglioma. And even if you still can't differentiate, then you should do a DOTA PET. A DOTA PET will clinch the diagnosis, because a paraganglioma will light up on a DOTA PET.
Amazing point. Amazing.
Good. So these are some radiological tips which help you differentiate, because for a large schwannoma, the classic description of anterolateral versus this displacement is generally lost. So you have to see for the carotid.
Yes, amazing.
Other 2 points which I would like to differ with you, Satish, 2 points, and you said paramandibular. So lateral mandibulotomy we generally avoid.
Paramedian, I'm talking
paramedian always if you have to do mandibulotomy, because if you cut at the ramus of the mandible or at the angle, if you look at the anatomy and the mechanics of the mandible, the maximum stress of the bite comes at the angle, and that is where after a marginal, you'll have maximum fractures at that point, where you take a posterior cut, because that is why you make it boat shaped and never rectangular.
Yes.
Okay. The maximum stress of mastication is there, and you'll get a fracture there. So to avoid that, you always do a paramandibular mandibulotomy.
So what is your site for the paramandibular osteotomy in relation to the mental now? In relation to
lateral. Yes.
What is your site?
Yeah. So, and second thing is, Satish, that in majority cases, I would avoid debulking of the tumor initially, because these tumors are in loose areolar tissue and they dissect the areolar tissue around it. So generally, you will be medial to the internal carotid, because high up at the skull base, the carotid turns a little bit laterally to enter the skull base, the internal carotid, and you will get a good space between this. If you have the intact tumor and the capsule, because you will have a beautiful space. Yeah. If you debride the tumor internally, sometimes the capsule can collapse and you may lose that space. So
that I mentioned in the situation when you are not able to get above the lesion. Sure. Like last vagal schwannoma, I removed in 3 minutes. Once I reached onto the capsule, I removed with 2 fingers encapsulated.
Yeah,
but once the lesion is going too high up, you have to keep an option in mind to avoid the mandibulotomy.
Yeah, sure. So last time, well, this may not give you space, but last time we were doing a parapharyngeal metastasis of a thyroid, and what we did is we introduced a 0 degree there to see the upper end, and then under vision we dissected it. But that was for a different reason. But this may not give you that space. Yeah, and here you can just do blind finger dissection, which is
that's really great. And his point is so valid about the DOTA. See, paragangliomas have DOTA receptors, and if you do the DOTA studies and negative, you can rule out paraganglioma. What is trying to say? That is something good to differentiate from the schwannoma. But here my role of angiogram is multi-pronged. It is not only, to diagnose the vascularity, number one, to see the displacement of the vessels much better. See how this vessel is going up. Let me show you. See the carotid, how it is going. Let me go up, everywhere. The third point I wanted to see on the angiogram is the cross flow at the level of the circle of Willis. That you can additionally get this information from the angiogram. And this patient has an amazingly good cross flow. You can see this is the basilar artery here, the basilar artery, and it is giving rise to posterior cerebral artery here, and this is the communicating vessel. And this communicating vessel is joining the carotid artery. This is the middle cerebral, this is the anterior cerebral, and this is the communicating vessel which is joining this. See this? And that is a good cross flow. That is an amazing and additional information we get from this the CT angiogram. So this carotid is coming here. See this is the tumor here, and this is the carotid how coming laterally into the carotid canal. So it is compressed. See, it is so small, compressed by the tumor, with the bulk of the tumor pushed to the periphery anterolaterally, and how it is coming to the carotid canal. We can see the same thing in the coronal picture as well. If you see the coronal in this patient, see, that is the carotid artery and how it is entering into the skull base. That is the carotid artery. See how it is compressed carotid. See this is the carotid here, this is the carotid here. Far laterally, this is laterally and anterior to the tumor. That is classical of this schwannoma.
Satish, have you discussed with your radiologist, as you went up and I'm seeing this, there is a lot of blush seen at the upper end, a lot of vasculature at the upper end of the schwannoma.
This is
probably
not,
from the ascending pharyngeal.
Yeah, the schwannomas are vascular as well. They are not, They see.
So you must be careful. It is not that they are avascular. Paragangliomas are very vascular.
Schwannomas are vascular, always vascular. See the kind of enhancement they are taking on contrast. See the kind of enhancement they are. Now with this enhancement pattern, you can also differentiate between vagal and the parasympathetic schwannoma. This sympathetic schwannoma. How come? The schwannoma are composed of two types of cell, Antony A and Antony B. Antony A are hypercellular, areas with lot of cells in the groups. Antony B is loose cellular architecture. In vagal paraganglioma, vagal schwannomas, the periphery is composed of Antony A cells, And what you see in vagal schwannoma, there is peripheral contrast enhancement. That is classical of vagal schwannoma. As compared to the sympathetics, you don't see any peripheral contrast enhancement. That is homogeneous, and that is another point of difference you can make out between the vagal and the sympathetic schwannomas. Any other point to be Narayan, Devendra, anything before we start?
Oh, I think both of you have given excellent insights, so I think we should go on with the surgery. Excellent insights.
So our case is ready. In a couple of minutes we are going to start. Anybody has any question, you can ask the master. Believe me, Devendra is one who is so academically oriented, so well read, so experienced. This is always a learning experience being with him. So you can utilize this time by more and more questions from him.
So sir, in your practice in Tata, how many cases have you come across this, since this has been a very rare finding?
Yeah, extremely rare.
Okay.
Sympathetic schwannomas maybe one a year, even less than that.
Okay, and usually these don't come with any symptoms except for the neck swelling.
No, they don't. So the two differentiating features of vagal and sympathetic are, one is symptoms and two is radiology. But majority of the times symptoms are not there. Neither you have Horner's nor do you have vagal problems of altered speech. So generally you can't clinch the diagnosis clinically, so it is always radiology. And the second thing that is important for postgraduates is that if you see a swelling at the carotid bifurcation or at that level 2, don't consider it as a node and stick a needle first. Always get radiology first, because some of them can be carotid body tumors. It could be a paraganglioma that can sometimes cause hematoma and make a surgery difficult. So level 2 swelling, just don't think that it's a node and stick in a needle before you get a radiological confirmation. It is not something else.
Okay.
The first thing that comes to our mind when we are practicing in our outpatient is that you have a level 2 node, so let's stick in a needle and see what the diagnosis is. But get radiology first.
Okay. Okay.
See a parotid after this?
Yes, sir.
One more point, like what Devendra said here. Many a time the sympathetic trunk schwannomas, they present with a carotid, splaying between the external and internal, because it is behind the carotid. Now, but in this case, why it is not splaying? Because it is below. As you come up behind the level of the bifurcation, the sympathetic trunk is exactly behind the carotid. If the tumor is arising at that level, it will lead to a classical Lyris sign like you see in carotid body tumor. And you may get confused, and that time the CT angiogram is the factor which discriminates. So this is something important, because this tumor can present with a classical Lyris sign. So we are all set now, and as usual I am going to demonstrate with a microscope.
So as well as the retrostyloid parapharyngeal space, I mean, we can also differentiate. I mean, there can be differential diagnosis based on this as well, this point as well.
Differential diagnosis. There could be many things, you can differentiate. There could be, metastasis like Dr. Devendra said just now, the metastasis of the thyroid. There could be, other lymphoma, there could be some branchial cyst. There could be many things which can arise. Radiology can distinguish between all these.
So radiology can, in the initial stages, tell you whether it is pre-styloid, post-styloid, most of the cases. Unless it becomes very large and, grows to both the spaces, then becomes very difficult to tell the epicenter of the. But most of the time, radiology will tell you whether it's a pre-styloid or a post-styloid.
And by means of radiology, you can get to know, I forgot to tell in the radiology, I will show later, when the tumor coming from the post-styloid compartment, it pushes the fat in different planes, anteriorly.
Yes.
It pushes the parotid fat plane laterally. If the tumor is coming from the deep lobe of the parotid, it will push the fat plane medially towards the the parapharyngeal space. So by means of displacement of the fat plane, you can get to know where the tumor is originating from.
Okay.
Now this is a microscopic picture. Microscopic will give you the limited view, but see, once I raise the flap, I will focus on each and every area under magnification. This is how I always demonstrate. So I will take a little bigger flap in this for the demonstration here. Like every other neck incision, you have to go right to the platysma and elevate the flap in the subplatysmal plane.
So Dr. Trung from Vietnam is asking, how do you secure the bleeding for superior limit? What precautions are taken prior?
Exposure. Okay. A proper exposure is the key. Okay. You can't work blindly over there without securing the upper end of the carotid in view.
Okay.
See, this is the greater auricular going up. Can you see? And this is the vein a centimeter below, which I always mention when it comes to identification of the greater auricular.
Dr. Balakrishnan from Manipal is asking, how do you differentiate this from a ganglioneuroma?
From?
Ganglioneuroma.
Yes. Ganglioneuroma are always multiple, number one. This, secondly, in ganglioneuroma, the spread is in a different way. Ganglioneuromas arise from the perineurium and they arise from the epineurium. So they displace peripherally, but the ganglioneuromas being multiple lesions, solitary lesions, they do not displace the nerve peripherally.
Okay.
What is this point I always mention? What is this point? Gonian. Can you see the gonian here? That is the posterior inferior angle of the mandible. See this gonian? In the vicinity of the gonian, can you see some nerve underneath?
Yes, Satish, we can.
That is your marginal mandibular nerve. Right in the vicinity of the ganglion, you can always see. The nerve is going up. Can you see here?
Yeah. Very well.
This is gonian, and within 1 centimeter of the vicinity, majority of the time you can positively identify this nerve.
Important point for residents is that when you see this nerve and you're doing
Though this is not our area of interest.
I know, but when you're doing a neck dissection,
This is the nerve. This is the nerve.
to trace the nerve posteriorly, because sometimes you can trace it anteriorly when it goes up, but posteriorly it kind of dips down sometimes, and you may cut it when you're doing a neck dissection there.
Yes, I am not going to go lower down because my tumor is going up. Lower down is not my area of interest here. My entire thing, tumor removal will be less than 5 minutes. The entire thing will be, the entire time will be invested in exposure, exposure and exposure. How is the picture there, by the way?
Picture is good.
Do I do something to the focus?
Yes. Now it is perfect. Now it is perfect.
एक को इधर भी लगा दे, इधर भी लगा दे. Do this fast. अबे इधर लगाना पहले. This is my tumor here. And now what we need to be, careful is, or everything, all important structures are lateral to the tumor. This is my anterior border of the sternemastoid. That's the greater auricular and the branch of the retromandibular, which is just 1 centimeter parallel and inferior to it. This is important whenever it comes to identification of the greater auricular, which is coming from behind, from the nerve point. This vein can be a useful guide.
Yes, sternal jugular vein. So you're making plane anterior to the sternocleidomastoid?
Yeah, I'm opening up the space. That's it, quickly. Well, this time, this part you can do quick.
Yes.
This is my tumor. This is the level 2 node. लाइगेट कर देता है यार. So first thing what I will see, I will go below and find the great vessels. That will be a great guide to me as I come up.
So you will trace the nerves from below upward, sympathetic?
No, nerve is something is going to be embedded in the tumor.
Yes, but you will identify vagus and both the great vessels.
That I will try.
By the carotid sheath and work medially.
That we have to do everything to save them, I would say. You know, what muscle is this? Horizontally?
Posterior belly?
Yes. If I don't dissect it, I can't go up in the parapharyngeal space. If I don't divide this.
You have to. Styloid area complex.
See how it is coming laterally because the tumor is pushing from behind.
Yes, yes. It is bulging.
There have been many requests for you to explain the Gonian point. The ones who I think they're watching your surgery.
Gonian?
This. Yes, yes. Gonian.
Gonian we have discussed several times. It's the posterior inferior angle of the mandible. And we almost always find in 1 centimeter vicinity of that the marginal mandibular branch.
Also a landmark for identifying great auricular nerve.
Yes.
Yes, and and the facial artery, which is roughly 2.5 centimeter, 27 millimeter anterior to that. It's a landmark.
It is a good landmark. Yes.
Yeah. This patient, you know, had I forgot to show on the scan, had a huge, you know, she had started complaining of, you know, difficulty in swallowing as well because of the compression, intraoral compression by the tumor. I will show that.
So then what were her complaints? What all were her complaints?
Neck swelling, difficulty in swallowing, she started.
Okay.
And the reason is simple, that compression by the tumor.
But the sympathetic nerve is functioning normally.
Yes, no pre-op Horner syndrome.
There is no such symptom.
Unlikely to have pre-op Horner syndrome in such patients.
Okay. But yes, once we remove it, it may go into...
See, this is level 2 node. Can you see?
Yes.
And I can see the glimpse of the jugular. See, all important structure are going to be deep to the digastric. Digastric is an amazing landmark. As long as you are lateral to the digastric, your all great vessels, your sheath, carotid sheath, everything is medial to it.
So Dr. Sham Sumani. Yes, sir.
So I always, what Satish said, you know, digastric is a very good landmark, and you can run your cautery over the digastric to get all the structures. But sometimes you will be surprised. It's very rare, but we have encountered it a couple of times that the external carotid artery goes above the digastric instead of going below. So when you're running a cautery, make sure that there is no vessel above that. In very rare cases, but you have to be sure, because I used to always teach my residents that just go above the digastric, nothing comes there.
Yeah,
but
sometimes when it runs towards the parotid.
Dr. Sham Somani from Latur is asking the role of combined approach, transoropharyngeal and trancervical.
For such a big lesion, it is not, you know, the primary. See the carotid? Yes. Can you see? This is jugular. Can you see here?
Yes. There are a few questions on the role of endoscope, sir. Is there any role of endoscope in this case?
Not in this case, but yes, many of the parapharyngeal lesions, even we have been doing endoscopically. Not this lesion.
Okay. What about Devendra, sir? What is your say in this?
As I said, for the thyroid parapharyngeal med, we did an endoscopic assisted excision, not pure endoscopically. But we put the endoscope in and dissected the parapharyngeal space. It was very high up in the, almost near the nasopharynx, the thyroid met, which is quite vascular. So we had to put in the endoscope, go all around it, and then excite. So yeah, endoscopic assisted.
Okay.
See, now I am going deep, inferior to the tumor. Once I have seen my great vessels, look at this. So I'm just opening up the field. Now see, this is your jugular, this is your carotid.
Deep down is the tumor between the two.
Bipolar. ये कौन सी bipolar लाया?
So, was there any findings in oral cavity examination like bulge or something?
Huge one. Huge bulge, not only bulge, that led him, led her dysphagia. See, this is the tumor below. This is the jugular, you can see here. Can you?
Yes, yes.
And this is the common carotid here.
Yes, nicely visible.
टिप्स है बाइपोलर दूसरी लाना पानी डाल You have not seen the Vegas yet. This is left side, you can orient yourself. Yes. Yes, sir. Yes. Can you see some now?
Yes, yes.
Yes.
Nicely visible. Vegas.
Should be.
Satish, sorry, Satish, just a question. Do you need to dissect there or can you just go medial to the carotid and take a tumor off?
Pardon?
Be sure it's not arising from the vagus.
Pardon?
Do you need to dissect there or you can just go medial to the carotid and take a tumor off? Or you want to be sure that it's not arising from the vagus?
Yeah, I am not bothered about that exactly what you are saying. But it's always better if you can, separate the vagus. Let us see if we can. Because these larger tumors, once they grow, they compress everything. See, this is my nerve. Can you see here?
Yes.
Yes. Well seen.
There have been requests from Vietnam, Singapore, Islamabad. They just want me to spell. So I'll just spell. It is Gonion. Gonion.
Yes, Gonion. Now, leaving aside, I will go up and look for the excess because my concern is the excess now in this tumor. I have already told about all the maneuvers which I can do to improve my access, and the first one I am starting now is I will sacrifice this digastric first. See the tumor, it is vascular. You cannot say that it is artery. छोड़ ऊपर लगा See, this is digastric. Be careful, just underneath the digastric, you may come across the vertebral artery. I can see below there. So I am cutting the digastric laterally. Yes. And this is my vertebral artery here, which runs immediately underneath the digastric, And the other structure which I can see here now is my hypoglossal. Can you see?
Yes, yes. It is crossing the carotid artery.
No. Yes.
Sir, you're doing under microscope. What is the magnification?
Yeah, that is minimum. I have kept at the minimum. This is our vario. See, in such tumors, sometimes the bigger task is to save the hypoglossal because you have to retract high up. In more higher up tumors, the hypoglossal is sometimes a bigger problem. And larger size tumor, lot of aberrant veins, lot of aberrant veins everywhere, dilated veins also. और कर. So this is the hypoglossal going. That is the tendon of digastric. Slow. See how the hypoglossal is completely crossing the tumor at this point of time. Slow.
You're trying to go around the tumor as much as possible.
Yeah, the hypoglossal is completely,
Yes.
compressed on the tumor because the tumor is quite big in size, and the coming from deep to the hypoglossal is obviously going to compress it from below. Now see, this is how the external carotid artery and the internal carotid artery are now going in different direction. Now see the branches of the carotid here, number of branches. These are from external. We all know internal doesn't give any branch in the neck. Scissors. How to separate, differentiate the external and internal? By looking at the branches. The external gives number of branches. You have to identify at least 2 branches to be sure of the external. Obviously, as the name implies, the external one is the external. But at the origin, The internal is little more lateral than the external. Though later on it goes internal.
Yes. External remains medial and the internal remains lateral.
So this is external to me here. See this? This is giving rise to this branch here. See this? This is giving rise to another branch here. See this?
Yes, sir.
Branch in relation to the hypoglossal is always lingual. Can you see this?
Yes.
This is external. So now I can say this is external carotid. No. And this is internal carotid. Very clear?
Yes, sir.
See the plane with the carotid artery. The only thing obstacle that we have to all the time take care of is the hypoglossal. Now, see this external where it is going, like Dr. Devendra was saying. It is running towards the parotid. Can you see here? But here in this case I am going to divide this, ligate this. See this? Before that, look now. Here. This is giving to occipital artery here.
Yes.
I am dividing the external here, and it is quite, see, such a thin branch as compared to the routine external carotid scissors.
It has got pressed by the tumor.
Yeah, maybe.
Doing that for exposure, or do you routinely do this?
You know, exposure, and it is quite thin as well, because I have to go high up.
Yeah.
The opposite
would you
side.
like to not first try whether you can just retract it and go up, or you're feeling that it's too big?
Yeah, you can divide this without any issues. Now what I can see here as I go up, that is the styloid process. That forms a strong tunnel, you know. See, more and more tumor is coming in exposure.
Yes. So you are going to do something to the styloid process as well?
100%. To increase your parapharyngeal exposure, this is one of the ways, as you need to go high up. Like in one of the carotid body tumor, if you remember, I divided the styloid complex. In others, I didn't require. This is my internal carotid going. See the internal carotid?
Yes.
Yes, sir.
Scissors. Bipolar. Bipolar. That is my internal carotid. Deep to it, scissors. Yes.
Satish, we were fairly certain it's a sympathetic schwannoma preoperatively, but intraoperatively, as you have dissected the vagus nicely, wouldn't you like to follow it up and see that it is separate and you're not in for a surprise?
100% I am going to follow that.
Yes, that is
I am going to follow the vagus thoroughly. See what I am struggling here is the exposure of the hypoglossal. And see, this is the branch of the hypoglossal. Ansa. Ansa coming down. See here. Mop.
So interestingly, the hypoglossal seems to be coming out of the tumor.
No, it is on the surface.
It's on the surface, definitely, but unless until you separate it, all the cranial nerves seem to be, originating or passing through the tumor. You have to keep separating the capsule, and they will keep getting separated.
Yeah.
Now
See this?
Yes.
See now?
So this plane is going to save all the cranial nerves.
Yes, if I stay
inside
within the right plane, everything will be out of it.
Yes.
रुको इधर अंदर.
So what is your monopolar setting in this?
Minimal 20. See, this is within the capsule.
Yes. That is the important thing.
Now, let me now improve my exposure by styloid. This is the styloid process. Can you see the styloid here?
Yes. No, it's not yet clear, sir. Satish.
Styloid muscles, and more importantly, the stylomandibular ligament.
Satish, the focusing is not that very good and it is moving too much. We cannot concentrate, Satish.
Oh, really?
Yeah.
You can
and can you reduce the zoom little more, because we are not able to appreciate things. It is moving continuously.
Now you see.
So you control.
I will make sure that it doesn't move.
Satish or Deven can answer this. How often that you all have seen a schwannoma and intraoperatively you have realized it's a vagal schwannoma?
Yeah, it can happen.
Pardon? How often does that happen? I mean, your MRI reading is very good, like for that matter.
See, these are extremely rare tumors.
Yeah.
And a difficult question to answer because we've not seen many sympathetic. We've seen more of vagal.
Exactly. That's the reason I asked this.
Can you see the styloid process here? See the styloid?
Now it is visible. Yes.
Yeah,
and
you can
the
see that.
ligament as well.
Yeah, go on, Deven. I'm listening.
All right. So the important point you raised, and I think you're raising that point, is that to keep the vagus under flow always, so that you don't inadvertently damage the vagus, even if because radiology can go wrong preoperative.
Yes. See, the final is the intraoperative. See, I am removing this styloid here and cutting away all these muscles. I am absolutely lateral in a very safe zone.
So this is styloid muscle.
Yeah, all the three muscles I am cutting off. And this is the ligament. Yeah, bada le. Now see how it has opened up above.
Wash karna Satish अच्छे से.
Yes.
So that every structure becomes clear.
Now see.
Superior.
Yes. Can you see superior to the tumor?
Wash it once.
My carotid is here. I am superior to the tumor, you know.
Yeah, your finger is going.
Can you see very clear?
Not very clearly seen.
Why?
You can see your finger going above the tumor. You can see that.
Now see. Not very clear?
Satish, wash करने को बोलो उसको. तो ऊपर का superior and blood है ना. That's why it is becoming a bit.
But here it is.
We can see. We can see.
Satish, the clarity is not good, Satish, really.
Really, what happened? Can somebody see?
See if you can improve the focus a little bit. I think.
Okay. Let me first do something to the clarity. Rest of the things later. Because my tumor is going to be out in next few minutes now. Now nothing is left behind.
So
I could just enucleate the tumor.
We want to see Vegas separately.
Yeah. I have to.
Before removal.
How is the picture? Picture क्या हुआ?
Picture is okay. थोड़ा suction कर लो, clean कर लो, हो गया बढ़िया.
Yeah, it is brilliant picture here. I don't know what is happening.
It is brilliant.
Also, because it is shaking so much, it keeps on sort of.
I know the magnification probably is too much.
Yes. I think external camera will be better for this.
External camera.
Plus, the microscope is very clearly appreciable. We can make out what is the thing, but the clarity and it is continuously moving, Satish.
Okay, let's do something. Now, tell me at this moment, how is the clarity?
थोड़ा sharp करो picture को.
थोड़ा focus करना पड़ेगा.
Focus करो.
Now?
Little better.
I don't know how picture is deteriorated. See now.
It is better. It is better. Slight feeding is all around. Otherwise, the picture is better.
Yeah. See, I am onto the tumor all around. My carotid is there pushed. See there on this side.
Yes.
And what I was doing is all blunt dissection. This is all blunt dissection.
So that you're sure that you know it's not the Vegas.
The carotid artery is well away from the tumor. See this?
Anterior margin of the tumor.
Anterior margin.
So now show us the Vegas.
Yeah, I am now coming to the Vegas. Hypoglossal now here.
Keeping inside this capsule will separate the Vegas as well.
So Vegas is here.
Yes, deep down.
See, this Vegas is out here.
Yes.
Outside the capsule of the tumor, I can see the Vegas. Very clear. And this is how now I am going to go inside the capsule and isko kaat de.
Keep inside the capsule.
Yes. Oh, scissors. Scissors. Close to Vegas. See my Vegas again. This is the Vegas and it is going outside in the capsule. See that? And this is my tumor.
Would you be able to show us the sympathetic trunk from which we think
I don't think sympathetic trunk
it will not be?
can be shown. Okay.
If you keep inside the capsule even sympathetic.
Yeah. See now, I am taking the hypoglossal below, my finger above the hypoglossal. Can you see now?
Yes.
It is out. It has been out.
Good.
See the tumor. Can you see the tumor?
Yes.
Absolutely intact.
Complete.
Now see the hypoglossal there. This is the carotid there. This is carotid.
Now you wash it and show every structure.
Yeah, all the structure. Because I told you tumor removal is nothing. It is all about exposure.
Yes.
Is Devendra there?
Yes, Satish, very much.
See, it is about preservation of your structures which you want to. This some venous bleeding. This is likely. Yeah. On the parapharyngeal space. See how deep it is.
Yes, sir.
See this. How deep the tumor was and how the carotid. See, this is the carotid. This one is the carotid.
Internal carotid.
Yes. And tumor was here deep. See how deep it is. I told you last time, when you enucleate the tumor, you preserve some nerve fibers in the capsule, you know. See this? And we never ever think of coagulating this, because ultimately you will end up injuring the nerve fibers, remaining nerve fibers.
So, sir, what are the post-operative complications that we will counsel this patient?
Horner syndrome, which doesn't bother, and you know many of the patients with this, enucleation, with preserving the, see nerve fibers are there in this wall. See this wall all around.
Yes, sir.
I have enucleated, this wall is intact, and I will never, like I told last time, never ever, cauterize this wall. I will use some Surgicel and gel form and it will stop bleeding. Now, see this?
Just for completion of the discussion, two things. One, when you are doing a vagal schwannoma, you use nerve monitoring to find out where the fascicles are to incise your capsule. And second question is there a difference in the recurrence rates if you do a intracapsular versus extracapsular excision of the tumor?
Intracapsular excision and extracapsular, the difference is the radicality. Because we preserve the capsule, there is always a question behind the recurrence. Believe me, so many studies done in these schwannomas, vagal schwannomas particularly, with 20 years follow-up. They are so slow growing tumors, 20 years follow-up with hardly any recurrence. That's why function preservation surgery prevails. See now the vagus. See, this is the vagus going.
Yes, sir.
Can you see the vagus going?
Yes.
This is vagus. This is vagus.
Nicely preserved. It doesn't seem to be arising from vagus.
That's why I see the vagus completely.
Vagus is going differently.
Yes.
Kudos to a pre-op diagnosis.
Yes.
Very good diagnosis. And three very important points you brought up to differentiate between this sympathetic and vagus nerve.
The other issue these patients, like Paramita asked, bada like gel form or Surgicel, these patients face is the first bite syndrome sometimes. First bite syndrome is what? Because we take away the sympathetics, and when you denervate the sympathetics, the resultant hypersensitivity of the sympathetics is aggravated when the patient takes the first bite of the meal, because of the parasympathetic secretion and the resultant denervation hypersensitivity. So that is something sometimes bothersome to these patients.
I think the sympathetic is also going to be okay in this, because
see now what I have done, I use the Surgicel inside as a layer and the gel foam above it. I don't want to cauterize at any cost, because whatever function I am expecting from the sympathetic is going to go certainly if I cauterize there. I'll wait for 5-10 minutes. This will, or the Surgicel.
What is the next case, Satish?
It's a CA parotid, as I told, and that's an interesting one. We have seen, 3 parotids in our webinars. 2 are the superficial parotidectomies for the benign, and one was last time when Dr. Shiva was there, was a low-grade mucoepidermoid carcinoma. Today is an intermediate to high-grade mucoepidermoid carcinoma. And this was diagnosed on a pre-operative core needle biopsy. The FNAC could not reveal much, So we went for the core needle biopsy, ultrasound guided.
So you do core needle biopsy in almost every case where you're suspecting
Almost,
meningitis?
I love in parotids, core needle. The only issue is it has to be ultrasound guided. And in high grade tumors, when you suspect malignancy, there is no issue, because in benign you have a little 1% issue of injuring one of the facial nerve branch.
Okay.
But once this patient is already a grade 4 pre-op facial palsy. So the core needle, the pathology is revealed intermediate to high grade. I don't know whether it is high grade, intermediate, because this grading is very important otherwise from prognostic point of view. The grading, immunohistochemistry, everything is important. And this is based on the, nuclear atypia, necrosis, mitosis, so many things. This is pathological, classification. But it has a significant impact on the overall survival.
Satish,
Yes, boss.
in this case, for parotid, if you're saying the nerve is infiltrated by tumor, you don't have to go back to pathologist. Clinically, the tumor is telling you it's behaving like a high grade. Clinically, the tumor is telling you it is behaving like a high grade. So
Yeah, I am assuming like high grade. I will share with you the radiology now and the clinical details. See this, I will never cauterize. In 5-7 minutes it will stop. You just apply the Surgicel and press for a while, gentle press. So we could preserve all our neurovascular structures. See the hypoglossal, how it was adherent.
Yes.
So tumor removal was like child's play. It was all exposure.
And before that, diagnosing it well on radiology.
Yeah, just keep it for 5 minutes and then dekh ke band karna. So again, to show you the structures. Yeah, this is the internal jugular. This is common carotid. This is internal carotid. This was external, which we ligated above. This is hypoglossal, and here this is the vagus going, which I had shown you. This is the vagus going, which was going all the way up here. That is the vagus now. Can you see?
Yes,
Here.
sir.
Can you see the vagus?
not very clearly. Can you just watch that, Satish? And show us?
Here, this is between the prong of my artery.
Yeah. Now we can see it. Yeah.
So just wash it and just keep this light pack for 5 minutes and then they will close it.
So now, when will you decide for mandibulotomy?
Mandibulotomy I rarely do for the parapharyngeal tumors unless it is malignant. Malignant, high up tumor, yes. I can consider mandibulotomy, like Dr. Devendra said, paramedian mandibulotomy. Only for the high up, large parapharyngeal malignant tumors, not for the benign ones.
Okay. Okay, so the question then, I'll ask Dr. Devendra sir, what about, there are so many studies about the intracapsular and extracapsular, as sir was saying. So what is your say in it, sir?
So, well, these tumors are so rare that, you really can't come to a conclusion. For Vegas, they say that intracapsular, there are a couple of studies which are conflicting. One study has shown that even if you do intracapsular, the nerve function is in fact only 50 to 60% of the cases. While there is another study which says that if you do intracapsular, the nerve function is lost only in 20% of the cases. So, but in all, whatever we have in literature is that the recurrence rate by doing intracapsular versus extracapsular is not different. Now, this is very little follow-up and very few cases. So, but current evidence says that there is no difference. So, if you can do for a vagus, try to preserve the nerve, use a nerve monitor if you have one, try to go in between the fascicles and incise the capsule and excise and try to preserve the nerve. which may not be possible in all cases, but you can try to.
Okay, okay, sir.
Now, do we go ahead with the next case?
Yes, sir.
So, this is a 72-year-old male who presented with this swelling. It was long standing for more than a year, according to him. And for last 1 month, he developed the facial paralysis. Presently, he has a grade 4 obvious disfiguring facial palsy. You know, and as I already told, on FNAC could not reveal much, so we got the core needle biopsy, which showed intermediate to high grade mucoepidermoid carcinoma. Mucoepidermoid carcinoma, as the name implies, it contains the mucoid as well as epidermoid components. And in high grade, we expect more epidermoid components as compared to the mucoid ones. So, first go to the radiology. If we see this on the right side, this is T2 weighted imaging, and this is the contrast one. And what you see here is the necrotic component in the solid part. See this? The solid part is hypo on T2, but enhances on contrast, and in the solid part is a necrotic component. And that central necrotic component in a parotid tumor, you know, whenever you are in doubt or anything, is almost always a malignancy. If it's an eccentric, you know, cystic or necrotic component, that is benign. But the central necrosis is a hallmark of malignancy. And this is exactly what we are seeing here. This is some of the, one of the most important thing. Now, secondly, see this tumor, this is the skin. This is in the superficial as well as the deep lobe both, and going to the parapharyngeal space, towards the parapharyngeal space, which I am going to show you on the axial sections. Now in the parapharyngeal space, what is this? This is the jugular vein. And I can show you the carotid artery as well. Yeah. This is carotid artery, this is jugular vein. This is carotid artery and this is jugular vein. This is not involving, I would say, this is not encasing, but just going close to the, or abutting the vascular structures in the parapharyngeal space. Now, this is this is coronal. What you see in the coronal here is the ramus of the mandible. Can you see the ramus of the mandible here? This is ramus of the mandible. Hello?
Yes, sir.
See, I am coming from anterior to posterior. This is ramus of the mandible, ramus of the mandible. This is the tumor lateral to the ramus of the mandible. And as I go behind the ramus, this tumor goes from behind the ramus deep. And here is the parapharyngeal space. We all know where the parapharyngeal space is, deep to the ramus of the mandible. Now, coming to the axial sections, which are very, very important to understand the three-dimensional relationship. Yes. So these are the axial sections. Now, what is important in the axial section is, this is the central necrotic part, this is the central necrotic part. And see, this is the level of the mandible. Can you see here the level of the mandible? This tumor, this is the level of the mandible. This is involving the superficial as well as the deep lobe of the parotid. Can you see? Very yes, clear? Sir. A tumor, radiologically, this is again a very important sign. Any tumor, particularly malignant, involving the both lobes of the parotid, you can imagine that the facial nerve is most difficult to preserve, even if it is not involved preoperatively, I mean clinically. You can imagine these are the classical things to see when the tumor involves both lobes. This is a malignancy involving both lobes, the facial is going to go. And this is what this patient has already reflected, a preoperatively facial paralysis. See, this is the level of the mandible. This is how the vein, retromandibular vein is displaced, and this is the medial component, that is the deep lobe of the parotid, which is 20% of the part of the entire parotid. The 80% is superficial lobe, and this is, here it is the parapharyngeal space. This is the vein, and this is the artery. This is the vein and this is the artery. Can you see all clear?
Yes.
And here this artery is dividing into external and internal carotid, and the external carotid going into the carotid like this. See, this is so clear. So this is our lesion. Now coming to the neck below, this is the parapharyngeal space. Now coming to the neck, this is the sternomastoid muscle. This is the level 2 now here. And see, this is the vessel, this is the vessel, this is all fat. And level 2, this is level 3 you can say. And there are no lymph nodes at all, radiologically. Clinically, radiologically, it is N0. But looking at the histology of the lesion, the grading, mucoepidermoid carcinoma, that to high, intermediate to high grade, we have to do at least some sampling in the neck. There are a lot of controversies. I will ask Dr. Devendra to throw a light on it. Some people do level 2, some people do level 2 and 3 at least. Some people combine level 2, 3 and with level 1B. And some people even more level 2, 3, 1B and 5A. So, Dr. Devendra.
Yes, Satish.
Hello.
Yes, Satish. Hi.
What is your proposal for the neck?
Yeah, a lot of controversy, as you said, in salivary glands. But one thing is clear, for a high grade, you have to do the neck. The incidence of metastasis are upward of 50 to 60%. And even occult metastasis is 50 to 60%. So for a high grade, you must do the neck. The extent of neck, again, is a debate. But if you see the data from Memorial coming out, the incidence at level 1 and level 5 is about 6.5 to 7%. Having said that...
1 means 1B?
1B.
Okay.
Having said that, so clearly you have to do level 2, 3 and sometimes level 4 also if it is a node positive. If it is node positive, then you must do 2, 3, 4, 5. Whether to clear 1 is a matter of debate, but mostly if the tumor is situated a little bit anteriorly, as in this case, majority of the people would do level 1 to 5 in a positive neck for a high grade salivary gland. That would be the extent of dissection. Otherwise, you can limit yourself to level 2, 3 if it is an intermediate grade and you just want to sample the neck nodes. But for a high grade, I would do at least in this case, I would clear level 1, 2, 3 and send it for frozen. If it is negative, I would close. Otherwise, clear level 4 and 5.
Yes, so that is important. That is very clear from the master that at least we'll do level 2, 3 and 1B. What do you say? Or just level 2, 3?
1B is controversial, but I would add level 1B to this section because this tumor is quite anterior.
And
I would do it. Unless you have a posterior tail parotid tumor, where people say you have to do level 5 rather than 1B.
Suppose I do level 2. Suppose I do level 2 and it turns out to be negative and frozen. Still you expect the other level to be involved?
Skip metastasis is rare but known. So I would at least clear level, if you're not doing 1, at least clear level 2, 3. I would at the high grade at this level would clear 1, 2, 3 at least.
Yes, so we'll combine at least level 2, 3, and what we'll do when we make the parotid incision, we'll just have an additional cervical extension little more than the usual, and that will give us a space to do the level 2, 3. Level 2 we have just seen in this, the previous case, and just below until the omohyoid, if we go, will be level 3 as well. So that will be sampling for the neck. Boss, regarding the extent of parotidectomy in this particular case, any suggestion?
Total radical. Yeah, Jayesh, Narayan, please go ahead.
Radical parotidectomy, including the facial now. And my goal here, whatever the facial now, beyond the tumor which we preserve, we'll try to do some sort of anastomosis if possible. And majority of the time, we are able to do in such even radical resections using the sural nerve, and we can divide the sural nerve into multiple fascicles and do multiple anastomosis as well. Let's see, it depends upon how it turns out to be. I am not very sure how it is going to be, but one thing is sure, this parapharyngeal component from below, it is going to come out with the finger so easily, because there is a plane, very clear-cut plane from the parapharyngeal space, from the great vessels, which is The tumor is not even, I would say, abutting, it's very close to it, but it is not involving at all.
Satish, the question that we need to answer is, you said that, you know, if you resect the nerve, then we will do some sort of grafting, either an interposition graft or a jump anastomosis or something,
Yeah.
and you will rehabilitate the nerve. But in the elderly man, we have to decide whether we are going to do an implant for the eye and do a temporalis muscle sling for the angle bump.
Yeah,
That is important to discuss in an elderly, especially in elderly individual.
In an elderly patient, it is also a reasonably good alternative to do some, you know, for the eye, rehabilitation of the eye. Not only that, otherwise this, I don't know how the involvement of the masseter is going to be. Otherwise, generally what we do, we just rotate the masseter as a flap to the modulus of the angle of mouth. But since the masseter is in the field of the lesion, temporalis is a better alternative. Temporalis myoplasty, advancement of the temporalis to the angle of mandible, that is a reasonably good alternative. Let's see, in an elderly man, that can also be a good option.
What is the age of patient?
What is the age? 72.
72, okay. Then that thing I think is a good alternative, because we don't know whether the nerve branches are really acting. They may be involved in the tumor, and we unnecessarily will be doing anastomosis when the nerve functioning is not there.
Yes, that is the concern. So let's see, I hope I may find the lower branch separable, I would say. The upper is surely going to go. This is, I don't see any hope of preserving any upper branches. So eye rehabilitation will ultimately be required. Any other question or any suggestion? Dr. Devendra, you want to put any distinction from other histologies in the parotid? Had this been a salivary duct carcinoma, would you manage something different or same way?
These are all high grade mucoepidermoid, high salivary gland, undifferentiated. All these are in the same bracket of high grade tumors. In the salivary gland, and maybe in this case, I'm not sure of mucoepidermoid, but salivary and adventitic, which are high grade, I may do a distant metastatic workup just to rule out distant metastasis.
In this particular case, neck is different. Obviously, we'll send for frozen. What do you expect from a frozen in a primary case if you send? Any additional information? Any information which can change your plan?
Not in this case. No, I would not send the primary in this case.
Because it is not going to change your plans at all. Our plans are very clear.
Maybe the stump of the facial nerve if you want to go deeper and get a
for perineural invasion or something you expect. That's
Unlike
a very important point.
Just to clear your margin.
That's a very important point coming from him, and that we always must keep in mind, that perineural invasion. We have seen in a patient, all set for surgery, I got the MRI done, and patient had a perineural invasion to the level that it was going right till the CP angle along the facial nerve, and that was clearly, obviously inoperable.
Inoperable, yes. You're right.
So sometimes the perineural invasion you need to see on the MRI very clear, particularly on the T1 contrast and the plain T1 images. You can see the nerve thickened all the way along its course, the foramen dilated, and you can see track the nerve where it is going. In one of the case, boss, I give an example. One patient had a CA buccal mucosa, was operated somewhere. As usual, wide resection, neck dissection, everything went off well. Had a infratemporal fossa extension as well. But wide resection, N0, R0 resection, everything. Patient came to us after 3 months with severe headache. Everybody was ignoring that there could be nothing, you have undergone radiation, this, that. I got the contrast MRI and you will not believe, had a perineural invasion along the mandibular nerve right to the Michel's cave. And had this been evaluated with a contrast MRI, probably nobody would have operated it. Many a times, not getting an MRI done, we miss a lot of things, because this is the only investigation which can pick up perineural invasion quite efficiently. There is no other. PET can pick up, obviously, but not the CT scan can easily miss unless there is dilation of the foramens or something to that level.
Sir, can we see the fat plane?
In this,
yeah.
See this. This is a deep lobe of the parotid which is involved, and suppose this would have been a parapharyngeal tumor. it would have pushed the flat planes laterally. Now, since it is within the parotid, now everything is the tumor grows towards the parapharyngeal space, all parapharyngeal fat planes would have been pushed medially. So medial or lateral push of the parapharyngeal planes gives you an excellent idea whether it is deep lobe parotid origin or a parapharyngeal origin. Not in this case, this is not that example of that situation, but this is how you can differentiate whether it is a parapharyngeal origin or a deep lobe origin.
Okay. Okay, sir.
So do we go ahead or any other questions?
No, sir.
Anybody, this is a great opportunity to interact with Dr. Devendra Chokar. Anybody has any question in mind? Please, anything from this master?
By the time Satish washes up, do you do the primary facial nerve reconstruction in these cases? Suppose the tumor is going way anteriorly over the masseter, would you also think of primary reconstruction?
Narayan? Hello?
Yeah, Madhuri.
It should be primary because otherwise after fibrosis and all the changes that take place post-surgery, we will not be able to find...
Then there is no chance in the future.
No, I understand that.
And secondly, even if you anastomosis now and radiate later on, it doesn't affect the anastomosis at all.
Yes, that's not what I'm asking. I'm asking if the tumor is going far anteriorly onto the masseter, would you still think you would get those peripheral branches? That's what I'm asking.
At that time, you do get it, the anterior-most edges, if they are not involved in the tumor. If they are involved in that, we may not get, but the anterior margins are always there. Whether they are functional or not, that is very important. Perineural, the involvement of nerve itself. Then we decide and can do sural nerve grafting there and then only. Later on, as Satish is saying, there is no chance whatsoever. We'll have to do with gold implant and the sling operation.
That's right. Devin, you want to add anything?
Yeah, Narayan, I kind of agree with you. It's difficult to get it anastomosed, but difficult in such a radical resection to get it.
Yeah.
But as Matt said, you can anastomose when you get it.
Correct.
Is there any role of frozen section of the cut end of the facial nerve?
Yeah, we do send that cut end. That's what I said. The role of frozen section in this case is only to look at the facial nerve cut end. And then you need to drill further to get a negative. In adenoid cystic, you will never get a negative margin most of the times. But in the mucoepidermoid, you can expect a negative margin.
Okay.
Yeah, in fact, we had an adenoid cystic carcinoma, which we did about not even 10 days back. It was basically into the ear. So we resected the canal. We did a total parotoectomy plus a neck dissection. And we didn't bother to do any primary thing for the nerve because obviously it was perineural spread. We had a grade 6. So adenoid cystic carcinoma is completely different ballgame.
Different ballgame.
So Madhuri, if you would do a secondary reconstruction, say you don't get the nerve ends, would you think of sling or what are other options would you consider?
Sling is the only...
And at what time? What time? Because this patient will most probably require radiation. So what time?
So once we don't do it in this stage and mucoepidermoid carcinoma, we may not find the cut edges of the nerve branches later on. And repairing the nerve branches is not the option. Then you are only left with gold implant or temporalis muscle sling or gracilis free graft. These are the ones which are available, not the primary repair of the nerve. That will go. Because
so when would you do it? Would you do it post-radiation, pre-radiation? Of course, we know radiation.
Radiation, let me tell you, radiation does not affect the grafting whatsoever, but we shall wait for at least 3 to 6 months. 3 months, let the healing happen. Gold implant can be done there and then only, but if we are thinking of putting free muscle graft with nerve, then we will have to wait for 3 to 4 months for let the healing take place and then we'll take the free graft. Gold implant is immediately during the primary surgery.
So then again a question, although radiation does not affect the grafting, would you still prefer to send the patient first for primary treatment, that is radiation, or would you rather do a second surgery, delay the radiation a little bit and do the facial nerve reconstruction? What would you do?
Narayan, oncology first always. Complete the standard treatment. Exactly. And yes, rehabilitation is an integral part of oncology treatment, but you can't delay radiation therapy because even if you reconstruct and have a recurrence, then there's no point reconstructing it.
Absolutely.
So try to achieve good oncological control first and then look at, because you have other means of rehabilitation apart from.
But exactly. Dr. Devendra, we can do gold implant at that time only. That is part of
That is what I asked Satish. You can do it on table also if you want. In an elderly patient, these methods of rehabilitation should be thought of on table because they tolerate nerve injuries very poorly.
But we have really seen patients improving really well after primary surgery, and we get the time to do the repair or reconstructive procedures later.
Absolutely.
Satish sir? Satish sir?
So Madhuri, the point we were trying to do is make is that in case you haven't done it at the primary surgery, you'd delay his reanimation of the, you'd rather delay his reanimation, but not delay the radiation.
Not delay the radiation.
Once you do a reanimation, you're putting a, say, free flap or whatever,
Yes.
You're going to be delaying his radiation by at least about 10 to 15 days more, which could...
Yes, no. Let the radiation happen, whatever fibrosis has to take place.
No, it's not about fibrosis. You're delaying his radiation. That's about all.
Yes, you're right. Right.
So there's a question from Dr. Balakrishnan Manipal. He's asking, will you have to divide the stylomandibular ligament?
Hello?
Yes, sir.
Yes, can you hear me?
Yes, sir.
Yes. So, are you getting any picture?
Yes, sir. Yes, sir.
So,
Sir, before you start, quickly, can I ask two questions from the previous case because that is left. In the previous case, did you put drain, suction drain or something while closing?
Yeah, we put a corrugated drain.
And sir, Dr. Manish Munjal is asking, how do you manage ptosis in these patients, in those patients?
Generally, not required, but yes, ptosis is the only thing which can be managed, I would say.
At the same sitting
like the other things, you cannot do anything, there is no treatment, but at ptosis, you can manage by levator aponeurosis advancement.
Okay.
Because ptosis here is because of paralysis of the Muller's muscle.
Yes.
On the tarsal plate. And that you can simply manage, dissect the levator aponeurosis and advance it to the edge of the tarsal plate, so it will lift up the eyelid. So ptosis is the only thing which can be managed in the Horner syndrome. Rest you can't do anything.
So at the same sitting or later?
Later on, if it is required. That can be done under local anesthesia. It's a outpatient procedure.
Okay, sir. Okay, sir. Continue, sir. Then.
Now, this patient, this is again under microscope. We saw in the last three parotids, I always emphasize on the incision part, as there are 4 implications of the incision as far as the morbidity is concerned. Number 1, the cosmesis, and we always give an incision going behind the tragus like this, along the curvature of the lobule and the occipital component and the cervical. That is quite reasonably, cosmetically acceptable. Number 2, the depth of the flap we raise, that is this the SMAS, this is muscular aponeurotic flap. We need to raise a thick one to prevent Fraze syndrome. Number 3 is to protect the posterior branch of the greater auricular to the lobule. And the 4th one, not to raise beyond the parotid here to go into the masseter. That is something not to be done, otherwise we can sacrifice the branches during flap elevation only. So here the things are different. Here we are not concerned in this 72-year-old male with all this, with the cosmetic part, with the greater auricular, we are really not concerned. Till now is already gone. So I am not going to emphasize too much on this issue. But still, see, this is my incision. Intercartilaginous notch going behind the tragus. Going behind the tragus, again between the cartilage and the lobule.
Satish, Devendra here.
Yes, boss.
Satish, Shiva has joined us. for the moderation. I may have to leave for some emergency.
Yeah, you told me.
I'll log off in some time, but Shiva is there to carry on.
Oh, thank you. Thank you for
Thank
sparing
you,
your
Satish. Thanks, everyone.
valuable time.
Thanks, Satish. Bye. Thank you, everyone.
Amazing, amazing, boss. Thank you.
Devan, thanks for your input.
Bye, Narayan.
Nice catching up with you again.
Same here. Bye.
Thank you, boss. Thank you. And welcome, Dr. Shiva.
Yes.
Yeah. Thank you, Dr. Satish Jain. Thank you, sir. See you there.
Yeah,
Bye.
Devendra, thank you very much.
We had sweet memories of having Dr. Shiva in our previous webinars. You know,
hello. Thank
what an amazing discussion it was.
Yeah.
Amazing insights from him. See now, this is Dr. Shiva. This is intermediate to high grade mucoepidermoid carcinoma this time.
Okay. Okay.
With a grade 4 preoperative facial palsy.
Right. Okay.
So plan is, limited neck sampling.
Satish?
Frozen, yes?
Satish, can I ask you something? With the facial nerve analysis, could you see that upper part was more involved, or
Upper, that's what I said.
So it is not clear cut for grade 4. It is different in the upper part and different in the lower part.
Why I said grade 4? Because there was absolutely, I would say it was not a complete silence.
So we say the upper branches, temporal and zygomatic, were paralyzed, but the lower ones, like angle of mouth, was working more.
The angle was better than the upper part.
Okay.
Sir, can you focus a little more?
Yes, yes. Now?
Yes, sir.
This is a 72-year-old.
Okay.
So my plan is a radical parotidectomy.
Right.
With let's see the situation of preservation of the, reconstruction of the facial now. I am not going to preserve the greater auricular branch here. First I will go in the neck and do at least level 2 sampling. The clinically, radiologically, no notes. So we discussed with the Devendra just now.
Yes.
Some people believe in initial level 2 sampling. If positive on frozen, then a comprehensive neck dissection. Some people believe in level 2-3 sampling, some in level 2-3 1A, and some in level 2-3 1A 5A. What is your opinion?
I mean, I don't know the full details, but going by what you say, the patient, I mean, it's being planned for a radical parotidectomy with some degree of facial paresis.
Yeah.
So, can we consider this to be a T4 parotid tumor?
Oh, obviously.
Right. So, one of the indications for elective neck dissection is a T3, T4 malignancy.
But how do you see the skip metastasis in parotid?
Skip meaning, yeah, level 2 sampling, yes, for sure, if there is metastasis. In level 2, you would do definitely a 1, I mean, you at least do a 1 to 4, 3, or maybe 1 to 5, depending on what levels you have metastasis other than 2. So in this case, I would at least do a 1 to 3. Because it's a T3, T4, and because also it's an intermediate grade, I doubt if it is only intermediate because the post-op, I mean, it's a open biopsy, I mean, core biopsy, right? That's what you would do?
Yeah.
Yeah. So
and that revealed intermediate to high grade, not very.
Yeah, so this would be more likely a high grade than an intermediate is what I presume, given the picture. So I would definitely do a minimum 1, 2, 3 in this case.
1, 2, 3.
Yeah.
So my question is, if you do a level 2 sampling,
yeah,
and negative, can you have a skip metastasis to other levels?
See, we actually were analyzing our own data at, I think Chokas also might have spoken to you about this in the discussion. So we were just discussing, looking at our series of parotid carcinoma malignancies from 2012 to 19. What has been the metastatic, as what you asked, what is the skip metastasis, what levels are commonly involved? So definitely level 2 is involved, but when the grade is high, the chances of metastasis to level 1 to 3 is up to 40%. So now it's very difficult to say skip metastasis, whether it would be there in other levels or not, but definitely the metastasis, when we looked at the level wise, it was there in level 1B, 2 and 3 for sure. And a few cases had in level 5, but that percentage was less. So minimum neck dissection in this case would, you can do a level 2 sampling just to buy time. By the time you finish your radical parotidectomy, level 2 sampling helps you get all the landmarks and you can complete your parotid and then go back to your neck dissection. That would be one approach. But this is my, thought process.
Yes. That is what we wanted to know.
Yeah.
So what I will do the same way like you said.
Yeah.
So Satish, can it be brought to lower magnification?
I will let me do something to increase the distance.
It is okay. We are able to see. That is okay.
Yeah, because I can take it little bit away.
No, it is okay.
So what I will do now, I will add on level 1B.
Yeah.
I will skip level 1A.
Yeah, that's what we saw. We were just looking at the other levels that are involved in our series, and the level 1 was not often involved. Very rarely, if at all, it was involved. But 1B, 2, 3, and sometimes 4 and 5 also was involved. 5 rarely, because if the multiple nodes levels are involved, then 5 was involved, but not otherwise.
5A even?
5B for sure. We unfortunately did not have the sampling as 5A and 5B, meaning to say the specimen was not sent separately as 5A and 5B, so it will be difficult for me to say whether 5A was involved or not. It was sent together as 5.
Okay. See again, I will show my landmark. I am just hugging the platysma. See here?
Yeah.
And this is how I am going to the level of my gonian.
You consider using a skin hook to hold the flap? Just a question.
Pardon?
Do you use the skin hook to hold the flaps as you raise? The Alice?
Sometimes skin hook, sometimes Alice.
Okay. No, because the skin hook might be gentle on the skin flap.
Yes. See here I am little, this is the lesion below.
Looks like it is involving the subcutaneous area there as you're raising.
Yeah, that's why I'm staying away.
Yeah.
See, my flap is not like the way it was last time in the depth of the this thing. SMAS, complete SMAS is not, it looks like involved.
It looks like the subcutaneous fat is also involved to a large
extent. So see, this is supple. I'm raising in the way.
Okay.
So does our surgical technique change if it is so superficial?
No, you have to go wide. If it is involving the skin, you have to remove the skin.
Leaving skin is okay then?
Yeah, you can't compromise with the oncological clearance.
That's exactly what I was about to ask. Is there a need to sacrifice the skin in this case?
No, not really.
Okay.
Serious, not really at all.
Okay. Okay, yeah, that seems to be a good slide.
Though the tumor is quite superficial.
Yeah. See, this is the tumor here, primary tumor here. That is my angle of mandible here. See this?
Right. Yeah, yeah.
That is the gonian.
Dr. Kranti Bhavana is asking.
Yes.
So Dr. Kranti Bhavana is asking, when will you not operate?
When I will not operate in parotid. Parotid, I don't see in a situation where I don't operate majority of the lesions. Even if it is involving the temporal bone, the exonerary canal, I will do a temporal bone resection. Even if it is involving, we have seen a couple of cases involving the skull base, we go to the skull base and remove radically. Involving the mandible, I can remove the mandible. So I don't see any regular reason for not operating by and large. Yes, these are the lesions where surgery is the only answer. Surgery and post-op radiation.
Can I add to that, Dr. Satish?
Yeah, yeah, please.
Yeah. So I think if it's in high-grade carcinoma with a distant metastasis, is another situation where
that
probably
is
we shouldn't be operating. Yeah.
That is something different. Yes.
Yeah, but if it is adenoid cystic, you still can contemplate surgery.
In spite of the high grade, yes.
Yeah, and it also depends on the amount of metastasis that has, because typically patients, adenoid cystic carcinoma patients, tend to have a lung metastasis and not often in other sites. If it's only confined to the lung, we still can go ahead with surgery. But in general, high grade, especially for example like carcinoma X pleomorphic adenoma or a salivary duct carcinoma, then probably we shouldn't consider surgery upfront.
Here I am not, keen towards preserving the. You want me to show the marginal mandibular and all? You have seen couple of times. Here, if you.
No, you
because my tumor is right resting on the nerve.
Yes. So you want to show us the nerve from this stylomastoid foramen area?
Yes, most likely I should be able to show, because anyway I have to get a safe margin of the nerve beyond. I may have to drill the mastoid behind to get if it is coming onto the mastoid.
Okay.
Bipolar. Bipolar. That is more important in adenoid cystic. Once you have a perineural invasion, we have seen many a time patient have a perineural invasion right up to the genu of the nerve. You have to trace back and get a good margin. Frozen, sometimes skip metastasis. So many situations, See, that is the marginal mandibular. This is gonian, and that is marginal mandibular. For your demonstration, but I am not preserving here because my tumor is right onto the nerve. I am bothered about it now. Now, the thing is, I will quickly. This is the vein. One. I will quickly clear the level 1B from here. Anybody who wants to see the best of the neck dissection, go and watch Dr. Shiva operating.
Thank you again for that.
I have seen a couple of times. Quick. चल उठा.
So Shiva sir, even you use microscope?
No, if at all we use a loop We don't use a microscope.
Which binocular loop is?
We usually use, we have the Carl Zeiss spectacle mounted loops, 2x,
Okay.
2.2 to 2.5x magnification.
Okay.
That's 2.5. Yeah, that's right, 2.5. So that's the loop that we use.
Okay.
Yeah. So, and I mean, I've used microscope as well in the past, but I'm comfortable with the loop.
Loop. Okay, sir.
Yes.
Can you see the lower edge of the mandible?
Yes.
That is the lower edge of the mandible. Okay, come.
So Dr. Shailesh Agarwal is asking from Mumbai, do radiation affect the nerve anastomosis?
No.
Not really.
No.
No, not at all.
Doesn't.
So we actually discussed this in the last,
Yes.
demonstration itself. So there are ample studies which shows that even when you do an anastomosis with a nerve, it takes at least 6 months to recover without radiation adjuvant radiotherapy. Even if you give adjuvant chemoradiotherapy at any instance, it may take another 6 months more. And if it is, if a good job is done, by 12 months you can expect a recovery of the function to a large extent. And there is no second chance in parotid like this, because it's very difficult to go back in and do an anastomosis at a later date. So whenever possible, if you're resecting it, reconstruction of the nerve is best done in the same sitting.
Primary. And Dr. Shiva, because it is usually the nerve is involved in the tumor, we have to use a graft.
That's right.
Usually, we cannot be doing end-to-end repair because
No.
most of the nerve is gone.
Sure.
So usually it is already going to take 12 months to 18 months for the first function to start.
Yeah.
So, radiotherapy doesn't do much of the loss. So
That's right.
goes through the
So
nerve
I mean
like
to
I said,
say-
going through the
Yeah.
graft.
Meaning to say the need for requirement for adjuvant radiotherapy should not be a hindrance to reconstruct the
Yes.
nerve that has been
Both
sacrificed.
can be done together.
Yes, absolutely. And the other thing is you need to have the stump on both the ends, like what Dr. Satish Jain was mentioning. Sometimes you'll have to drill all the way up to the genu.
Yes.
Sometimes you'll not have a nerve to anastomose
So
at one end.
proximal stump.
Yeah,
only
yeah, that's
proximal
very
stump
important. Yeah,
is-
sometimes you can drill up to the vertical segment. Still, you can anastomose if you have a stump. It becomes difficult beyond the vertical segment. Once you go into the horizontal genu, at least it is difficult in.
What we can do is then, in those cases, you take masseter as the primary nerve. You don't go up till that and keep tracing the proximal nerve till that. If masseter nerve is okay, we can take
We
it
need
as a primary feeder.
Correct.
There we can, do a grafting.
Sure. Yes.
So zygomatic, whatever two areas are important, eye closure and angle of mouth. Eye closure can be achieved by gold implant. Angle of mouth is the basically one so that we can connect the masseter with the zygomatic and buccal branches.
Absolutely. No, what I was talking about was the proximal stump. If we want to have the proximal stump, the facial nerve to do the anastomosis, then it becomes difficult.
Yes.
Then you have to look for other
Hello.
options.
Yes,
Yeah.
sir. Yes, sir.
Hello. Are you
Yes, yes.
Are you getting the picture?
Yeah,
Yes.
nice and clear.
See, this is the digastric, and this is the mylohyoid. That is the lower border of the mandible. This is the. I'm just quickly doing this neck part so that we can focus on the primary. This is level 1B I am doing.
Yeah.
Now this is your submandibular gland. ये नहीं वो दूसरा लगा loop. Now see, this is deep to the mylohyoid. Deep to the mylohyoid, and what I can see here is the lingual nerve. You can see. Can you?
Yes.
Please focus it for us.
Yeah, that is lingual nerve. See the lingual nerve?
Yeah, it's seen now.
And here is the duct. And what I am going to do is, yes, that is the duct I am taking off. And these are the चल कर. See the post-ganglionic fibers I am cutting off.
So does this patient have trismus?
Pardon?
This patient has trismus?
Not really.
Okay. So Dr. Shiva, in these cases, do you see patients coming with trismus?
It depends if there is the deep lobe involvement, then if it is involving the fossa, they may have trismus. But if parotid with a patient, parotid malignancy coming with trismus is not very common.
Not common. If there is, then how will you manage, sir?
So that's what. So we just have to see what is the involvement. So in that case, you'll have to do posterior segmental mandibulectomy as well. You should probably remove the posterior segment of the mandible as well with your parotid.
Okay.
Can you see the hypoglossal? Can you see the hypoglossal as well?
Yeah, seen.
And now here I am going to take the facial artery.
So in those situations, you probably have to do an infratemporal fossa clearance as well.
Okay, sir.
But we don't often come across a situation where you have to do such things. Of course, there are many times where we have done a posterior segmental mandibulectomy along with the, removal of radical section of the parotid. Yeah.
Dr. Shiva.
Yeah.
When would you preserve the gland in a neck dissection, this submandibular gland, in a SOSD or anything, in oral cancers?
Now, this question of preserving submandibular gland in a neck dissection has been a question that has been debated. Many studies have come, and people have said that the gland as such is not involved even in an N plus neck.
But because unlike parotid, this gland doesn't contain any lymph nodes.
Yes, there is no intraglandular parotid lymph nodes in the submandibular gland like in the parotid, but there are a group of lymph nodes which are around it. Now, to have a good clearance of 1B, this gland also has to come out with it. Now, the second question is
the facial artery, yes.
Yeah, the second thing is if the patient is going to require adjuvant radiotherapy, which in many cases this patient might end up with, saving the submandibular gland might not help because the patient is going to have xerostomia anyways. But that is the least of the concern. But the thing is, you should do a proper clearance. So what I'm trying to say here is somebody is trying to start to do a neck dissection, shouldn't start by doing a submandibular gland preserving neck dissection, because the evidence that is there is on both sides. One thing is for sure that the submandibular gland is not involved, but there are nodes around the submandibular gland which needs to be cleared properly.
But for an experienced person like you, when you take a call?
Experienced person, yes, they can do that. But I generally do not, go towards saving the submandibular gland often, because it becomes difficult to save the submandibular gland and clear all of it, which you can do it. It's a bit time consuming, but it's possible. But there is no real advantage if you actually look at in literature. There's no compelling evidence for me to do that. That's the reason.
So there is no too much of gain in preserving that gland.
Exactly. If I'm going to really improve the patient's quality of life by leaving behind the submandibular gland, I would do whatever it needs to be, to preserve that gland. But as of today, we don't have such compelling evidence to do it. Yes, some people do. Very few people do it. There are a lot of studies which says there are some advantages, disadvantages. But then it has a lot of pros and cons. But I wouldn't advise somebody who's starting off to do a neck dissection to attempt to do this. But of course, an experienced person can take a call on a case-to-case basis.
Yes, that's a very important information.
Dr. Prakash from Devangere, I cannot type for you here. So can you please tell what step is not clear to you so that I can mention it?
I didn't get what you're trying to say.
No, sir, not to you.
See, my level 1B is done.
Nice.
उधर लगा some vein. Yes. Tie. To the level 2 and 3 quickly. The lesion is quite hard.
Yeah. I mean, I'm not seeing the images, but is there a need?
We'll show you. More. You have not seen the CT scan, no? MRI.
You can just say, just because, no, my question was, what is its relation to the mandible, and how much of the masseter is,
It is going behind the mandible.
Right.
It is entering the parapharyngeal space, just entering. Not, involve anything inside in the peripheral space. Now at this point of time, okay, see this now. That's the accessory.
Spinal, yes.
Okay.
So Dr. Rai from Kolkata is asking, kindly explain the orientation of nerve graft during anastomosis.
Yes. If we do, definitely. I'll show in detail.
Yes. And Dr. Amit Kesri is asking how to manage the mucoepidermoid carcinoma found in HPE of low and intermediate grade, where complete excision is already done.
That is something. That's how the pathology is important. That is how the frozen is important. Once you have a frozen, this question doesn't arise.
So
I think Amit Kesri has a frozen PGI.
Probably he must have got patient in his clinic who has been operated, and then he has probably seen the patient subsequently.
Such are the situations which are coming to Tata every day.
Yeah, that's right.
So Dr. Shiva can answer the best.
I'll just try to answer the way we deal with it. Again, depends on the, I think, on what duration after the surgery the patient is in. So usually after surgery, 6 to 8 weeks after surgery, at least 6 weeks, we do an MRI to see if there's any residual disease in the operated bed. That is one thing. The other thing is, if the slides are available, we just get the slides reviewed, confirm the histopathology. The third thing is, I think we'll have to talk to the operating surgeon upfront and ask them as to what was the kind of clearance that they did and all that, just to have an idea as to how the surgery went, so that you can also, that will also help in your decision making to a large extent. So whenever possible, we try to do that. So get the slides reviewed and also get an imaging done after some, at least 6 weeks, so that if you do an MRI before that, the post-op changes, the inflammation will, make it look like disease. And if there is no margins that have been, taken, or if you see any residual disease, then I think you'll have to go in and operate. If it is an intermediate or on high grade. For a low grade, you can take a call depending on what's the residual disease that is there.
Sir, is this a good case for retrograde parotidectomy, considering the bulk of the tumor? Is this a good case for retrograde parotidectomy?
But the patient already has a facial paresis, so, and we are going to sacrifice the nerve, so may not. This is probably not the right case.
और धीरे धीरे नीचे चल धीरे धीरे आ चल पंकज बोस को भेज दे So I am not taking level 2B. You want me to take level 2B?
I mean, I think yes. I mean, it wouldn't take much time. You can just safely handle the nerve and just go around it and get it out, because it's high grade. So, and level 2A and 2B parotid is important.
Yes. इसको इधर कर.
Because we have
Sir.
seen, yeah, sorry.
Yes, sir. Continue, sir.
We have seen some recurrences happening in the level 2B because that's the another in parotid level 2A and 2B is important. So I think we need to get that out. Please go ahead with your question.
So radiotherapy will be mandatory now in this case?
Yes. Yeah. So adjuvant radiotherapy is mandatory. The evidence for adjuvant chemoradiotherapy, like what we have in upper aerodigestive tract tumor, is not available in parotid and salivary gland malignancy, though there are some systematic review and meta-analysis of some prospective studies that are there. There's one ongoing randomized trial that is looking at radiotherapy versus adjuvant chemoradiotherapy. The results are awaited. But as of today, the adjuvant therapy for salivary gland malignancy would be only adjuvant radiotherapy. Addition of chemotherapy, the evidence is still not, robust. If I may say.
In these high-grade tumors, the addition of radiotherapy is must. There is no debate over it, no doubt. This is how these tumors should be taken. High-grade means you have to do everything.
Yes. Because your radiotherapy, if there is disease left behind, the radiotherapy is not going to have any effect whatsoever. Because
not the residual disease.
Exactly. So salivary tumors are radio resistant. So if at all the radiotherapy that you give, you usually use the photons, So the neutrons and carbon ions is what has some impact on salivary gland tumors, which we don't have the facility as of today, and it's not, even if it is available, the neutron is definitely not there. The proton therapy is just coming up in certain parts of India. So the surgery is the answer for this.
Okay.
So we have taken level 2B.
Great, lovely. The other thing I would like to, just tell to the youngsters or the residents who are watching this is that when you're dissecting in level 2, especially 2A, when you're adjacent to the internal jugular vein, especially in an elderly such as this, what you would always see, not always, sometimes come across is the prominent carotid knuckle in level 2A.
Yeah.
That will very much look like a node. And if you're not cognizant of this fact, you can damage the internal carotid artery there. So what I always tell our residents is that in level 2A, when you're dissecting, just do blunt dissection, be gentle.
That's a very important point.
Yes, until you see the splenius capitis, the bed of the level 2, don't use your cautery. Until then, just do a blunt dissection, use a bipolar, and then just as you round it off there, then start using your cautery. Otherwise, there have been instances where the carotid has been injured there, and it's a catastrophe there.
So my level 2 is going to be complete. Non-tooth. Only non. See the plane below? Hello?
Yeah, seeing it very well.
Yeah, my level 2 complete.
Yes, absolutely.
I don't see any significant nodes as such so far.
I think if we just clear level 3, your next
According to you, what is the incidence of, metastasis in such T4 high grade?
Yes, so that's what. So when we saw our series, high grade T4, it was like out of 73 cases, we had metastasis in close to 40 patients.
Really?
Yeah.
Oh, that is.
Yes. So that might be, I mean, that's the kind of high grades of, these advanced stages of parotid tumors that we see. It could be due to the referral, pattern as well, but that's the way it is. If it is a high grade, intermediate grade is it's not as much. Low grade definitely is less.
Yeah. And how efficiently the frozen able to differentiate between high grade and intermediate grade?
It's difficult for them to tell very accurately. They do say it depends on the on your pathologist as well. So sometimes the pathologists are comfortable, commenting on the grade, and many times they may say intermediate to high grade, but I cannot be confident. There are some foci of high grade, but then they'll say I'll require to take more sections. So whenever there is a doubt,
like it.
Whenever there is a doubt, you can consider it to be an high grade, and then do a minimum neck dissection that is required, I guess.
Yes, exactly. See, that is my this thing, omohyoid coming anteriorly. See that?
Yeah. See.
Fast. Sometime I go anterior to posterior, sometime posterior to anterior. Any of your preference?
I usually, mostly, I go from lateral to medial. So I usually like to use the knife on the, but then that's not a must.
On the jugular.
Yeah. That's not a. That's the way. You can do whatever you like or you're trained with.
I use many a time, but.
Yeah. Doesn't matter. That's not a must. The thing is, you have to have a proper clearance and go around the vein and get everything out. That's it.
Just to orient you, this was my level 1B. This is digastric, this is jugular, that's the carotid here, and this is the spinal accessory. This is level 2B about 2A down, and now lastly finishing off at level 3.
So just for the sake of the residents, the level 3 is where the omohyoid just crosses over the internal jugular vein. So that is the area, and just you'll have to round it off there.
Yes, and as I've already mentioned, we are getting this frozen done for the neck, not for the primary in this case, because primary, I don't think my frozen is going to change my management.
The only thing that from the primary that I might consider sending for frozen is the facial nerve, if at all. If I'm planning to do an anastomosis,
that is the only thing.
Otherwise, nothing from the primary. It will be, as you said, it's only from the neck. Just for the sake of the residents, as you're just doing level 3 clearance, the tendency would be you have to be above the prevertebral fascia and not breach the fascia, because your phrenic nerve will be just beneath that, your brachial plexus is beneath that.
Lot many branches.
Yes, and so and the tendency is that as you're taking the fat out from level 3, you would have the tendency to pull out the fat from level 4 as well, which you should just try to minimize as much as possible, and you'll have an ascending branch of the transverse cervical artery coming, which needs to be handled properly. Otherwise, that is one of the common sources of post-operative bleeding that could happen. So all these things.
Dr. Shiva,
Yeah.
I've seen you delivering the level 4 from here. Any tips for the audience?
So here, level 3, you just round off till the while you see the transverse cervical. I mean,
I've seen you just upper part of the level 4,
yes,
something,
that's it.
some group
Yes.
of notes.
Yes, and just round it off at the level of the omohyoid itself, and just be above the fascia, and not to go below that. And if the problem with that, when you're trying to fish out from level 4 as well, is that when you're on the left side, you might have a chyle leak. And sometimes if the chyle duct is higher up in the neck, you might have it even in level 3 sometimes. And it more often happens on the left side than the right, but it's not that it cannot happen on the right, it can happen on the right as well. So.
Yes, so on the left side, you have to be particularly cautious.
Yes, yes.
Yes. If this turns out to be positive,
yeah,
I will quickly convert to all levels.
Yes. Level 4 and 5 definitely has to be clear. Level 1A, I think we can still do away without it.
1A I can still leave, even if it turns out to be positive.
Yes.
Or for that matter, it doesn't take more than a minute to do that.
To do 1A, yeah, of course, absolutely. But sometimes what happens is when the skin is to be sacrificed, for reconstruction, we might do a submental flap. In which case keeping a level 1A, untouched helps, because the perforators for the submental flap might be preserved much better with that. So it's not that you cannot clear it, but just gives you that comfort.
See, this is what Dr. Shiva was emphasizing, this plane.
Yes. Not to breach the fascia. You can just see the phrenic nerve just about. You see the phrenic nerve is just beneath the fascia there.
Yeah. As long as in neck dissection overall, fascia plane,
yes,
you are not going to give any, major complications.
That's right.
Because not only this lower down, so many neurovascular structures, all are deep to this level. See, that's the nerve. So now you can see level 1B, 2, 3, okay?
Yeah.
And now we move on to the primary quickly. You can see clearly.
Yeah.
Now coming to the primary. First frozen. Now, see, this tumor is centered over here. I don't know, we'll be able to see the trunk of the nerve or not. Let's see. No, disease. What is that? No.
The cartilage.
So now finally we come to the primary. See, that is the tracheal cartilage. See the digestic there?
Yeah, seen there.
And very much displaced.
Seems to be infiltrating a bit of the digastric as well.
Yeah. Oh. Yeah, retractor. Let's see whether we'll be able to see the facial nerve or not here.
Yeah.
Lift. Yes.
If you have a cat's paw, I think that will give you some more space to work there rather than the right angle there.
I'm not only retracting, I'm lifting up like this. I want something to have a catch hold.
Okay.
That is the triangle point. Triangle pointer.
Right.
The tumor is, right over there.
Yes.
थोड़ा सा हटाना. Yes.
I think you'll not be able to get the healthy stump here, huh? It is all.
Let's see.
Looking at the way it is, yep. Drilling of the mastoid will be required is what it is.
Yeah, you can drill anytime.
Yeah, yeah.
We don't know the facial nerve could be displaced laterally, medially, because the tumor is involving both lobes.
Right. Yes.
लगा ना? That is the facial nerve. रुकना.
You have kept this nerve monitor?
Not really for this case. Why? What would nerve monitor help? In an already paralyzed situation.
Yes, yes. But once you use it, we can see which nerve branches really work functional till now. Only that one can be repaired. I mean, nerve monitor can help like that.
Not for repair, maybe to save the branch if possible, but the way it's sitting on the exit of the stylomastoid foramen, it looks like the main trunk will be, problem saving.
Going up to second gen, and going from nerve monitor, okay, this branch is okay, then we can do the grafting there.
I can see some stump of the nerve, I can see. I'm not sure. Let me confirm it. Give me a wash.
So I had used nerve monitor in one of my cases and it could do the repair of the lower branches. Because those were active, I could find the functioning there. So because it is the only time we can do the repair, otherwise not be able to.
See the glimpse of the nerve. Let me confirm. Seen the depth?
All tumor.
This is now.
Yes, yes, yes. Now it is visible. Yes.
Can you see?
Very clearly see.
Dr. Wasim from Saudi is asking if the carotid gets nicked, when to involve a vascular surgeon?
In the neck?
Yeah.
In the neck, you can put up stitches yourself.
No, the
In
thing
the
is
neck.
that more than repairing the carotid, you have to ask your anesthetist. The first thing is you have to ask your anesthetist to keep the patient's BP higher. That's the only time where you ask the anesthetist to raise the BP. Because we are, we keep asking the anesthetist to lower the BP all the time. This is one situation where you have to tell your anesthetist to raise the BP, so that to see to that the circulation to the brain is not hampered.
To maintain the perfusion.
Yes, and the most important thing is not to panic. Just put a gauze or a mop on the carotid. Call for help. Ask your anesthetist to maintain the BP, and you have to have the right kind of suture material to suture it. And also, and when you're suturing it, it's not going to be as simple as suturing the IJV. You have to be very careful that the intima is not left loose inside. If the intima is left loose inside, that will that will act as a nidus for a thrombus formation, and the patient might have a thrombus and it can just get dislodged and the patient will have a stroke. So suturing the carotid is very important, and it has to be done carefully under the loops or the microscope, taking care that when you suture the intima, the proline. You use a fine proline like probably 6-0, and it has to go through the entire layers of the carotid, and you can take a continuous or an interrupted. Most important thing is not to panic and ask for help.
Looking at the present situation, hello?
Yes, sir.
See, I remember the second option what Devendra was mentioning. In a 72-year-old,
yes,
you can do the reanimation. Yes.
Yes, nothing.
This now is not going to serve any purpose.
Yes, because he said oncology is.
Oh, see this, the tumor is completely over it.
Yes.
There's no point.
Yes.
So now I'll do a sort of excisional biopsy from all around. So see this?
Yes.
That is the normal tissue. You can see
the difference.
Yeah, see the message below.
Yes.
So Dr. Tapan Kanti Hajra from Kolkata is asking, role of radiotherapy in most salivary malignancy is questionable as they are radio resistant. So
yeah,
That's
its
right.
role is adjuvant.
Yes, absolutely. That's why it's not the treatment of choice for salivary gland tumor is surgery followed by adjuvant, and it's not upfront surgery for the very reason that it also depends on what is being delivered. If it is electrons and photons, that is what usually used. The photons is used to deliver, which is not going to be effective on parotid tissue.
Okay.
There are studies to show that the neutrons can have an effect on the parotid tissue, on the tumor, and so do the carbon ions. But we don't have the facility for that. And also the studies so far have shown that when you do a proper surgery and give adjuvant radiotherapy, patients do well. So that is what we need to do. And in an adjuvant setting, you're just doing a mop-up of the micrometastasis. Not really the macroscopic disease that is left behind, on which the radiotherapy will not have an effect.
But usually radiotherapy is an adjuvant therapy for that.
That's right. So that's what it's an adjuvant modality, not an upfront.
देखना क्या है? Yes, so radiotherapy is not a substitute to any surgical management.
So we take it in all grades, even grade 1, low grade also we give the radiotherapy.
I tell you one thing.
No harm in doing.
Whenever we use the adjuvant therapies, we have to be very clear in mind. Adjuvant therapy is not the substitute for the primary cancer treatment.
Primary removal.
Like if the people think that they leave a little bit of the tumor behind and then they will manage radiation, is a joke.
Yes.
Yeah, so radiotherapy, yeah, absolutely. So a proper R0 resection is very essential, crucial for salivary gland. I mean, as for any malignancy, more so for salivary gland.
See what I am doing, excisional biopsy.
Yeah. Once the nerve is involved, then it really, there's nothing, it's a biopsy.
Yes.
So coming back to the adjuvant, for low grade, I think we can definitely do away without an adjuvant therapy. It's for the intermediate and high grade is
But
where...
in low grade, we will do the intraparotid lymph node examination.
The whole parotidectomy you will do, and then it will go with the specimen. And even the chances are that the nodal metastasis, even if the intraparotid node is involved, it's going to be.
The masseter. See my plane with the masseter.
Yes.
Now, I don't want to take any chance in terms of margins around. Whatever structure it is involving has to. Masseter is least to be bothered about. Facial now, once it is involved, it is a grade tumor. It is the oncological clearance now which matters. That's it.
So that is what, if the situation demands, we can also do a posterior segmental mandibulectomy without opening up into the oral cavity.
Yeah.
So oncological clearance is very important. And in this case, of course,
I may have to do.
Yeah, and in this case, you definitely will have to ligate the external carotid artery to remove the entire parotid. Yes. So
Yes.
So can you then tell us the total?
Yeah, it is. See, you mentioned and it is there. अभी तो उसको यूँ कर अभी ligate करेंगे नीचे. Leave it. I will ligate below. इधर ले. I will ligate it formally.
Yeah. So
the overall bleeding will be minimized.
Correct. So again, a point for the residents is that when you're going to ligate the external carotid, just make sure you're ligating the external carotid. When to begin with, you have to really differentiate between the internal and external. So you have to make sure it's going into the parotid, it's going above the posterior coming.
You have to see at least 2 branches.
Yes. And then ligate the external carotid. Make sure you're not ligating anything else but the external carotid.
Come on. At least we need to see at least 2 branches. External carotid artery passes through the deep lobe of the parotid, and there behind the mandible it divides into the terminal branches.
That's right.
Now see, this is the external branch most likely. So now.
So the other way to identify here is the hypoglossal nerve will just go across the external carotid artery, and your internal carotid artery will be just deep to that.
It starts getting deep.
Can you see the branch?
Yes.
See the branch?
Yep. So that's the lingual there.
Yes. Most likely.
Yep.
Now, we saw in the previous case of the schwannoma, the way we ligated the external carotid.
Right.
Oh, branch. Wait. Catch.
Shiva, so there's a question for you from Srinagar.
Yeah.
Dr. Amir wants to know that if there is high-grade mucoepidermoid carcinoma, but if there is normal pre-op and intraoperatively, the nerve condition is good, then when to sacrifice the facial nerve intraoperatively?
So again, it depends on how much of the nerve and in which point it is involved. If it is involving if it's just going around sitting on one of the branches, maybe we can just get away with just sacrificing the branches and not the trunk. So it depends on which location of the parotid and on which nerve it is seated. And if we are not able to get any proper plane on the parotid, we cannot leave behind the disease on the nerve just to save the nerve, even if it is functioning. That is that's an unfortunate situation to be in. So, but then the plus point about that is the nerve is functioning and you reconstruct the nerve at the same sitting. The chances of the nerve recovery in a functioning nerve is much higher than chances of recovery in a nerve that has already lost its function. So that's the way to look at it, and reconstruct sacrifice the nerve, either the main trunk or the branch that is involved. and then reconstruct. If it's only one of the branches, maybe you don't have to reconstruct it. But if it is the main trunk, yes, you will have to take a call.
Okay. Dr. Shiva.
Yeah.
In this patient, has this been a functioning nerve pre-op?
Yeah.
Obviously, it is a straightforward situation with a high-grade histology.
Right.
Had this been a low-grade histology and the nerve involved then?
Sorry, I didn't hear the question. There was a...
Had this been a low-grade histology?
Yes.
And the pre-op nerve normal?
Okay.
Involved intraoperatively?
Right.
What would you do?
I would try to, create a plane and just see if I can, get the plane and get the disease off as much as
Can
possible.
you see the internal carotid?
Yeah.
Yes, sir.
Yes.
And see the loop.
Yeah.
During the carotid case, during the, the adenoid case, can you see the loop of the carotid?
That's right.
Yes.
So that is...
See the complete loop of the internal carotid. Complete. 360-degree loop. See this? This always happens in the lower parapharyngeal part, not in the upper. That's what I want to say.
Right. Now the same loop that we were discussing before when you're dissecting in level 2, now in this case the loop is, in the anteromedial direction. Now the same loop can come, 90 degrees and lie on the floor of the level 2. So that is what you need to be careful about, which I was mentioning. And so coming back to that nerve, yes, we would make every effort, to dissect and see if there's a plane that can be got, if it is a low grade. And
can you see another branch? First of all,
yes.
2 branches, one here, and one here. See this. And now I will take a call of this external carotid ligation. Can you see very clear?
Yes.
Dr. Shiva, how can you be very sure that how much nerve is involved?
So that
when it is functioning, 2 points are there. Pre-operatively, function of facial nerve is there.
Yes.
Once we have opened up intraoperatively, how can we be sure that this nerve is involved? Though function may be there, but involvement is important. How do you decide which thing demarcates that it is involved?
So if I don't get a proper plane between the tumor and the nerve, if the the epineurium, if the plane with the epineurium of the nerve and the tumor is lost, then we definitely get an idea that you many a times will get a plane on the nerve, even if it is sitting. So you have that sort of a plane that is left behind in certain cases. So that even if you're saving this nerve, you've got the disease off, and if it is a low to intermediate grade, and if it's a functioning nerve, you might think of preserving, giving that nerve behind, if it is a functional nerve. But definitely may not be in high grade.
The therapy can help us in this slight involvement of the nerve. If it is functional, we can leave it there because we're not very sure that this is involved or not.
So that's exactly the point I'm trying to make.
The external biopsy is on.
Yeah. So that call has to be taken on table as you're dissecting the nerve, the tumor of the nerve. Right?
And
now I'm taking the diagnostic here.
Yes, sir.
And that's why I think facial nerve monitor is important in these cases.
No, I would differ from that. You don't need a facial nerve monitor to actually save the nerve, or decide on whether you're going to reconstruct or sacrifice the nerve.
Sorry?
For reconstruction, even the thing is that the intraoperative nerve monitor acts, it's like a cable which is connected to a machine. You stimulate the nerve, the end plates are stimulated anyways.
Yes.
So if the nerve continues till the end plate, the tumor might be behind the area where you're stimulating. So that part of the nerve will be functioning, right? So that much you can know, that you will know even without your nerve monitor. It's at the point where the tumor and the nerve interface is there, is where the nerve monitor may not actually, matter much. You really need to know.
I tell you, to me, the biggest role of nerve monitor here, first in the identification if you are finding difficulty. Number 1. Number 2, if you have identified the nerve, at the end of the surgery you can see the response of the nerve.
Yes.
It is not the anatomical, preservation which is the only important thing. The functional preservation, and that you can ascertain with the facial nerve monitor. To take the call to take resect or not is not decided by facial nerve monitor.
Even going by evidence that is available in literature, it doesn't really help you decide whether to sacrifice the nerve or not.
So it is for reconstruction part.
Exactly. That's the point. For reconstruction as well, you need to have a stump. If it is far away from the disease, that stump beyond the disease, if you stimulate, it will go and stimulate the end plate, and there will be response that will be detected.
No, I'm not saying stimulate it at the stump. I'm trying to tell once the branching has happened.
Right.
Now beyond the disease, we can see which branch is active.
Correct.
We can do the repair from the stump to that level.
Yes, that can be one strategy. Yes.
See, now I have separated from the mandible to the mandible here. What I am going to go, because it has an extension deep to the mandible. So just I will secure my great vessel and resect it from above. That's it. See this? It is going to come. See, without removal of the margin of the mandible, part of the ramus. I am not removing that at all. Dr. Shiva.
Yeah.
Sometimes you may have to
remove it. Yes.
See this?
In this, yeah, you just see the external carotid coming into the parotid. Is that all?
Yes.
Yeah.
And see, I told you this tumor is just abutting into the parapharyngeal space. Correct. It is not deeply invading. So I can very well pull it out from behind the mandible. I can see my visualization. This is the mandible there.
Right.
So now I am away. Little bit of the venous bleeding in this area is acceptable.
So once the mandible has to be removed, it's a sort of a simple procedure like a posterior segmental mandibulectomy that you do for an oral cavity surgery.
Yeah, without entering into the oral cavity.
Oral cavity, without entering into the oral cavity. The only thing here is that you will end up ligating the external carotid artery and nothing much.
See this parapharyngeal tissue?
Yes.
So now I will take this vessel here.
Yeah.
And get the specimen. I have already ligated it below.
Right.
Yes.
So we would, just for the residents, we would always double ligate any named artery. That's the standard teaching, and then sometimes you might do a transfixation with a proline or something like that. But if it is
I've seen you using a lot of clips.
Yeah, we do use clips, and we use a lot of the free ties that you're using right now.
Yeah.
On named arteries and vessels, we definitely ask our residents to double ligate just to be on the safer side. Nothing else. So that you can go back home and sleep well, nothing more.
See now, we saw in the radiology the closeness of this tumor to the jugular and the carotid. Let me show you the relationship as it has been now elevated of the important structures.
Sir, at what point external...
Negative. Hello?
Yes, sir.
The frozen is negative.
For the nodes. Oh, great. That's great news.
Great. So at what point external carotid artery should be ligated, leaving which branches?
Yeah, external carotid has to go. Once you have a parapharyngeal extension, you need to remove the deep lobe right into the parapharyngeal tumor.
So you'll have to ligate the external carotid just as it's just below the entry point into the parotid.
See, this is the parapharyngeal space now. See this?
Yeah.
My vessels I am leaving below. See this?
Yeah.
See my internal jugular left below here. Can you see?
Yes. Yes.
See the jugular going down. See that?
Yes.
And the carotid even more medially.
Right.
Here. Now I am at the verge of removal of everything. My specimen is coming out.
It'll be just hanging on the facial nerve if I have not cut it still. Or
See, I have a good cuff of tissue.
yeah.
Everywhere. And here my bipolar is the key tool. This is the digestive I am cutting here.
Yeah.
This is a part of the digestic. Scissors. Oh. See the final picture and the relationship, the structures I am going to show you. And see here, many a time this tumor ascends to the skull base, which we have removed, following right to the jugular foramen. See this. Just for your orientation, see this is level 1 neck, this one. Then digestic, it is cut over here. Level 2, 3 dissection. The hypoglossal here, the jugular and the carotid. Then this is the mandibular surface. See this, the masseter. Completely everything free, everything supple all around. This is a classical radical parotidectomy.
Anything for the stump of the facial? I mean, would you be tracing it back or sending it for frozen?
No point, boss. It is. It was right onto the foramen here.
No, it's not because to save the nerve. It's just to get a frozen.
No, but I could see a centimeter or so, a good healthy facial now.
Right, that's the point. It's
yeah, no doubts about that. Not the slightest of the doubt.
Right.
So now, what we have achieved is a radical parotidectomy, and see the defect. The defect is sometime, bothersome to the patient. This parotid loss defect, see this area right towards the skull base. See this?
Yes.
Dr. Shiva?
Yeah.
Would you do anything additional here?
No,
as
that's
far as
the only. Nothing in terms of clearance. I would just trace the facial nerve and get a frozen confirmation that it's negative. Yes, you said I saw the nerve as well.
Yeah, but I am sure. So that is to me.
Yeah. So that is the one additional thing that I usually do. That's all. Especially because the patient had a facial nerve palsy. If he wouldn't have had, then
I know, but I know the way the facial nerve was exiting the foramen. It was okay at that place. Now see, this is going to be the defect. This is going to be the parotid loss defect to this patient. See this?
Yeah.
So that is all about the radical parotidectomy. The frozen is negative. Had this come negative, positive, see, many of the levels we have already done. One I would leave. Only thing left was a level 5 and a 4. 5 is just behind the sternemastoid till the trapezium. 5A above, 5B below, and a level 4 is hardly anything left just below this thing, omohyoid. So this level 4 and 5 left, which is not required, otherwise we could clear in 10 minutes. So this is the clearance about this patient. So just wash kar beta mop kar. So we'll close it. We'll not do any reconstruction here, no point. It was quite massive tumor. This is real high grade tumor. Now I can say this is not intermediate grade for sure.
Yeah.
This is real high grade tumor, and what we'll do post-op, let's see the Bell's phenomena. If required, we'll do a gold implant under local anesthesia for this patient.
Okay, sir.
Anything else? Anybody? Our next case is getting ready. So now is the time for otology cases. We have seen the nose, throat, head and neck. And now otology will start with the stapes. Then we'll have malignant otitis externa with a atypical presentation. Many of the malignant otitis externa will take in future with different presentations, different presentations.
Yeah. So.
I just
Yes, sir.
I'd like to thank again for having me here for this. So I just
Sir,
would like
we
to
are
thank.
really thankful,
Yeah,
sir. It was very informative. So whatever you shared with us, it was really very
Dr.
informative.
Shivakumar, thank you so much for filling in
Thank you,
last
sir.
minute. What a Kirtani here.
Thank you, sir. Thank you so much, sir.
No words to express our gratitude.
Yeah.
Thank you.
Dr. Satish. Thank you. See you some other time.
And
Bye.
soon we are coming with the next case.
Thank you. Bye.
You know, Shiva, we are also doing one more malignant case, but it's not a malignancy in that sense of the word.
Yes,
it's
sir.
a malignant otitis externa. It's a purely otological case.
Sure. Yes, sir.
Anyway, so thank you very much for your time, and God bless. Thanks.
Thank you. Thank you so much, sir. Nice talking to you.
Vijendra, sir. Hello.
Good evening.
Good evening, Vijendra, sir.
How are you, Paramita?
I'm good, sir. We are so happy you will be here with us. We can share your expertise with us. So, the next two cases will be having interlate tympanoplasty and a stepidotomy.
Okay.
And I don't know, they're deciding on malignant otitis externa as well.
Yeah. Thank you. So at the outset, I sincerely thank Milan Kirtane sir for giving me this opportunity, and also for the Alchem people. They have done a wonderful job. As usual, Dr. Jain is most enthusiastic and a wonderful surgeon. And I don't know what is the reason behind him for the wonderful surgeries.
Yes, sir.
I'm grateful to.
I don't know why we have not. I mean, even Madhuri told you, and Government told you.
Wonderful job in the whole world. Hats off to Jain for his wonderful. I've been watching all his webinars so enthusiastically. Every time we watch, we learn so many things. And really is a great surgeon. Hats off to him.
Yes, sir. Yes, sir. We have been doing many webinars till now. There's been 17 webinars, live surgical webinars, and in this pandemic situation, conducting these live surgical webinars is really rare. And for this, we are thankful to Kirtane sir for today's and Alchem for organizing this. Kirtane sir?
Yeah.
Yes, sir. So we'll have the next case with us.
See, what Satish is saying is that he'll do the stapes now.
Okay, sir.
And then there is an interesting case of malignant otitis externa going to the TM joint, which we would all like to see.
Okay,
Yes.
sir.
Okay.
Okay.
So he's starting with the stapes now.
Okay.
And then, so both otology cases right now.
Fine.
Okay.
Okay, sir.
Okay, sir.
Yeah, Paramita.
Yes, sir. Hello? Hello? So,
Sorry,
sir?
I just got up. Did you ask me anything else or what you said?
No, sir, nothing.
Okay, no, you were saying something. You said something about Alchem, etc.
No, yeah, we are
we are
thankful.
still going on the program.
We were thankful to, yeah, we're still going on, but I'm just saying that we're thankful for today's event organized by Alchem. So,
yeah, they are amazing as far as supporting educational activities are concerned.
yes, yes.
And what is very, very happy to work with them because they never dictate to you, we want this, we want that. They just say, we want a good scientific program.
Yes.
And I think Satish is giving us the best.
Yes. Yes, sir.
Hello.
Hello.
Yes,
Hello.
sir.
Yes, sir.
Hello, Satish.
Yes, sir. Good afternoon.
I want to know what is the secret behind your such energy, enthusiasm, and this thing. Just tell me the secret.
You are the boss.
Amazing, boss. Hats off to you.
Yes,
Thank you, sir. Thank you.
But you didn't tell the secret.
Your blessings.
Huh?
Your blessings.
Modest answer.
So now
Yes, sir.
we are taking one after another is a stapes and a case of malignant otitis externa
Yes, sir.
with a atypical presentation. You know, so stapes, we have already discussed a lot about the stapes cases in the previous webinars, including our stapes, dedicated stapes webinar with Ashish and Ashim. And this case, again, has a moderately severe conductive hearing loss. CT scan is something we always get done to know any surprise, which we may get intraoperatively otherwise. The only thing in this CT, I don't see the oval window region very, very clear. I have a doubt on the clarity. Rest, everything is clear. If I see from above downwards quickly in 5 minutes about the certain salient points on the CT scan, we must see to rule out surprises. Number one, to see if there is any, you see this is lateral canal. This is lateral canal. To see any superior canal dehiscence which may be leading to a misdiagnosis. The intra-aortic canal, it is absolutely perfect in dimension, everything. This is cochlear aqueduct. This is, the jugular bulb. This is round window here. This is round window absolutely free. This is jugular bulb. And here, see how the stapes is going to the oval window. This is facial nerve, and facial nerve is not prolapsing. This is how you can see the facial nerve is not prolapsing and has a good oval window space.
Okay, correct.
So this is generally we see on a CT scan to prevent any intraoperative surprises. It is always good to have.
Yes, sir.
That is how often you see superior semicircular dehiscence?
What?
How often you come across superior semicircular canal dehiscence in your
Not very common. Not very common. But yes, facial nerve dehiscence, facial nerve prolapse.
That is common.
Yes.
But superior semicircular canal dehiscence, as so many literatures are there. Now,
Yeah,
how much is that? But how many cases you have seen in your experience?
Not common. I have just seen a couple of cases in life.
I agree with that.
And we have repaired them.
Yeah. But there are articles where they say 50, 100 cases they have seen. I don't know. How is it possible?
Yeah, because they are getting imaging, more and more imaging done. The problem is, many a times, less than 10% of the people are getting imaging done in autosclerosis. If we get imaging more often, probably we may get more cases. Same is with the lateral skull-based pathologies as well.
But of late, you are also doing for almost all the cases, no?
Yes, nowadays almost all, and we just couple of cases we have got, not many.
But so much of things have been talked about the superior dehiscence. There's so many papers. They claim that so many series of cases they have been watching.
The reason is because it is a misdiagnosis if it is, and second is it is a treatable pathology.
Okay.
It is a treatable. once you get evidence of superior canal dehiscence, you can
Yeah.
go by middle fossa approach from above and put some bone wax or something, bone
I
dust or
agree with
something. It
that.
is so easy.
The incidents what they publish and all, and with
It
your
is too much, too much.
too much. No, very rarely I see, as
Yeah.
my experience.
I understand. Your point
No,
is,
Satish, sometimes we've seen superior semicircular canal so-called dehiscence in the CT scan, but the patient is completely asymptomatic. So
yes,
sometimes that we have seen.
patient may not be having vertigo or anything. And I have gone through Kirtner sir's publication on it by transmastoid approach.
Yes.
Yeah, we did it under local anesthesia, so that was very simple.
Yeah, that is one of the approach.
But Satish, since we are talking about it here, can I just mention something?
Yeah, please.
You know, what you're saying is going and sealing the fistula by middle fossa, even that is not necessary. If you definitely have a fistula which is symptomatic, the idea is to obliterate that canal, like you do posterior canal obliteration for BPPV. You want to obliterate this canal. So what people also can do is transmastoid. You outline the superior semicircular canal like you outline the lateral canal.
Yes.
You blue line it. You know what you call, you do a double blue line and take off the bone so that you expose the semicircular canal lumen now. And instead of going through the fistula, you can block the canal from the mastoid side. The whole concept is you want to block the canal.
Yes.
So that will automatically take care of it.
Can be done transmastoid.
And just lift up the
reason is,
dura and put a cartilage.
Yeah, the reason is the ease. Ease with the middle fossa approach is much more. It is straightforward. You are coming from above and
Satish,
see
you're
the
talking about yourself. Not every ENT surgeon is so used to doing a middle fossa approach.
Because in the transmastoid, going right above in the circumference of the canal sometimes is difficult.
No, you don't have to. You just do a mastectomy. Don't bother to go towards the fistula. You skeletonize the superior semicircular canal and do a blue line there and open the canal and pack from there. You don't have to go to the fistula. If you want to close the fistula, just thin out the tegment, lift up the dura and put a cartilage from there. You don't have to go around anything.
I've seen what you had done in that publication.
I agree with Ketan sir. It's a very simple
Yes,
procedure.
sir. Yes, sir. Yes. No doubt about it. Secondly, we are trying to get more and more steppies to see the variations if we get. So, in one of the case, I had shown the reverse stepidotomy by the fish. Majority we do with the laser, so that we don't do any mechanical, movement. And in case I get a case to do by different technique, I'll definitely show you that. That's the reason for keeping steppies cases. These are, the cases don't take long. My associate is already, opened the ear, lifted off the flap and all. So it won't take long. In case laser is required, I'll be through in 5 minutes. And in case something different, I would like to show that. Because one should be able to deal with all those variations or difficult situation we may come across in stapes surgery. And the next case is going to be a malignant otitis externa, and what I can share right now before going to that is yes. So quickly I will go from that case to other case.
Yes,
so
sir.
to diagnose this malignant otitis externa, like Krishna sir was saying, it is not malignancy to an oncologist. The course is malignant. Because of the nature of the disease, the course is so refractory to treatment and so, sometimes even fatal. So the course is malignant, that's why it is called malignant otitis externa. There are so many terminologies: necrotizing otitis externa, diabetic ear. I believe in this terminology of the diabetic ear because most often it is in the diabetics who are immunocompromised for the reasons because of low vascularity, because of microangiopathy, low blood supply to the area with superadded Pseudomonas infection. Pseudomonas itself is so virulent. And in diabetics with the added on low phagocytic activity of the neutrophilics to combat infection and all, perpetuate this situation. So this is mostly in diabetics with low vascularity. Similarly, what we see the diabetic foot, that is a gangrene. It is similarly gangrene of that area with less vascularity and the infection superadded, which is not allowing the antibiotics to penetrate and give a persistent problem. And this is so difficult so bothersome to the patient having severe nocturnal pains or telangia. These are the criteria described by Levinson to diagnose, and many of the patients are straightforward with the diagnosis. Any patient coming with a history of a diabetic patient with a severe pain, ear discharge, granulation in the extra-auditory canal, and on culture pseudomonas is straightforward a diagnosis for malignant otitis externa. But the presentation is so varied, you know, the extension of the disease depending upon how the patient is presenting. Many a time patient present with a limited granulation and with a, you know, a very thorough local treatment and the antibiotics, because the mainstay is antibiotic. It's a infection. You cannot you know, do anything to an infection but to give antibiotics. And here pseudomonas directed antibiotics, when it involves the bone, you know, for the bone to revascularize, it takes weeks. That's why you take weeks of antibiotics. Weeks of, you know, culture directed IV antibiotics for weeks. And it is so frustrating to the patient with the same problem persisting, sometimes not responding to anything. So sometimes present with a necrosis in the temporal bone, sometimes present with necrosis in the infratemporal fossa, other areas, extends to the skull base, then it is named as a skull base osteomyelitis, sometimes extends to the central skull base, named as a central skull base osteomyelitis, involved in the course of disease, the cranial nerves, earliest is the facial nerve, then lower cranial nerve as it goes medially deep into the jugular foramen and other areas. And this particular patient has a disease which has crossed anteriorly from the external auditory canal. We all know, like in malignancies of the external auditory canal, the way it extends into the parotid through the fissures of Santorini and foramen of Haskell, it has eroded the temporomandibular joint and pushed the joint anteriorly, and that necrotic area, this patient has taken antibiotics for more than 1.5 months. And this is how the role of surgery is not a primary treatment. Primary treatment for an infection is antibiotic. What all we can, you know, help the patient with: improvement in the glycemic state, controlling the diabetic, improving the immunocompromised situation of any deficiency of other things by improving the, you know, give the antioxidant, vitamins, whatever, to improve the immune system. But by and large, the treatment is antibiotics. Surgery has a role either in non-responding cases to take a biopsy. Sometimes it is difficult to discriminate from a malignancy ongoing, and sometimes it's a, you know, co-malignancy along with a you are biased with a diabetic patient with infection pseudomonas towards a malignant otitis externa, and it turns out to be a malignancy along with. So many times in non-responders you have to take a biopsy, and that's how surgery is important. And secondly, surgery for anywhere. If it is a necrotic lesion with no vascularity, obviously you have to debride it until you get the fresh vascularity all around. That is the goal of surgery only. That is the role of surgery. Now, whatever structure is involved, necrotic, if the bone is necrosed, obviously you have to remove. If the soft tissue areas are necrotic, muscles you have to remove. I have seen in a case where the entire carotid artery got necrosed, thrombosed right from the lower parapharyngeal to the cavernous portion, the entire carotid got necrosed, and I had to completely debride it without any drop of blood. Sometimes the necrosis extends across the infratemporal fossa right to the nasopharynx, because this is so varied depending upon the immune system of the patient. In diagnosis, many a times there are a lot of points to be taken care of, because the diagnosis, a correct diagnosis is important. So overall, like any other situation, imaging has a role. Imaging are, you know, here in malignant otitis, there are certain concerns from the imaging point of view. First of all, a correct diagnosis, correct extension of the disease, then to know the progress of the disease with your treatment. You know, if you are giving antibiotics for 4 weeks, how it is responding or not. So how do you assess? You have to ascertain the response as well. So that imaging is divided into anatomical and functional imaging. You know, we live in India, we can't get functional imaging so often done. The cost is a big limiting factor. So many a time we rely on ESR. A simple ESR with your treatment, if the symptoms are better, with the ESR coming down, that means it is responding and no need of further imaging. Anatomical imaging has a limitation because it can show you the lesion, the areas, necrotic areas, more with the MRI with different, sequences, that what are the areas are inflamed, what are necros, what are abscesses, or what are normal areas, or marrow involvement, bone marrow involvement, everything you can ascertain from MRI, not from CT scan. But it cannot show you the treatment response, because even if the patient is cured with the disease, if you get even after 6 months the MRI done, you'll see the same changes. So MRI changes don't revert back to normal so soon. So the anatomical imaging has a limitation, and then you have to bring in the functional imaging. Hi boss, I can see the Dr. Ashim Desai, champion.
Hey boss, how are you?
Welcome, welcome.
Thank you.
Great. So we are starting some otology cases, and your presence will definitely boost us. The 2 cases we are taking, we have already started the stapes and the malignant otitis externa.
Yeah.
So we are discussing some points about the diagnosis. The main difficulty comes in the assessment of the treatment response. Here comes the role of functional imaging. What I mean? Functional imaging will tell you the metabolic activity. Like for example, there are many ways of assessing the functional, the functional imaging. One is by means of gamma imaging and one by means of beta tracers. So gamma is like technetium. Whenever there is active osteoblastic activity, the technetium scan will show you the osteoblastic activity. But again, it has a limitation, because even if the lesion is gone, cured, still the activity will show on till longer period afterwards. So it is not good for response. Secondly, the gallium. Gallium is a good scan. We got done sometimes. The cost is a limiting factor again. But the true value of the gallium is it detects the dividing cells. So whenever the patient is better with the treatment, the activity will reduce immediately. So if the patient is cured, get the gallium, confirm with the gallium, all functional activity gone, you can assume that the patient is cured. But the limitation is the nuclear imaging. This is the nuclear imaging which has its own adverse effects, cost, and so many other things. You can't push the patient again and again so frequently. So nowadays in the present era, what we are getting done is the PET. PET, we all know, it detects the metabolic activity. It doesn't discriminate whether it is a cancer, whether it is a infection, whatever. But it will show the high glucose activity. And that's what we want to see here. The beauty is PET, if you can do with a CT or MRI. Here we prefer with the PET MRI because we get the functional activity as well as the anatomical information by the MRI. Because MRI is more useful than CT scan as far as these lesions are concerned. MRI gives a lot of information about the spread of infection to the soft tissues, because CT scan doesn't give you soft tissue spread. Like in this patient, let me tell you quickly. See this patient on this side, left side. See this canal is blocked by the granulation tissue. Here you can see this is a non-contrast CT scan. And what you see here, the destruction of the anterior canal wall, and see how the TM joint is expanded. Can you see?
Yes,
and
yes.
see the joint is pushed anteriorly.
Yeah.
See, as compared to the opposite side with the normal side, see this is the normal side with joint intact and the joint space normal. Here the joint space is expanded and the joint is pushed quite anteriorly. Can you see this?
Yeah.
Yes, sir.
This is one of the atypical presentation. I have seen in my life 2 cases with this presentation and turned out to be fungal ultimately. They were not responding at all to the medical management. That time I didn't get the galactomannan test done. This time I got the galactomannan, it is not convincing. It is not always convincing, so still I am not sure. If the galactomannan is positive, I would have started the antifungal straight away, voriconazole for such patients. So the serum galactomannan is a quite important test in situation when you suspect fungus, when it is not responding to the antibiotics. But here you can see how much of the anterior canal is eroded and the TM joint is affected. And this is something need to be treated, which we are going to take. Now see the mastoid. This is inflammation of the mastoid hair cells, but I don't see any significant bone erosions in the mastoid. Obviously the canal is full of granulations and all that. It is more an edema and infection than the discharge. Middle ear looks normal, I suppose, looking at the conditions. But the thing is, this is anterior extension. Now look at the details. CT will not tell you anything more than this. MRI can give you more information. Let me put up one by one. First, T1 weighted MRI. T1 weighted MRI gives you a lot of information because this assesses the bone marrow. Can you see the bone marrow enhancement? In any skull base osteomyelitis, you must see the T1 to see any drop in signals of bone marrow enhancement. Because anywhere you drop in signal of bone marrow enhancement, that part is involved. Yeah. That is so simple to detect. So like here, this is clivus. In the central skull base osteomyelitis, you will see all the clival signal gone. So wherever you can compare with the opposite side and see the area of facial planes in the infratemporal fossa and compare with this side. Can you see? Can you see the difference, the loss of signals? Yeah. This is T1 imaging. Now the more important is the T2 imaging, because we all know T2 give us the picture of inflammation as a high signal because of the water content. Water content. But here, even on the T2, see, let me show you. See, even on the T2, the signals are not high. The reason is, this is microangiopathy because of the lack of vascularity. Even the T2 signals are not high, and that is classical of skull base osteomyelitis. That is classical of skull base osteomyelitis. And see this high signal of the inflammation here. This is the extraordinary canal, and as I go down anteriorly, this is the TM joint pushed anteriorly, and see, this is the area which is affected. I don't know what I'm going to find, the granulation, the abscess. We tried to look through the diffusion weighted MRI along with this, what it is, whether it is an infection or not, and see even on the diffusion. Let me show you. Yes, even in the diffusion, see, there is some hypodensity which is showing abscess. On diffusion, when we show in such lesion, when you see some sort of hypodensity, that means totally necrose tissue. Necrosis will show diffusion restriction, and with all this, and this is a low signal. So could be not the entire area is not showing. See, rest of the area is hyper intense. That means inflammation. Now again, like mucormycosis, we always say, whenever there is a good blood supply, your antibiotics will work. Why to remove that? Only area that need to be removed is the area where the antibiotics are not penetrating. And that is what we want to know. And that is what we want to debride. If these muscles are inflamed all the way, see, as compared to the opposite side, all this is inflammation, need not to be removed, because ultimately the antibiotic will penetrate. The only thing why it is not responding is this area, with this area anterior to the canal in the posterior part of the TM joint. I don't know what it is, which is, limiting our antibiotic response. So my goal is here, this is a typical presentation. I will get a biopsy done. In case I have a doubt, I'll immediately get a frozen done, because I tell you many a time there is coexistent malignancy as well. So here I will first assess, and if need arises, we'll take the biopsy and get a frozen done. We'll remove whatever the necrotic area is until we get the fresh area, vascularized area where the antibiotics can penetrate. And that is our goal. Now finally on the contrast. Finally, let me put a 3D contrast one by one. See, on contrast, this is the area which is not enhancing like anything, not convincingly enhancing. I don't call it enhancement. See this area with a patchy involvement. See the compare with the opposite side. Now see, this is TM joint and this area behind. This is TM joint and this side. See the normal side here. This is the canal and the normal area behind. And see, all this is enhanced because of the inflammation. And this area is not enhancing. Can you see this particular?
Yes.
This is my target. So I will go anteriorly. We'll have a full approach to deal with any involvement of the temporal bone, because once we open, then will be the final picture cleared. So in case many a time we have to do a mastectomy, many a times we have to do a subtotal petrosectomy to get rid of all non-vascularized tissue or the bone. So our approach will open up for everything, and here this is the area which I am going to see first, and then see what exactly it is giving us a problem. If I see in the coronal the same area, this area, see in the coronal, let me show you. See, this is the TM joint which is anteriorly pushed. Now I am going behind. And this is the area. This is the area which is variably enhancing, not enhancing much, and this area is hypodense, not enhancing. See at this level. So I don't know what exactly the situation. I have a doubt about the fungus, I have doubt about malignancy, I have doubt about complete necrosis. So let's see what it turns out to be, and accordingly we'll treat a call. But we know our target, where to focus. Now this is the final 3D contrast picture. Let's see. 3D contrast is a sequence which many a times proved to be a very, very important sequence. Let me show you something on this. See, this is our external artery canal, this is distraction, and this is how it is accumulation in the posterior joint space, and this is how the TM joint is pushed anteriorly. If I take my cursor here, you can see in all planes, this is our canal and this is the anterior area to the canal, and this is TM joint, and this is the area. See now it is enhancing variably over here. This area, this complete area is the target, and this is just anterior to the external artery canal. Anything, Narayan?
Satish, so have you found your FDG values? You just told me you've been doing this PET MR. So are you finding a drop?
We didn't have the PET MR for this particular patient.
Okay.
That would have been useful, not only for the diagnosis. For diagnosis, that would not change anything. But for the assessment of the response, if I am treating this patient for suppose 1 month of antibiotics or operate this and get after 1 month the PET MR done with the previous reference, I can see the metabolic activity. How it has decreased and which area it has decreased, which area has developed further abscess or something. If there is any evidence of abscess, you have to go and debride. You have to remove that to get rid of antibiotic limitations. The antibiotics will penetrate then and give response. So this is
Dr. Satish.
Yes, sir.
Yeah, Gautam here. So
yes, boss.
When you have a central skull-base osteomyelitis, so how do you differentiate on a PET MRI? How do you differentiate it from a malignancy?
That can be best assessed on PET MRI, number one. So it can be best diagnosed on PET MRI for that matter. The reason is that bone marrow involvement of the clivus, like I've already told you earlier.
Yes.
See, this is my clivus, because in central skull-base osteomyelitis, clival region is most important that need to be assessed. So involvement of the clival marrow on a PET MRI will signify the diagnosis of central skull-base osteomyelitis, number one. Then obviously your primary treatment is, the medication. Long-term, IV antibiotics directed. If it is cyanogenic, you have to be suspicious of the fungus as well. Sometimes it is more common with the cyanogenic. Okay. Okay, so we are starting very soon now. So in central skull-based osteomyelitis, the clival marrow involvement, petrous apex marrow involvement can be best assessed on the fat suppressed MRI sequences. Why? You know, in marrow is a fat. Fat enhances on every MRI sequence. Whether you get T1 done, T2 done, fat always enhances. Now, if there is osteomyelitis which is giving enhancement, or is an inherent fat which is giving enhancement, how can you differentiate? Fat suppress image. Suppress the fat, and still if it enhances, that is osteomyelitis. As simple as that. So this can only be diagnosed on a PET MRI. MRI means PET is for activity, but the MRI is the situation, the thing which can diagnose.
Okay. Thank you.
Have you seen these cases in non-diabetics also anytime? And what is your choice? Have you seen these cases in non-diabetics?
Only once in life.
Yeah, even I have seen cases of non-diabetic. That's the reason I'm asking.
Yeah.
So even I have
Generally,
seen
non-diabetics is a
What is your choice
staphylococcus
of
infection.
antibiotic usually, Satish?
Pardon?
What is your choice of antibiotics usually you try?
Yes, we give culture-directed injectable along with always oral ciprofloxacin, whether it is sensitive or not on Pseudomonas if it is, because the ciprofloxacin is a good bone penetration. So we combine ciprofloxacin with either a ceftazidime, it is sensitive, if it is sensitive to piperacillin tozobactam, if it is sensitive to meropenem, depending upon the situation. Like
But I
this
find
patient,
that
this patient was
works
taking meropenem.
Meropenem works good in my hands, I have seen. Usually I give meropenem and with ciprofloxacin, that works good, but not in all cases.
Yeah, and even after the full response, what you see assessed with the functional imaging or ESR, I follow with the ciprofloxacin for at least additional 3-4 months.
Yes, I too do that. Yes. Then lastly, what about counseling of these patients when they are doing surgery?
Very difficult because
in spite of doing good
expectations are always there, and results are unpredictable. You can't control the immune system. You never know how it is going to behave. That's why there certain patients have a mortality also associated with this disease. And even if you treat, it may relapse.
Yes.
And sometimes you are so uncertain about the cure, whether the patient is cured of the disease or not, and you keep on giving something,
That's the reason, because you do a good surgery, everything. Suppose if the patient succumbs, then they keep on telling because the surgery. There's a human tendency. So that's why counseling is very, very important before doing surgery, because you have to tell the percentage mortality for these patients.
Yes,
Satish, just one word about piperacillin tazobactam, that it's important to combine it with an aminoglycoside to potentiate its actions further. So, typically, piperacillin tazobactam, even if you use 4.5 grams, you still need to use aminoglycoside.
Resistance otherwise. But
rapid onset of resistance occurs without the aminoglycoside potentiation.
Many of these diabetic patients have subclinical nephropathy.
That is the thing. That is why we don't choose to use piperacillin tazobactam. We'd rather use a third generation cephalosporin along with a quinolone.
And a patient can afford meropenem.
Yeah, that's the next step.
Ashim, just a small thing. So what I have started doing is, of course, earlier we used to do just plain CT and MR. I started doing an MR for sure, but I started doing a PET CT at the time of diagnosis. Okay, when I first suspected, and at the end of treatment, maybe 4 months, 5 months, 6 months, when I think the patient is almost cured, that's when I repeat the PET CT. And what I check is the SUV max values, the FDG uptake.
Yes.
At the beginning and values at the end. So typically they are very high at the beginning, and at the end of treatment, the FDG values are very low. So that gives us a better analysis whether this patient actually we can. That's what I was discussing with Satish. Yes, Satish.
You are right. But if you ask me, the ideal imaging combination.
Correct. I understand what you're saying.
PET MR plus HRCT scan.
Yes. PET MRI is not easily available everywhere, Satish. For us, it's PET CT. PET MRI is the best, no doubt about it.
Because with the PET, we get the functional assessment. With the MR, we get the rest of the assessment of
Correct.
involvement, the inflammation, anatomical
Absolutely.
assessment,
So
along
PET
with
MR is
along
exactly
with the
PET MR is
information of bone erosion on CT scan.
correct. And we
That you can
supplement
see
it
on.
with we supplement it with ESR and CRPs. So that gives us an endpoint of treatment. And point number 2 is instead of ciprofloxacin, I've been for a long time now using levofloxacin. Now, for its anti-pseudomonas activity, and also, of course, it also acts. We do a gene expert and other stuff. We check for rifampicin and anti-tuberculosis stuff. But we use levofloxacin instead of ciprofloxacin. Yes.
To use levofloxacin earlier.
Yes, you changed
But
that.
then I was warned by my microbiologist
Not to use levofloxacin.
use it
Exactly.
because it develops it makes the patient develop resistance to other antibiotics.
Sir, can this be COX as well?
You're ruling out that in the beginning.
Pardon?
Okay. No, I was asking if this can be tuberculosis.
Could be anything. This is
Okay.
a full surprise
Okay.
disease.
So, sir, lab ESR is required. You do lab ESR in every case for these
Yes,
patients for diagnosis?
Not for the diagnosis.
For the prognosis.
ESR is for
Prognosis.
follow-up.
Prognosis.
I like to use CRP, Satish. I don't know what you think of CRP.
CRP is for the bacterial infection, boss.
This is bacterial.
SSR is different. ESR will give you the chronic infection, maybe bacterial or fungal or whatever. CRP will detect only bacterial infection.
That's true.
What you can get out of the CRP is, if the CRP is low or normal, believe me, you can avoid giving antibiotics.
And
That's
so
true.
what about
Corda is gone, Yes, please. Are you getting the picture?
No, sir, we are not with you for the surgery.
We are still seeing the MRI. We are seeing your computer screen.
No, I had gone to the case. We're not.
No, we are not seeing the case.
No.
Patla de.
Dinesh?
Yeah, got
we
it.
can see now. Yeah.
Now?
Yes, we are with you.
Right focus is to be better focus is.
Yes. Just a minute, madam.
Yes, much better.
I'm actually
focus on the Koda.
No, please.
Better?
Yes. Perfect.
So this was given to me. I've just joined, and I was told that he was, not able to get rid of Koda, so he didn't remove the bone much. Great. So my first part, as we have many a time discussed, that Ashim has so many times mentioned, about the exposure part. So I will expose more to have a more space around. I think the Koda is already damaged or something like that. Here the piston I use is a titanium one, which are more anterior-posterior length, So I am little more concerned about the posterior exposure. Though there is no strict definition, why we need exposure is to get space for maneuvering our instrument. That's it. See the tendon below? Can you see? And see this Koda is damaged already. Can you see the tendon below?
The glare is there, so we cannot see it. Yes, now it is better.
And now it is better.
Better?
Yeah.
So I am sorry for the Koda, it already damaged. That's why he got up. Can you see the tendon below now? Hello?
Glare is there.
It is glaring too much.
The angle of microscope, please rotate it a bit so that the glare goes off.
Viru?
Yes.
Now it is seen.
And the focus, slight more focus.
Focus and little zoom.
Yes. Yes. Beautiful. Now it is okay.
Okay. So now see the tendon very clearly.
Yeah. It's very pyramidalis process is also seen.
Yes.
Until that, better to cure it. Always, if you see the pyramidalis process, then that exposure will be
because
good
you
for.
get ample of space to maneuver your instrument.
Yeah, that is most
piston.
important.
Now superiorly, my
Facial
exposure
canal.
limit superiorly is where the incus starts broadening. The long process starts broadening, and you get a glimpse of the inferior, incubomalleolar joint.
And also
Inferior
facial
aspect.
canal. Facial canal.
Yeah, I can see very well.
Yeah.
And this is a pretty good exposure, I can say.
Yeah, very good exposure.
Superiorly as well.
Yeah. If you tilt, you can see the anti-accrual also.
Yes. Glimpse of it.
That is an advantage.
Yes, sir. Now let me check the mobility first. See the malleus, it is mobilizing the incus, very clear.
Yes. Yeah.
No movement of the foot plate. Can you see?
Yeah.
Again, if you want me to do without laser, I can try.
Yeah, that will be good.
Because I'm so feeling secure with the laser, so used to. But here I got information, many people are not having. So all I can do.
Okay.
So what I can do.
So there is Satish, there is a thick ridge on the foot plate.
Yes, I know.
Yeah, running along. So for people who use the perforator, I think this is case, but one has to be careful. You have to drill away that ridge.
Yes. 0.64 diamond. So let me use for laser. For laser is a straightforward condition. But let me push myself in difficulty using something else.
Satish?
Yes?
Slight jerkiness is there. Continuous jerkiness is there.
Yeah. That we have been watching.
A bit more stable.
His respiratory movements.
Okay. Yes, that can be.
You are doing under GA, Satish?
No, under local. Always under local, sir. So what I am going to show here is the use of skeeter. Earlier I had shown you the micro drill in one of the case of reverse stepidotomy. And here, sometimes the reverse stepidotomy is not possible because of the overcrowding of the structures, So what you can do in that situation, you can make the space by means of, partially drilling the posterior crus of the stapes. That is what Ashish always propagates. Thinning the posterior crus gives you more space. क्या हुआ? देना ये देना क्या हुआ? ना मुझे डायमंड चाहिए. एक मिनट देना क्या खुला है? Just a minute. So I am changing the skeeter burr. Diamond. Hello.
Yes, sir.
Yes, Satish.
So I can make the fenestra directly. My security with the laser is I am not going to mobilize anything if I am using laser. That is for sure. And you have seen so many times. But here, what I am going to do is, I am using the skeeter.
So Satish, do you take away the mucosa before doing this fenestra making from the surface of foot plate?
क्या है चल क्यों नहीं रहा? क्यों नहीं चल रहा था?
Before making the fenestra, you won't do the length?
Pardon?
Length measurement before you make the fenestra?
No, I am not making fenestra.
You are just flattening the foot plate.
क्या हुआ चल क्यों नहीं रहा?
Maybe he's doing posterior crurotomy.
I know he's going to flatten. I think he's going to drill away that ridge.
I am going to thin out the posterior crus.
But continuous movement is there. It is not stable, Satish, the picture.
See what I am doing. Thinning the posterior crust. Can you see now?
Yeah,
beautiful.
you can see a dent there.
See so much of the space now I have acquired.
The entire width of the foot plate is now visible and accessible.
See, the small step has changed the scenario.
Exposure, yeah.
Complete exposure of the oval window, I would say. This is giving so much of glare. I'm changing the speculum.
And in the same step, you have weakened the posterior crura so that there is no avulsion. So two things are achieved in one single maneuver. Yeah.
Because for the avulsion of the foot plate, when you remove the crust, it is the posterior crust which is almost always responsible because it is so stout. Anterior crust is so flimsy, it doesn't give problem too much. Now, in the reverse stepidotomy, what do? We take the advantage of the entire incudostapedial joint as well as the incus as well as the foot plate fixation. Complete assembly fixation, and we can make a fenestra and put a piston first and then do the rest of the removal of the suprastructure and joint. Okay? So, what I want to do here right now, the measuring gauge. I will...
Satish, reverse stepidotomy cannot be done in white autosclerosis, whereas white foot plate.
You should not. You have to be more careful.
Yes.
It's not that cannot be, but then more likely that you are going to mobilize the foot plate, because in those situations, the foot plate is not adequately fixed at the margins.
Yes.
And if you try to make fenestra and do all this, you can end up mobilizing the foot plate.
Yes.
Now, Ashish, see my ridge is more superiorly placed.
Yes. It's upper 1/3 and lower 2/3.
Yes, see my area is opened up.
Yeah.
Do anything for the ridge now. You can bypass the ridge.
There are times when you can drill away the posterior crust completely, keep
Yes.
the anterior crust and the incudostapedial joint intact. That still gives you a fixation of the incus.
Yeah, but
then
that's,
you can drill as much as you
Ashish,
wish.
that's what we normally do. Drill away the posterior crust, leave the anterior crust intact.
Yeah.
So you get space at the same time, the same stability.
The stability, yeah.
Ashish.
Yeah, Satish.
This was 4.5.
4.5. Oh, wow. Okay.
Surprising.
So you
Male patient?
7.5.
No, it's a female patient.
Female? Oh.
So what now I am going to do is to make a fenestra. And here you have to be very careful, since I am not having lasers. I have so much of insecurity, boss.
What size burr is it?
0.6.
0.6. Okay.
0.6 or 0.5?
Now looks small to me. Yeah.
0.5. So
Medium only, huh? Teflon will need a 0.61.
see now, I will use this burr without any pressure like I am using on a cover slip. In the central part inferiorly,
Done.
Thank God.
It took 1 second more than the CO2.
I am so used to laser. I have so much of insecurity without laser.
Yes.
See now.
Beautiful. And Madhuri, it is advisable not to take away the mucosa because the mucosa actually holds the fragments of the foot plate. So only like in Ashim, when he uses vein interposition, that's when you're supposed to demucosify. But at other times, the mucosa being present, the non-vascular, not the highly vascular.
Vijendra sir, we want to know your technique.
I use always
Perforator man.
Perforator because I got a very good control with my fingers and I know how much pressure I have to use.
Yes.
So I've been using that from so many years. I learned from Hugo Fish. So I've been doing that. I'm very happy with that.
But at some point of time, you may have to use the drill.
Yeah. So when the foot plate is very thick, biscuit type of foot plate, I use Keter and make it thin, blue line, and then again I use a perforator.
See now my video game. just put the piston over the fenestra.
Yeah, yeah.
See the mouth taking on the incus. See
Yes.
this? At the desired place, 0.5 millimeter above, 1.5 millimeter above the joint, and then just push. See the middle slot taking on the incus. Can you see?
Yes. Yes,
Yeah.
yes.
Beautiful.
The only thing is, it is so easily reproducible by anybody. That's why I love this technique, because anybody can do it so easily without struggling at all. Experts can do with a Teflon, with the adequate crimping, everything, handling Teflon. You can, you see Ashim or Ashish or Vijendra sir, anybody expert using the Teflon piston, pushing in seconds the way they want. The piston has to follow. But it is not all that easy for everyone. Believe me, it is the crimping, the adequate crimping, which is having the significant impact overall.
Yeah.
The only thing which made me use this piston is the,
Clip,
it doesn't
crimping
require
clip.
a crimping. That's it. That's the only factor which fascinated me.
Now, he very clearly says that placing the piston is easier than crimping the piston.
Yeah.
See now the joint?
Yeah.
Scissors. I didn't even cut the tendon. Forgot to.
Yes, I was thinking what you do finally do it in the end, or it was
No,
by
actually this is advantage. Keep the tendon.
Yes.
Later if you cut it, that is an advantage. If you cut the tendon, then the stability of the stapes will go. So routinely what I do first, disarticulate the includo-stapedial joint and then cut the tendon. So tendon will have a stability for the stapes. Don't cut the stapes the other way around.
Okay. Yes, sir.
Sir, anytime you preserve the tendon or do something?
Pardon?
Anytime you preserve the tendon or do anything else?
No, I have tried all those things. It doesn't matter anything. I have tried these things. I don't think it has got any advantage. Preserving the tendon. And I learned from Jain Bernard Kass. I was working with him. He used to preserve the tendon in all the cases. I tried that, but somehow there's not much of any difference at all.
No, Vijendra, we had done that. We preserved the tendon in a series of cases, but post-operatively you tried to do a stapedial reflex. We wouldn't get a reflex.
Yes, you don't get it.
I think the capsule is open.
Correct.
It's attached to the capsule of the joint and that's opened up, so you don't get the reflex.
Yes, yes. That's what I was about to tell that.
See, with the intact arch, you can carry out the stapes with more safety. That is the philosophy which was described by Hugo Fish as a reverse stepidotomy. That's it, I'm through.
Yeah, one disadvantage in this procedure, Satish, very rarely when you put the piston, everything, when you are trying to remove the suprastructure, there will be a fracture of the foot plate or there will be a subluxation. What you do?
Yeah, it can happen, but that can happen only in the white foot plates. In the blue foot plates, it is unlikely because the blue foot plate, the bone is strong as compared to the brittle bone in the white foot plate.
Fine.
It doesn't fracture. And in the white foot plate, the foot plate is not adequately anchored.
And also once you make the finish of 0.6 mm, the stability of the foot plate will become weakened. So that's why you should be very careful in this when you are...
I feel posterior crurotomy is better than the reverse stepidotomy.
Pardon? Posterior?
I feel partial posterior crurotomy before making a fenestra is better than the reverse stepidotomy.
Madhuri, I would ask you, why partial?
I mean, still,
Why do you group? Because the anterior crus is still intact, so the stability is still there.
I know, sir. Still, if...
So the partial, may I answer? Because in case the foot plate gets mobilized, in case the foot plate gets mobilized when you're trying to make the fenestra, then you have both the anterior and the posterior crura both present.
If you have the anterior crus present, see, when you do the posterior crurotomy, the superior, the lateral portion of the crus near the head of the stapes is still intact. So you can always hook that. Having both the crura intact doesn't really help you.
Now you can hear better.
No, in case you land up with a complication that while making the
if your foot plate
the ear
subluxate, you still have the arch of the stapes intact. You only drilled away the part of the posterior crust near the foot plate. It gives you better access, like you saw how much his field opened up.
Now, you know, in this case, how could I do with sense of security without a laser? It's a simple trick advised by Ashish to thin the posterior crust. I love this technique. Whenever you find the need, this makes your life easier. Because
Satish, that's just what we were discussing. Why just thin it? Why not just drill through it near the foot plate?
But then my stapedial, this entire arch stability will go.
No, why? The anterior crust is still attached.
That
and
is not so strong, you know.
it's not so strong, but it is still fixed. The foot plate is fixed, so the stability doesn't
That
go.
may not, you know, sustain because when you make the fenestra and the mobility of the foot plate that is prevented, it mostly by the thick, stout posterior crust. Once
we've been doing it routinely
and
now
we are
for
taking the advantage of it. That's why the reverse stepidotomy is.
but the whole concept is the anterior crust is also holding the foot plate there. The stability of the foot plate is not because of the crust; it's because of the fixation of the foot plate.
Yes.
If you remove the posterior crust partially or completely, since as Ashish said, that if you accidentally subluxate it,
both the crura at least.
No, what I routinely do is I drill away the posterior crust near the foot plate, so I have my access. The anterior crust is left intact. So God forbid if I subluxate the foot plate, I have the arch of the stapes and the anterior crust intact, so I just have to put a right angle hook and lift it out. But
one thing I have against keeping too much of the posterior crust intact is when there is a very thick mucosa on the foot plate. Unless you denude the foot plate thoroughly, you will have persistent bleeding when you are doing the stapes procedure. So that's why I like to remove the posterior crust first. And what I do is I always drill in the axis of the stapedial tendon. There is no
axis in the long axis.
We are not doing any linear drilling at all.
Yeah.
Never.
One question from you. From Ashim Desai, who has experience of having done over 6,000 cases. How many times you have found the thick anterior crust?
Very rarely. Anterior crust is very rare. I mean, I would say less than 5%.
But it's unpredictable, 5%.
5% is too much.
But I've seen a lot of thick anterior crusts, but 5 in 100, 4 in 100, I will see for sure.
So what do you do under those circumstances?
Sir, in those circumstances, what I tend to do is I use a diamond saw. It's a flat disc. It's a flat diamond disc that I have. It's a 1 millimeter diamond disc. And I just slide it under the head of the capitulum of the stapes and just move forward.
Most of the time, it is not visible.
Yeah, but that's it. But that doesn't matter because this is 1 millimeter. So you have.
But your piston is already in position, isn't it?
I'm sorry, sir?
Your piston is already in position.
No. Because I use a vein interposition. I need a 0.8 hole. So I need the superstructure of whatever happens.
Okay.
With experience, the moment you try to remove the cruras, if it doesn't break, means the anterior crust is thick. So it should be very careful. Try to visualize by tilting the head of the patient.
Tilt the head, remove
if you can
more of
see the anterior crust, yes, you can drill it. Or
at
else
the base,
what
you can see it at the base,
9 times out of 10, you can see base of the anterior crust and drill out there. 9 times out of 10.
One more thing you can do is blindly try to do that with a crurotomy scissors. Blindly. Sometimes you succeed.
And in managing the difficult anterior crust, if your incudostapital joint and part of the posterior crura is still intact, then you do not have the possibility of subluxating the long process of incus inadvertently with the shaft of your burr, because then you can still reach and you still have a play in that joint.
That depends.
So you will not. So that is the advantage of
keeping
keeping the joint
not in
intact.
all the cases.
And of course, now with the fiber laser, then that solution has come out. We can always bend the fiber.
That is a better answer.
Yeah.
That is the best answer today.
What is the Skeeter burr size?
This was 0.5.
2-3 sizes.
They are available in all sizes, you know. Skeeter is a useful tool. You should have In your armamentarium, sometime you need.
Skeeter for those who use the drill is most useful when you have a overhanging dehiscent facial nerve.
Yes.
So that is when you need the skeeter which has a protected shaft.
That
so
would
that is
preclude any laser. When you have an overhanging facial of a
exposed,
grade 2, there is no way you can use
We can't use the laser so freely.
So that's
Vijendra
when
sir,
Yes, sir.
Vijendra sir, I had seen your one of the presentation. So we want to know, in case somebody gets a floater,
Yeah.
what do you suggest?
Yeah, what I do in routine procedures is first, before doing anything, I make a control fenestra of 0.3 mm. That's the first thing I do it with intact suprastructure, everything. So once if I make a 0.3 mm fenestra, if I get a floater, I think I got another instrument, it is 0.2 mm pick, fish pick. I can pass that in this 0.3 mm and pick the footprint from median to lateral. That is the best thing. So even if you encounter floater, I can manage without any problem.
I have a question. If
that fish hook, sorry Madhuri, 1 minute, that fish hook, the Karl Stoll's fish hook, I think is the most important instrument for otology procedure.
Correct, correct. I
also
totally
to
agree.
remove the tympanosclerosis between the arch, also sometimes to remove the epithelium between a mobile footplate arch, mobile stapes arch, I think is the best curved. It's a fantastically engineered instrument.
Correct. I totally agree with you.
Yeah.
But it's the most delicate instrument also. You
Very
should-
delicate, and I think cost 18,000 rupees. I don't know last.
Yeah, 18,000. And if you're a little
I
careless,
think you
immediately-
shouldn't be worried about the money, boss.
no. I'm just saying just for the.
And sir, this fiber laser, does that cause more fibrosis?
No.
Okay.
Not at all.
Okay. And there's a question from Islamabad. Dr. Talat wants to know that if patient develops post-op vertigo immediately, so what can be done? What has to be done?
See,
The surgeon should not get vertigo. He should be calm.
Most important thing is length of the piston may be long.
The length of the piston is long is the commonest cause of postoperative vertigo.
And plus, if you're doing under local anesthesia, the moment you put the piston, sometimes patients will start vomiting or they complain of giddiness. That one thing you should see. So if you feel that, better you remove the piston and cut short between 0.25 mm, not 0.2 mm. So that you have to manipulate the length, and practically you can see the difference on the table. When you cut short the piston, the patient will not.
Dr. Vijendra, it is not all the time the length of the piston, it is excessive manipulation at that place.
Suction near the opening.
That is true. That's why you saw that how Satish was totally away from the fenestra. Always that you should make it a point. Your suction should never suck the vestibule. Never make an empty vestibule. That causes sensory loss and also high frequency loss, and patient will have giddiness. So always is a suction tip should be far away from the fenestra throughout the procedure.
Okay.
Hello.
Okay, sir. Yes, sir. We'll move on to the next case. Before that, for the last time, you can just tell us the name of the processes and from where we can get. It's a request from many doctors all across the world. They want to know the
This
name
is
of
Kurz
the process.
titanium. This is Kurz titanium.
This is the Avingen titanium, right? It's a Kurz titanium clip piston.
Yes.
It's the
Now,
Avingen clip.
yes.
Okay.
Are you getting the picture?
Yes, sir. Make it, better by focus. Yes, now
Yeah, वो कर यार इसको clean कर lens.
Yes, sir.
Let me clean the lens
Yes, sir.
to improve the picture.
Satish, we have one more case after this.
You told me to finish that off.
No.
I got that finished.
You said something about an interlaced tympanoplasty. You had
Yeah,
mentioned
you told me that let it be the last case.
No. Hello?
Huh?
No. If you have the interlaced tympanoplasty, we can still have it. No problem.
कर दिए क्या उसको? देखना.
I just told you to change the order and do the stapes first.
So once you told that is finished, I will keep next time, sir. I thought you said the time is a issue.
No. All I said was do the shorter cases first and the malignant otitis externa afterwards, so that.
Yes. Redo it, Satish.
Pardon?
Redo it. If you have done it.
Redo.
Sir, I have a question from Professor N.K. Mojumdar. He's been attending this webinar since morning and he has his few questions for you. He was asking about 2% acetic acid in these cases. What is your opinion about this? In these cases, malignantitis externa.
See, this is the situation of the canal here.
Hmm.
See, the TM is intact. Can you see?
Yes, sir.
And we don't see why I opened from behind.
Yes,
in
sir.
case anything is required to be done in the temporal bone, you can go with the same incision. Otherwise, I would have gone with the preauricular incision.
Yes, at fish infratemporal type B kind of approach.
Yes, but in that situation, if I had to go to the temporal bone, would have been difficult. So I made this incision, found everything is good. In case I need to go further inside, we'll take a call later. I have an option now. I am going anteriorly.
Is the skin of the external canal edematous or it's
Yeah, it is edematous.
Okay, Satish.
Yes.
That means that the infection has gone from the tympanosquamous suture line. It has not disturbed the tympanomastoid suture line because there is no disease there behind.
Yeah. Yes, it has gone anteriorly.
Yes.
And even on the CT scan, it was just reactive.
Can you see what is there?
Abscess.
Yeah, abscess.
Ah, the culture.
Enter inside.
This is what the issue. When there is abscess, your antibiotics are not going to work. As simple as that. Anywhere in the body.
You anticipated that, no, Satish? Pus. Yeah,
Pardon?
Satish,
Oh,
you anticipated pus also.
Hello?
You anticipated there will be pus.
Yeah, it was. I was anticipating something like that. Necrosis, pus, or something like that. Yes, madam.
So I was absent in between, had gone away. So are there some cranial nerve palsies also there? The facial nerve? I didn't.
No. No face. No face. This is, I told you, the atypical presentation I showed on MRI. And this is something.
Which cranial nerve is affected most in these cases?
Seventh, obviously.
Always seventh.
When it goes into the neck, then it involves the lower cranial nerves. Vagus gets involved. Many a times patient.
Now I will remove all these granulations and make the conditions better. Now I'm happy that I got some abscess because this patient, this poor fellow had been on antibiotics for 1.5 months, not responding. How will the antibiotic work in the abscess condition,
Many a time when the TM joint is involved, I've seen that it's more of staph infection rather than Pseudomonas. I don't know if that is your observation too, Satish.
What, more of a?
Staphylococcal MRSA staph infection rather than Pseudomonas.
No, it is proven staph. Oh, that is Pseudomonas. On culture twice,
it was
the infection in the canal. And the canal infection on culture has proven Pseudomonas.
Okay.
Twice. See now from the same incision I am going anteriorly.
Center, please.
I can elevate.
You need to centralize.
Yeah. I can elevate from underneath. See this? Focusing on the preauricular region now.
Shaking like anything. Focus it, please. Now.
See this preauricular area?
Yeah.
And now I am going to clear this abscess cavity because my TM joint was pushed anteriorly because of, see the granulation?
Yeah,
the drill there, no?
You will take it
Retractor,
for
tongue depressor liya ek. Put some tracks because I am going to drill here. Drill. I will drill this diagomatic arch to go underneath. Now the situation is straightforward and we are going to finish in no time.
Satish, just hold on. Your camera is disconnected.
Okay, sir.
So, sir, you were saying that what is the role of 2% acetic acid in these cases?
Amazing role. In Pseudomonas infection, these bacteria grow in the alkaline media. Having a acidic media by means of, washing with the acetic acid or something prevents the growth of the bacteria. This is really good. We have been using this for years.
That is an adjuvant role, not main treatment.
Yeah, adjuvant, always. And another thing which we use is the Burroughs solution. We order that to a chemical company guy here, and he makes for us. It's an aluminium subacetate, and this is also again very, very effective.
Can you repeat that, Satish? Aluminium? What is that?
Burroughs solution.
Okay.
Where do you get it from?
Yeah, here we have a chemical, company here, that is Ram Singh and Sons in Jaipur.
Spelling of Burroughs, what is the spelling?
Burrow.
Burrow.
Burroughs solution. It is available in the US by some brand names. यार देखना क्या है? By different brand names. It is not available in our country somehow. So we get manufactured. कहाँ है?
Just going around the abscess area where the...
Now this abscess, whatever collection, had pushed the TM joint anteriorly. You had shown on the scan as well. This is the zygomatic root which I want to drill away to expose this cavity. This could be a big cavity as well. Could be some granulation also there. Since it is anteriorly centered, see, these are the granulations which now I am going to take for the biopsy as well, the biopsy for sure.
For TB PCR also?
Yes, TB PCR, biopsy.
How many times could you get a TB PCR positive in clear-cut tuberculosis cases?
Yeah, see, both the cases we did in the webinar, facial palsy, both turned out to be tubercular.
Yes, we are getting positive for this. Many cases are there, brain abscess and all. We get the thing, TB PCR done, it comes positive if it is tuberculosis.
But do you have concomitant pulmonary infection also with this tuberculosis?
No, sir. Many times
isolated.
No, even I have not seen concomitant tuberculosis, isolated tuberculosis. Always it will be not there.
Isolated temporal.
Cases, yeah, all the cases routinely, once if it is proved tuberculosis, I do see chest X-ray, but none of the cases I have seen that associate pulmonary tuberculosis. None of the cases.
Sir, only a few days back I did a brain abscess away from the site of defect, hematogenous root with granulations. Granulation came positive with TB PCR. No chest involvement.
That's what I'm telling. In most of the cases, I have very rarely I have seen in my series. I must have seen only in one case. Otherwise, no. So the primary is a year only.
So I'll ask a question to the panelists. Dr. Sandeep Karmakar is asking, apart from culture-directed antibiotics, what is your opinion about long-term quinolones and rifampicin? And have you seen quinolones and rifampicin?
Now see, once the abscess is clear, I removed certain granulation. Now area looks good. Probably I don't need to do anything, and now my antibiotic should work.
Paromita?
Yes, sir.
I got the tissue. I told you the role of surgery in malignant otitis externa is monopolar. Is to get rid of necrose areas. Areas with antibiotics not penetrating. For the confirmation of diagnosis by means of getting some, material for histopathology. Now see, this is a TM joint capsule.
Yeah, you can see that.
Yeah.
That is a joint capsule. See this?
Yeah, very clear.
Looking so healthy.
Yeah.
This pocket had developed abscess. See this? And now everything is healthy around. Can you see very clear?
Yeah.
So nothing more is required to be done in such situation. I hope you should respond now.
Paromita?
Yes, sir.
the answer to Dr. Sandeep Karmakar's question is
Yeah.
whether which drugs to give for a long-term basis. So if it is TB PCR positive, we give rifampicin also along with other
If
anti
TB PCR positive, then we have to give a complete ATD.
or then we give ciprofloxacin with ornidazole for 5 to 7 days and then plain ciprofloxacin at least for 3 months.
Okay. And whatever temporal bone mucormycosis, have you come across?
Yeah, I have
temporal
seen
bone-
one case, very interesting, diabetic, I mean, absolutely unexpected. And the same story like, like this case we are managing or any mucormycosis, you have to debride, prove the diagnosis and start amphotericin. That's it.
Satish, one case, I thought it is skull-base osteomyelitis. It came out to be verrucous
Pack
skull.
लगा दो यहाँ.
Even
Put a pack in canal and close it.
it's skull-base osteomyelitis.
Yeah, Madhuri, that is true. That's why in every case it is advisable to get a histopath.
Histopath, yes.
Even if you have granulation in the external canal, because I have also had this experience that we kept on being treated as diabetic otitis externa and then turned out to be a malignancy.
Yes, sir.
Yeah, we have seen fungal skull-base osteomyelitis, but never mucormycosis.
That's why you should have a routine protocol in osteomyelitis skull base. What we do in all the cases is first take pus for culture sensitivity, invariably granulation will be there, always take biopsy and MRI. These things routinely as a protocol we do it. And in my experience, we do give meropenem and ciprofloxacin for 6 weeks, and most of the cases they do well. And the most important thing is because these patients are elderly patients, getting the line will be very difficult. So from the day one, you start them on a CVP line, and that will be very easy to instill the drugs. Otherwise, what happens if you start on giving IV line every 4th day, 5th day, you have to keep on changing it. At the end of 20 days, you will not get veins. Then patient also will get disgusted. So the best thing is try to put a CVP line, and each one has got their own experience. In my hands, I have got a lot of give importance for this meropenem and ciprofloxacin. Meropenem we give 1 gram TID and ciprofloxacin 500 mg BD. And we every week monitoring we do it. Plus, you should have a association with the physician to monitor any renal problems, all those things. Every week we get a LFT and urea creatinine done, and like this we manage. And the diagnostic value is most important. Pain, if it is coming down, there's a very good prognostic value. This is how we treat.
So why do you give meropenem all the time? Is it never culture directed?
Pardon?
Why do you give always meropenem? Don't you give culture directed? Sometimes
directed. In all the cases I have done, cultures will show sensitivity to meropenem.
Okay. So what about clindamycin? Is that
clindamycin is not, you have to do culture. Don't write clindamycin just like that.
It should always be culture directed. Satish? And always rule out fungus by getting galactomannan test done.
Okay, there are a few questions about ofloxacin. Can ofloxacin be used instead of ciprofloxacin?
Not really. Cipro has a tendency, as an ability to penetrate deep into the bone. That is the best antibiotic for such situation. It has an activity against Pseudomonas as well.
And unless until the culture shows resistance to Cipro is the first choice.
And also it is a very safe drug. Ciprofloxacin, long term we can give it for 3 months also. It's a very safe drug.
Yes, safe.
Satish, I've been using Levoflox. Why did you say Levoflox is not a great choice?
Levoflox makes the patient develop resistant to other antibiotics. So this is never recommended by microbiologists now for this kind of use. That is for only certain critical situations where the culture is directing towards the levofloxacin, that only. For short-term use.
Linezolid?
Linezolid is for MRSA, Staph aureus. But linezolid is a bacteriostatic, But still it is good. Still it is good in certain situations. Even in the nose we have been using linezolid for the staph infection sometime. It is not so potent like vancomycin or teicoplanin, something like staph, but still it is good and efficacy against MRSA as well.
And in these cases, we cannot.
Paramita, you have some more questions from participants?
Yes, sir. There are quite, yes, sir. Few more.
Yes, start. Now Satish is available to us to answer questions. He can answer some questions.
You all are here to answer, sir.
Yes.
Vijendra, sir, or Ashim. Can somebody eat the head of Ashim?
So what is the role of hyperbaric oxygen as adjuvant therapy?
Amazing, amazing. I forgot to mention. It should be given. You know, this condition again, we are fighting with some situation which has no control, immunity. There is already, the defect in the microcirculation because of the diabetic microangiopathy. What we want is to improve circulation, and that is what the hyperbaric oxygen provides. Secondly, it improves the phagocytic activity of the neutrophils as well, the hyperbaric. So many times we subject these patients for even for weeks along with the antibiotic therapy and all to the hyperbaric oxygen. It is definitely a useful adjunct therapy.
Okay, sir.
Yeah, I agree with that. Even we do that. So
Okay.
definitely it helps. Okay. But only few centers in India have that real hyperbaric as in Bangalore, luckily we have. So in that Hindustan HAL, they have one. So they really do a good job. But now private people have started doing it. They don't have any concept about that. I see that. I'm not happy with these private people. But whereas the Hindustan Aeronautic Limited, they have got for pilots, they do it. And really they have got an excellent chamber of hyperbaric oxygen. Even for SNHL, sudden onset hearing loss, we do that. It is definitely has got a role.
Okay. So Dr. Ramesh Tohiwal is asking the composition of the Burroughs solution that you had mentioned.
It is aluminum subacetate. We use 5%. It is available in various, in the US, it is available in 5.3% drops. That is Dominic, I forgot the name of the brand name of the drop.
Domboro. It's called Domboro.
Dombro. Yes, Dombro. It is not available in India, but we can get it, through the chemical fellow. We get it here. And, if you want, he can supply you anywhere in India. You can just give an order on telephone and he'll supply to your address. This is Ram Singh and Sons.
You have to give the
Satish, any idea?
Huh?
What is action? How it acts this one?
This is a pure antibacterial, bactericidal with a strong efficacy against Pseudomonas.
Okay. Which is
Secondly, it gives the acidic medium as well. It gives the acidic medium as well. So that is the added advantage of that. And it is proven by literature to be very, very useful.
In the olden days, people used to put vinegar in the ear.
Vinegar, that's what I was about to tell. Acetic acid, even that has also got the same function.
No, this is the main content is aluminium.
Okay.
Okay.
Yeah, Paramita, go
So
ahead.
there's a question for you, Kirtane, sir. Dr. Rajat Jain from Lucknow wants to know that if a patient having mixed hearing loss, if STAPI surgery is done in these cases, after seeing audiogram, will it benefit the patient long-term consequences?
It depends upon the airborne gap, because you'll be able to close the airborne gap. You may still have to use a hearing aid after doing a stapedectomy if the SN element is bad enough, but the hearing aid will be more useful to him if you do that. Of course, if the speech discrimination is poor, then you may not get too much benefit. But even if there is a sensorineural loss and you know that after stapedectomy also he's not going to come up to good hearing, normal hearing, he will definitely have more benefit with the hearing aid. So if you have a reasonable amount of airborne gap, you can still do it.
Okay.
But the counseling of this patient is very, very important.
Yeah.
Yeah, because they think that after stapedectomy they can hear everything. No, you should counsel these patients that you may have to use hearing aid after the surgery, and benefit will be the performance.
Even if it is profound loss,
yeah,
still I will recommend it will make the use of the hearing aid better.
The performance of hearing aid will be better after the surgery.
Satish, I've just operated on a lady. She has a severe to profound loss on one side. On the other side, loss was profound. So I suggested a cochlear implant and she was refusing. There was a negative Rene, so I did a stapedectomy on the profound loss ear, and now she feels that ear is doing better than the the other side. So she will still have to use a hearing aid, but she's at least got some
very
benefit out of
important.
that. Yeah.
You should counsel them for post-operative
See,
hearing
there is
aid.
no harm in
Yes.
using it. Still, you can do a cochlear implant. There is no contraindication
If
to
this
cochlear
doesn't
implant
work,
in
you can
future.
go ahead and do a cochlear implant. Yes.
Yes.
So Dr. Shambhunath Mukherjee from Guwahati is asking role of serum prolactin level in malignant otitis externa cases.
Prolactin?
Is there any role, sir? I don't know.
Prolactin, no idea. I fail to understand why prolactin. But prolactin has nothing to do
No,
with
never read anything about it.
Yes.
Okay. Okay, sir. Dr. Deepak Dalmia has a question that he had a case of CP angle tumor which came as tuberculosis. So he's asking if there's any experience of the panelist of such cases.
Never. At CP angle.
Yeah.
A tubercle granuloma.
It came not involving the mastoid or temporal bone?
No.
Okay.
I think that's a medical disease. It's a physician's domain now.
Okay, so I think we've...
Any more?
I think we've covered almost all the questions. So no, I think we've covered almost all the questions.
Okay. Can I ask a couple of questions? Is Ashim there or Ashim's left already?
Yes, Ashim's right here, sir.
Yeah. You have a tremendous experience of revision stapedectomies, right? You said.
Yeah.
What is the commonest finding? I mean, what is the reason for which the revision was required? What is the commonest finding?
The commonest finding by far is the fact that we are dealing with incus necrosis after an initially successful result. And when we open this, we always find that the undersurface of the incus is necrosed more. And this typically is due to A, under crimping of the prosthesis, poor crimping of the prosthesis, and B, when the prosthesis is fitting into a tight fenestra. So the relative movement of the malleus, or this is what we postulate, is that the relative movement of the malleus and incus vis-a-vis the under mobility of the stapes prosthesis is what causes the undersurface of the incus to eat away rapidly. So
this would usually occur after how many years after surgery?
I'm sorry, sir?
This you would notice usually after how many years after successful surgery?
Okay, it's variable. I mean, it could be successful for many, 2 to 5 years, 7 years, 10 years, and then you end up with incus necrosis.
In what condition would you explore for a sensorineural hearing loss as far as revision stapage is considered?
You see, typically what happens is that when you have an unoperated ear and an operated ear, and you start off with a similar bone conduction, and you find that the bone conduction of the operated ear gradually deteriorates below the level of the unoperated ear. This is by far due to a fistula. Fistula need not present itself as a sudden onset hearing loss. Fistula can also mean a slow progressive sensory neural hearing loss with a progressive loss of discrimination. And one of the reasons that I believe that loss of discrimination is due to the poor micromechanics of the cochlear fluids due to the fistula. So when I find that the deterioration of nerve function is occurring slowly, and he's losing discrimination faster than he should in the operated ear vis-a-vis the unoperated ear, that is the time I would think in terms of exploring for the fistula. Yeah.
Now, in a patient who has been operated earlier with occasional recurrent dizziness, imbalance, persistent for few years, still coming back again and again after stapes surgery done few years back, what would you be your plan? Would you get any investigation done or direct exploration?
Absolutely, vestibular evaluation is a must. Absolutely, CT scan is a must. CT scan is a very, very fine 0.5 millimeter sections of CT scan is a must, and vestibular evaluation is an absolute must. The second thing is that...
How will you confirm fistula in that?
If it was my patient, I'm so obsessed with measuring the length of the piston, I'm very sure that's...
It's referred to you.
If it is referred to me, I'm very sure that it possibly would be due to a longer piston. Now, during episodes of vertigo, most of these patients have a hyperactive labyrinth. Most post-stapedectomy or stapedotomy rather, vertigo is over a period of time a hypoactive. In such cases, you will find a hyperactive. Sir, Dr. Kirtane sir, what is your impression on this? Have you done vestibular testing on these guys?
No, not really. I mean, yes, but I'm not able to corroborate what you're saying about the hyperactivity. What you're trying to say is that when you do a warm stimulation with a caloric test,
that is right.
You're getting a hyperreactive.
Hyperreactive, and when I do a V hit, I see excessive action potentials on the affected side.
I have seen couple of BPPV, classical BPPV patients after STP surgery.
That is common.
That is known. I mean, that after any ear surgery can occur after any ear surgery.
Any form of ear surgery, BPPV is common. Doctor.
Also very common. Yes, I agree with that.
You see that, yeah. And in those cases, Epley's works also. But the important thing is whether you want to see a utricular-petal or a utricular-fugal BPP.
You're
because
talking
you could
about
be dealing with the BPPV of the opposite side. So you should have to look for the utricular-petal or the utricular-fugal.
That's about the lateral semicircular canal.
Correct.
Utricular-petal or utricular-fugal will come into play in the lateral semicircular.
In the lateral canals.
Yeah. But more commonly, you get a posterior canal.
Posterior canal. That is deeper.
Yeah,
that
but
is more dependent.
You know, at one time we used to hear a lot about granuloma formation causing vertigo.
Sir, I think that's a bit of a myth.
Yeah.
Never seen, sir.
I've never seen in my life.
That's what I was wanting to ask you, because we've never seen granulomas. But
sir, have you ever seen?
Yeah, I have seen in 2 patients. It is so unfortunate. This patient, mother and daughter, both of them, they had granulation. So this granulation occurs very fast. 6th day, 7th day, it will start. So these patients both the patients lost the hearing. So first patient, when I did, on 8th day, she came, she was perfectly all right, procedure was perfect. She was not able to walk. She was lifted and she came to me. Then I was in a dilemma. I asked my boss at the time. He said, immediately open it and see what is there. When I opened, it was full of granulation. Incus was necrosed, the piston was necrosed, and the footplate, everything. This is 11th day.
How could this?
Unfortunate, the same thing happened to her daughter. She had so much of faith in me. 1 year I operated that lady. The 2nd year when I operated, she developed this granuloma. And then operated her daughter. Similarly, she had a severe vertigo on 7th day. Immediately I opened it. Fortunately, she had a severe mixed loss, but not a dead ear. I removed the piston. So I have seen in 2 cases. And we have published on paper also, myself and Madheva sir, series of 5 cases of this foreign body granuloma post-operatively. This occurs within 10 days.
But this is the reason why I remember Professor Plester used to say, never use cotton ball in the ear when you're doing a stapedectomy.
One question which came to us last time was wanting answer from everyone when Ashim and Ashish were there. A patient coming to you with a post-stapediectomy vertigo, immediate post-operative vertigo, and referred to you by a junior colleague. You got the HRCT done with no long piston. What is your cutoff time and when you will re-explore?
It is better to re-explore immediately if vertigo is too much.
The role of conservative treatment, you wait for some time or you will immediately?
If the hearing, we don't know what is going to happen. If the vertigo is too much, if the length of the piston, your CT scan may not reveal, but still if it is more, better to remove it, make safe ear first, prevent further loss. Then you can do. I have got one nice case where that is also opposite ear operated after 7 years operated, but on the table he was perfectly all right. And when shifted to the ward also, after 6-8 hours, she started getting very severe vertigo. Then immediately I opened and I removed the piston, I cut short the length of the piston, and he is doing even today fine.
So Satish, you are asking within few days of surgery, na?
Yes, yes, immediately after that, yes.
It is better to remove the piston and play safe role rather than waiting and subject them a CT scan, everything. So first thing is play safe role, prevent SN loss.
You mean to say there is no role of conservative, you should not waste time.
No, it depends upon who is operated. If somebody, novice is operated and he is sucked on the labyrinth, You know, in an open labyrinth, if you have done the case and you know that you've not done all that, okay.
Yes.
But if somebody else has operated, I don't think I would open up immediately.
Yeah.
And I just wanted to ask you, the piston is long, would a fistula test be positive?
Not always.
In spite of a long piston. So that
may
will
not be.
Not get a complete.
If there is a perilymph fistula, there will not be a, seal for the pressure to be transmitted to the...
But if there is a perilymph fistula, again, it should give you a positive fistula test.
Not always.
Not always, sir.
Even with a fistula?
Yeah, even with the fistula.
Seal is not there, na?
Huh?
Seal is not there for the pressure to pass on to the inner.
To the membranous labyrinth. So
What
it
is not there?
always there. That's why, even with the fistula, sometimes many of the patients, they stay with the fistula for years together with some intermittent symptoms. And they pass on with the symptoms and again get along with the normal life. And then again they develop symptoms with a minimal symptom. And that's how we have discovered a fistula 7 years after the stapes surgery.
Sir, I want to say one thing, that whenever we do, every person, when he does a stapes surgery without using a vein interposition, is that not a fistula? It's a fistula.
Yeah, but then you're not doing a fistula test at that time.
No,
When the
sir,
fistula heals, you see, you will have a little blood coming on and sealing the fistula.
No, but sir, what happens
when you make the fenestra,
yeah,
you will get a connective tissue seal because like Satish puts a little blood course, the little bleeding. You've got a small fenestra with a piston almost fitting snugly except for a little space around. That fistula gets sealed with connective tissue like blood coming over there. So that is not really a fistula. If you have a fistula that is leaking fluid.
As long as the piston length is adequate, there is never an issue, even with a direct piston, without a seal.
Agreed.
Perforation like thing in the foot plate area, from where I seen there will be a small perilymph gusher. In only one case I have seen that. That patient had severe vertigo. And also clinically I could see the mid-ear was filled with fluid. That gave me a clue that there is a perilymph leak.
But in 9 times out of 10, their middle ear will never be filled with fluid until the piston is removed, because always the perilymphatic leak is submucosal. Now what happens in many of these cases is that the fistula may have existed for many years, and what happens is that due to a otitis media with effusion, that infection creates the symptoms. The asymptomatic fistula can exist for a long period of time, which is what we have seen. Because a long piston doesn't suddenly create a fistula. That fistula has existed for a period of time,
Right, but only after, I don't remember.
Unless when you remove it, you will see the fluid coming out.
No, in this case, even the piston was intact, but I could see the fluid in that. Only one case I told. That is after 5-6 years of his surgery. I don't remember the duration. I could very clearly see there is a fluid in the middle ear. So that gave me a clue.
Possible.
Vijendra sir, there's a question for
Only
you.
one
How
case I
will
see
you?
that.
Vijendra sir, there's a question for you. How will you treat an uncontrolled perilymph gusher?
Uncontrolled perilymph gusher. See, that is when you do a fenestra, that is called perilymph gusher is there means that's very difficult. We have to try to put a wider diameter piston, and then first thing is try to put a vein graft, and then you try to put a seal and try to, even in spite of that I have seen it will be gushing out. Okay, so it's very difficult. Then you may have to give some head end elevation, then so many things has to be done, but I have not come across in my experience.
Okay, sir. Sir, there
We
is
had a
one more
stapes carnival in 2013, sir, when we did 50 stapes in 2 days. We had 3 gushers. And all those 3 gushers luckily came to Ashim.
Okay.
So, actually what happened was somebody asked me, what are you going to do, sir? And I said, that, listen, I'll order a cup of coffee. So, what we do generally is take the head up and wait till the pressure of the perilymph reduces enough to put a vein, and then to put a piston. But in all cases, all such cases, I would recommend putting a vein, as Dr. Vijendra sir said, that vein is an essential part when you're trying to close this. But the problem with these fistulae is that these are pseudo fixation of the stapes. It's not really true otosclerosis.
Okay.
often what happens here is that the pressure of the perilymph itself is causing a pseudo fixation of the stapes. Satish, do you agree?
Yes.
Especially in the monster gushers.
Sort of inner ear hypertension, you can
Yeah,
say.
literally inner ear hypertension.
So this is not perilymph, it's CSF that's coming out.
It's literally CSF. Those
CSF.
what we call the weepers, those are the perilymph weepers in which you wait maybe half an hour, 45 minutes, and then you put a vein and piston and they work out beautifully. So I believe that out of the 3 gushers we did on that day, 2 did very well. 1 continued with a conductive hearing loss. Nothing happened. Am I right, Satish?
Yeah, and in one of the patients, I had to do cochlear implant.
Yeah.
Later. She had a mixed loss. We didn't have a CT scan, remember?
Yeah, we did not have a scan.
time we took this that we'll get a CT scan done in all young patients.
So it was the incomplete partition 3.
IP3.
Yeah, yes, IP3 it was.
Classic IP3.
And we had to do a cochlear implant later on for that child.
That is
It was a
pre-operative.
12-year-old child. Yeah. Yes,
That is pre-operatively, can we predict this perilymph gusher by any
100%. 100% with a good CT scan.
Yes.
CT scan.
Good CT scan, you can always.
Yes.
And if pre-operatively you suspect a direct communication with the CSF space, like to the intra-auditory meatus or something, you can avoid doing stapes surgery.
Yeah, that is good.
That is the bottom line. That is the advantage of CT scan.
So then is it advisable to do CT scan in all cases of otosclerosis?
See, the reason is, these are the patients who have a high expectation of hearing, you know.
Yeah,
They come
that
with
way
a
you don't.
conductive hearing loss.
Yeah.
And any such patient going back with a sensory neural hearing loss is never acceptable, not to the patient and not even to the surgeon. And this is, if you take the international, data, in otology, the biggest cause of medico-legal litigation in otology practice is the stapes surgery.
So then it is advisable to do CT scan all cases in present.
Better to do.
We started
harm
doing
in
it. We've started doing
do
that.
it. Not only this, we get so many things. Sometimes we see anomalous ossicles. Then you can predict this perilymph
Sir,
gush.
I have seen the incus fixation, malleol fixation.
Yeah, I also seen many
anterior
cases.
ligament on CT scan pre-op.
Yeah, on CT scan we can see that. So that
You are not prepared.
better to do a CT scan like cholesteatoma. We do it for all present scenario. Better do a CT scan in all cases.
See now, this is different in your practice, in a junior guy practice. The reason is, if you come across such, difficult thing, like a malleol fixation in the aortic, anterior ligament fixation, incus fixation, you may find a decent facial now overhanging. With your experience, you can overcome these challenges. But if a junior person coming across will this, either he'll end up in complication or, abandon this. So that will something you need to think. There is no harm in getting a CT scan done. Like we get a CT scan for sinusitis, for anatomical details.
Yes.
To prevent surprises. There is no harm. You can install a cone beam CT scan in your OPD. You don't need even a separate room for that. Just a corner of the OPD. And the cost of the machine is just 25 lakhs. And you can get the entire data in DVD in less than 10 seconds. Hardly any radiation. Hardly any radiation with cone beam. That is important only for the temporal bone and PNS. That is what we want in the practice most of the time. CT scan for. And it is so feasible,
Okay.
Okay, so I think Satish.
So one more question. So last,
Yeah, sure,
Dr.
go ahead.
Deepak Dalma is asking that for diagnosis of tuberculosis, will you get a TB PCR done or a gene expert or both?
For tuberculosis, many a time it is so difficult to diagnose.
Correct.
The reason is, for the pathologists, their problem is they will never declare TB unless they see the acid-fast bacilli. Even if it is high likelihood of tuberculosis, they will never declare. This is their, their habit, their practice. TB PCR, it can pick up. It can pick up actively replicating tuberculosis, but many a time it is missed. I see in my practice in mastoids, pre-op, post-op, many a time you miss, and when patient present with atypical presentation, atypical symptoms, discharge not responding to anything, some osteomyelitic bone inside, sometimes facial paralysis, then you click that could be having tuberculosis. So many a time it is so easy to miss, so easy to overlook, and there is no test, no definitive test for that.
I totally agree with Satish, what he said. So many patients, even if you send the granulation, they will not give us tuberculosis. But if you follow up the patients, they keep coming up with recurrent granulations. Sometimes when you do biopsy second time after 3-4 months, that turns out to be tuberculosis. We have come across. So
many times we end up giving an empirical course of
empirical course, yeah, that's what I was about to tell. In these patients, when I suspect, I do give empirical antitubercular. They do very well.
Okay, okay, sir. And Satish, sir, the previous case which you did, parotidectomy, to fill the defect, will you fill fat in it? I mean, to
not
fill
really.
the gaps? No.
Since it was malignancy, so I didn't want to put anything.
Okay.
Because now we have to subject him to radiation. He's 72. We had already convinced him. Not only for this, I had convinced him. We had a consent for the mandibular ramus resection, consent for the flap, consent for so many things. In malignancy, you never know. You may need a temporalis myoplasty. I told him we may do it now, later on. This defect is hardly anything for such an old man with a high-grade malignancy where the radiotherapy is imminent. In a young person, the things would have been different. Young person, I would have gone in the mastoid, found the facial now. I put a graft, at least 2 grafts to the zygomatic and the marginal branch. And I would expect some sort of recovery from them. But here, you can, whether he is diabetic, he is a cardiac patient also, With this malignancy, there was no way, that you don't operate.
Unnecessary time.
With a less chance of, life expectancy, with the malignancy, diabetic, cardiac condition, reconstruction, role of reconstruction is always secondary, I would say.
Okay, okay, sir. So, sir, I think we have covered almost all the questions. Just Ketale, sir, if you allow me to the viewers, many have joined late. So, they have been asking the same questions repeatedly, which has already been discussed. So, I haven't taken those questions anytime in between.
I think this is recorded, so they'll be able to, if they play this, they'll be able to.
I know, sir, this has happened many a times, and the people may feel it because sometimes somebody is asking question who has joined later.
And they feel that they're not been
his
answered.
or her question is not taken up because that point is already discussed, as he has not been since beginning. So they may feel offended that their question is not taken up. It's not like that. There is
Tell them you have missed the bus. I tell them you have missed the bus.
So there have been...
they haven't missed the bus because they can always log on to this and they have the whole thing recorded. So their question will be answered. It's just that it won't be answered today, but when they log on, it will be answered.
This entire 130 hours recording is available on YouTube, unedited.
So there have been more than 7,000 viewers today and more than 1,000 questions which were there on the screen for me to see and ask.
I tell you, the biggest credit goes to Kirtne sir.
Yes.
Not only for making this happen, but the way this was organized. He asked me to keep basic cases right from basic to advanced. Similarly for otology, laryngology, rhinology, he wanted to give the delegates the best possible, information, and the panelists he chose is mesmerizing. All my teachers, honestly I accept. Nupur came in the morning, Bradu madam, Devendra sir, Vijendra sir, Ashim, Gautam sir, Narayan, Madhuri madam, these are all people who have done, the lifetime.
Not to forget your cricket partner,
Devendra. Devendra and Shiva. Devendra is amazing, You ask him midnight, 12 o'clock a question, he'll respond.
Satish, I had to get panelists who could match the surgeon. No, that's the whole thing.
And I am so fortunate. I have been sitting with all my teachers who have taught me all these years, and I could be there today to learn
I think
from
you're
all
doing a
of them.
fantastic job, Paramita. Really good.
Thank you for giving this
Satish,
opportunity.
I have no words to say. Thank you. Your stamina.
All thanks to you, sir.
I think Ashish keeps on calling you an alien. I'm almost starting to.
You are teacher of teachers, you know.
आपका DNA चेक करके देखना पड़ेगा किधर एक सुपर कुछ जीन है क्या उसमें. You just don't seem to get tired. You don't want to eat. You don't have a cup of coffee.
Yes, sir, yes.
You can just carry on. Amazing. But your depth of knowledge on all the aspects of ENT, every question answered with.
We have to learn more and more, sir.
With evidence from journals, not just. No, I think so. I think every answer that you give has a background of what you have read. So thank you very much. It's been a great learning experience for all of us. Believe me, I have never seen an ENT surgeon as accomplished as you.
That's true. That's true. Very true.
Very true, sir.
I would like to thank all the panelists. He's already named them, and all of you. Thank you so much for your contribution, Paromita.
Big thanks to Alkem.
Big thanks, all.
Very, very big thanks to Alkem. And as I mentioned, one thing I love about Alkem is they just say do the program. They don't come in, tell me who to call, what subject to cover, my product should be. Nothing.
They are the people unimaginable. They provide the backup more than what you imagine, you know, more than your imagination. They are ready to do everything. They are so committed. And sir, with you, we have done so many programs with Alkem. They're amazingly dedicated people. Yeah, it's rare to find in the pharma industry people like them.
They've also promoted books. I think one of Madhuri's books, Madhuri, am I right, was taken by Alkem. Nupur's book was taken by Alkem. So they have been very, very supportive as far as educational activities are concerned.
You, sir.
No, it's...
Yes, they value you so much.
They will value good work. That's why all of you are here. Okay.
And big thanks to Paromita for bringing so many important questions and discussion. We miss Pachori boss. He was busy today. We'll see him next week, next Sunday, with some new topics, new surgeries and new concepts. And we really missed him. And he was occupied somewhere today.
And I must say, Ashish kept out of the picture for a long time. I mean, he was there, Chupa Rustam, but he didn't.
Always Chupa Rustam.
He is always Chupa.
Can I add something? Satish, can I say something?
Sure, go ahead.
Yes, Narayan.
Yeah, so of course, the first thanks goes to Dr. Kirtane for putting up this program and Alkem for supporting. And sir, I mean, we don't need to say it. You have been the teacher for all of us, and we continue to learn from you all the time. And as regards Satish is concerned, of course, we had a lot of teachers, and you would say we are the panelists, but you believe it, as a panelist, we get to learn so much more. And Satish knows that Satish has got about 120 hours of webinar. And believe it or not, I've made space for seeing most of these webinars. Not because I know lots, but it's because you get so much more to learn from Satish, and so many concepts change.
Because
and the way he
learning so much from you.
And no, I'm not praising you. I don't praise anyone unnecessarily.
Every single input is important, Narayan. Everyone, we are learning from each other.
That's true, but Satish, phenomenal job. You deserve a lot of credit for your webinars and the amount of knowledge that you spread. Thank you very much.
Believe me, in the last session, so much I learned from Vijendra sir and Ashim.
Obviously.
Every input is so important out of their experience, you know.
That's what I said.
Sometimes you don't get things in the books. You don't get things, you know, to get to see from anywhere. But it is out of experience. They are speaking out of their heart. And this is something we are grateful to them. Thank you, sir.
Okay, can I just request everybody on the screen to go down to, there is a column called reactions. And if you go to reactions, you can give Satish a big hand. Can you see that?
Yes.
Okay, and Alkem, Anthony, are you there? Anybody from Alkem?
Big thanks to Alkem. This wouldn't have been possible.
Big thanks to Alkem.
Anthony, nobody from Alkem here on the...
Kirtane sir, before we depart, I call Satish nowadays, I call him, you are like cocaine. You are an addiction. Every time you come on stage, everybody leaves everything that they're doing and they sit in front of the screen wide-eyed for 10 hours, 8 hours at a stretch.
7,000 people on a Sunday, imagine.
Yes.
7,000.
I think I spoiled the Sunday.
The only people who are really complaining are the spouses. But it's magnificent, Satish. It's really been magnificent watching you all the time.
I get
learned
so much to
from
learn
you.
out of it. Believe me.
I also like to thank Kirtane sir, Alchem people, and also the man of the match, none other than Satish. Hats off to you. Thank you very
Man
much.
of the series. He's man of the series.
Correct.
Sir,
He's not man
you
of the
are a
match, he's the
teacher.
king.
You know, you have taught us your lifetime. Not only me, you have taught, thousands of students from everywhere. And they are doing their job, doing so good work. And this is amazing. And still you are spreading your experience, your knowledge. This is something
Once again,
phenomenal.
anybody from Alchem around? Anybody from Alchem still connected? No. Okay, so I think we shall end. Thank you very much.
Bye, sir. Bye-bye.
Bye,
Thank
sir.
you. So, see you next week.
Thank you,
Yes,
sir. Bye.
and next year, hopefully, we'll do this meeting by actually meeting and having something.
You are not locked in.
Thank you. Thank you. Thank you so much.
Thank you, sir. Bye, sir.
अरे आप क्यों नहीं आए?